Sion Hospital, and a national coordinator for Foxy Medical Disorder Pregnancy Committee. He was a vice president of MOGS he is a vice president of MOGS from 2020 to 2021, scientific secretary of AFD from 2020 to 2021, member managing committee IAGE, joint treasurer elect for Foxy for 2021 to 23, chair and convener of Foxy Cell Violence Against Doctors, dean and chief content director, Highguard E3 courses, chairperson of Foxy Oncology and TT committee, course coordinator of 11 batches of MUHS recognized. We have got a dynamic chairperson, Dr. Niranjan Chavan.
Thank you, madam.
Thank you, sir. I now hand over the mic to Dr. Anshu for the invitation of the next two chairpersons.
Hi. Now I would like to call our next chairperson, Dr. Asha Bakshi ma'am, to please chair the sessions 1. And ma'am is the director of Disha Fertility and the Surgical Center, Indore, and the leading consultant at Fertility Center in association with Motherhood Hospital, Indore. Ma'am is the joint secretary of ISAR 2021, and with I think a maximum number of votes, he won this election, and the founder, chairperson, MP IG, MP ISAR, and chairperson of Foxy Infertility Committee 2017-19, and the past president of IOGS. To her credit go to the first ICSI, TESA, ICSI, and the micro test and the ICSI babies of MP, and the recipient of Dr. Kumud Tamaskar Award Foxy 2008-2009, and the best paper in Foxy Journal in 2011-2012. Runs Foxy recognized infertility and the endoscopy courses and the certificate courses of the ICOG in infertility and the endoscopy. Has organized many conferences like Star Endogyne 2019 and joint organizing secretary of the IFAS 2016. Ma'am is organizing chairperson of AICOG 21, which is to be held in Indore very soon, and the contesting and already a winner of president of the West Zone Foxy. Ma'am, please chair the session.
Thank you very much for the kind introduction.
Next slide, please. So our next chairperson is our own founder member of Noida Obs and Gynae Society, Dr. Uma Sharma ma'am. Ma'am is a director and head of the department of Kailash Group of Hospital since last 30 years, and the special interest is in high-risk obstetrics. Ma'am is the chairperson of Kailash Group of Hospital and the HOD as well. Please, ma'am, please raise the session 1. Now, I would like to request our all chairpersons to please start the first session of rapid fire round. Thank you.
Thank you, Dr. Rakhi Singh and Anshu Raina, to invite me. And I also am thankful to co-chair with Dr. Asha Bakshi, Madam, and Uma Sharma. So we have the first now speaker, Dr. Rohan Palshetkar. We all know him as Dr. Palshetkar's, what I would say higher. So, but I have to do the formality of introducing him. He is a member of Mumbai Obstetric Gynecological Society Managing Committee and the second joint secretary of MOGS, that is the All Maharashtra Obstetric Gynecological Society. Presently, he is also the associate professor at Dr. D.Y. Patil School of Medicine in Navi Mumbai, and he is the joint treasurer of Maharashtra chapter of IAGE, working with me in this organization and also in MOGS and in Foxy. We find him to be quite vibrant, hardworking, and has got many awards. One of them is the AOFOG Young Gynecologist Award, and the other awards are related to ISAR and Foxy Yuva Orator. He is also the recipient of MOGS Best Youth Council Member Award 2016 and 2019. 19. And how I cannot forget that he is also the youngest member to get the recipient of the Foxy Corion and the Foxy Shanti Yadav Award for Infertility. With this introduction, I would request Dr. Rohan Palshetkar to start his presentation. Thank you.
Thank you so much, sir, for your kind words. And it's always been an honor to work with you in MOGS as well. At the outset, I would first like to thank Dr. Sujata Bhatt ma'am, Dr. Raki Singh and Dr. Anshu Raina for inviting me to deliver this rapid fire round on fertility after 40. So as we all know, the fertility rate of any woman decreases as the age increases. And this chart is being seen by us for plenty of years. As the age increases, your fertility is increasing, your quality of oocytes is also decreasing, and your poor quality oocytes end up increasing. So what we have seen that in patients that are above the age of 40, the biggest problem is poor ovarian reserve. And the first thing that we end up jumping to when they come for any infertility treatment is that you think we have to think of donor eggs, or we have to think of taking eggs from another woman. So at that point, we start wondering, is that the way to go forward, or do we want to give them the ability to forward their own genes into their child? So generally, when we're looking at women above the age of 40, we think of poor ovarian reserve. And as you can see, we generally are following this Poseidon group criteria. I'm not going to go through all of them, but as you can see, most of these women fall under either Poseidon group 4 or Poseidon group 2. So when we're looking at the management of infertility in these patients, you can see that our main criteria is to try and get one euploid embryo. As we know that embryos are always the chances of Down syndrome and all the other syndromes increases exponentially with age. Now, if there was a study published in 2018 which says that above the age of 40, you need more than 10 oocytes or 20 oocytes to try and get at least one euploid embryo. So when we are trying to maximize the ovarian response, now what are the things that end up coming in our way? One, we've noticed that there's high dose gonadotropins that are usually required. And it's also been seen and proven by the Cochrane reviews that all the types of gonadotropins are equally good. Now we know that these are the different protocols which can be implemented such as the antagonist, mild stimulation, long agonist, and ultra short. Now what we have seen is that the GnRH agonist, as per this study, I'm just going to stop sharing for 1 second, sorry. Yeah. So as this per the study in 2019, it said that there was the agonist protocol is much more effective than antagonist in young POR patients. But the recent studies have shown that there's been really no difference in the treatment. Now, what do? I generally still prefer using the antagonist protocol in patients above the age of 40 or a mild stimulation protocol, because that seems to give us better quality oocytes. Then dual stimulation is something that we started doing recently, where we stimulate the patient twice in one cycle itself. Then another thing about embryo pooling, which has been coming into trends right now, where we try and gather as many embryos as we can first and then start transferring them inside. And now this dual trigger is something that we have started using in patients with poor oocyte reserve, so that it's been giving us better quality embryos as well as more number of oocytes. So this study, which was published just now in July 2020, showed that the dual trigger gave us better number of oocytes, better fertilized oocytes, and better day 3 embryos and top quality blastocysts. And it also resulted in significantly higher clinical pregnancy rates and live birth rates in the dual trigger group. Now, another study which was published in June 2020 was a different protocol, where they said give letrozole daily with the gonadotropins, because this has seemed to improve the ovarian response and IVF outcomes in these patients with the poor responders. Now, patients, older patients, what do we do? IVF or ICSI? So there's been a meta-analysis which has been published in Feb 2020, which said that in about 8,800 oocytes were injected with a mean age of more than 38. They saw that IVF or ICSI had the same results. So continue what you're doing, because either way, you're getting the right results for your patients. So be comfortable with what you're doing in your lab, because that's what's eventually giving you your good rates. Now, adjuvants, this has been always a sign of a bone of contention among all the infertility specialists, as well as all the gynecologists treating these patients. But there has been a lot of improvement in the use of adjuvants and how to use them. Now, DHEA and testosterone, what do we understand by them? One, the mechanism is uncertain, but it's been speculated that it increases the IGF-1 concentration, which improves the response to gonadotropins. It's also improving the steroidogenesis, which is a precursor for estradiol and testosterone. It also creates a condition of PCOS-like characteristics, increasing the LH. It acts as a pre-hormone for follicular fluid testosterone. It reduces age-related aneuploidy by affecting the meiotic chromosome segregation, and it also increases the number of small antral follicles and AMH levels. So DHEA, we all know, is supposed to be started at least 3 months prior to the IVF cycle and until the end of the ovarian stimulation, and you give about 75 mg daily. And I think most of us end up using a combination with DHEA and not just DHEA alone. This Cochrane review where on the role of DHEA included 10 RCTs, which involved 2 RCTs including normal responders and 7 RCTs in poor responders. And it showed that with a DHEA pre-treatment, there was an improved live birth rate. Now, testosterone gel or patches which have been coming, you generally give a pre-treatment of about 2 to 4 weeks in the previous cycle. A meta-analysis published in 2019 suggests that it may increase live birth rate, clinical pregnancy rate, and also give us more number of oocytes and embryos in such patients. However, now currently there's a T-transport trial which is going on, which is going to give us very good quality evidence about the role of transdermal testosterone in ART. So once this trial comes out, we'll actually know how good this testosterone is actually in our day-to-day practice. Now, growth hormone is another thing which has been being used recently for poor ovarian responders or women above the age of 40. Basically, it acts on the receptors and is responsible for the preantral follicular growth and differentiation. It also is stimulating the small antral follicle counts to the gonadotropin independent stages as well as the maturation of oocytes. You generally give a dose of somewhere between 4 to 12 international units per day, starting from day 2 till the day of trigger. A recent meta-analysis has shown that there is a statistically significant higher clinical pregnancy rate with the addition of GH. In 2018, there was another paper which included the Bologna criteria poor responders, and it showed that there was no statistical significance between the two groups. However, in 2020, a meta-analysis and systemic RCT where it included 1,200 patients showed that it may improve reproductive outcomes in poor responders, but there was no increase in live birth rate. So I think this is still a bone of contention where I think it can still be used in specific conditions where you need to properly select the patient. Now, melatonin is also another adjuvant which has been being used quite often, and it has shown good results in my own personal practice as well. The mechanism basically is it acts as a scavenger for any oxidative stress created, and basically what this does is it reduces the stress on the oocytes, improving the quality. There's been a meta-analysis and systematic review of 10 RCTs which improves the clinical pregnancy rate but not the live birth rate, and it's also showed to increase the number of M2 oocytes as well as the good quality embryos as well. Now, this was another study which I saw was about estradiol pre-treatment. So what it says is give 4 mg from day 20 of the previous cycle to the first day of the menstrual cycle. Its advantages are that there's a milder FSH suppression, there's a lesser reduction in overall antral follicles, it coordinates the follicular growth so you don't have one follicle escaping from the rest of it, and it can be used when OCs are contraindicated. The next thing, what we need to discuss is ovarian rejuvenation. Because our job in order to make sure that these older patients are able to pass on the genetic material is to rejuvenate their ovaries, get good quality oocytes, and then make the embryos which can be used for transfer. Now, intra-ovarian PRP, this study published in June 2020, where they had 311 women with premature ovarian insufficiency. I thought this applied a lot to the older patients, because if it's working in poor ovarian insufficiency, it will definitely have a good effect on women with poor ovarian reserve as well, because they would improve their AMH and oocytes. So it shows that there is a 23% live birth rate per transfer, and even 23 women have conceived spontaneously. Therefore, but they did give a very in the conclusion, they said that it has to be explained to the patient that it is an experimental treatment. We've also started using this PRP transvaginally in patients for low AMH, and currently we have one patient that is pregnant and about to deliver. In fact, Dr. Meenu Handa and Sunita Arora are doing this even in Delhi itself. Stem cell therapy, bone marrow derived stem cells, they're containing several types of stem cells. So I'm not going to get into too much detail because I'm really worried I'm running out of time. So this Pellicer et al. In 2018, they did 17 women with poor ovarian reserve. They injected bone marrow stem cells, and they saw that in 81% of the patient, there was an increase in AMH and AFC within 2 weeks time itself. Now this Pellicer and his team again published another article in July 2020, where they injected stem cells with into mice with chemotherapy-induced ovarian damage, and into immunodeficient mice where patients of poor human cortex, the ovary from the poor ovarian responders was xenografted into these mice, and they're seeing the response. All our treatments have eventually first started with animal studies and then moved into human studies. So probably this is a very intriguing thing where we're going to probably see if these stem cells have a very good effect on ovarian rejuvenation. Now then there was this ovarian in vitro activation which was published in 2016. What they did was they harvested laparoscopically the ovaries. They did cortical sectioning, and they incubated with a P10 and a PIK3 enhancer. Then what they did was they regrafted these ovaries, which allowed the retrieval of oocytes, and after IVF and embryo transfer, normal pregnancies were obtained. So this is another thing which can be possibly used to this. Now, all those who attended this worldwide conference, which was held in April of 2020, Johnny Zhang spoke about spindle transfer. So we're talking about poor quality oocytes. We're talking about, he spoke about this, where what you do is you take the spindle from the older patient's oocyte and you transfer it into a donor oocyte, where the spindle is passed into the oocyte. So the genetic material of the mother is passed with a better quality oocyte. And then you do the ICSI, and then you transfer the embryo, ensuring that you have a genetic of the original biological mother passing into the baby. Next, Nuno Costa Borges in 2019 decided to do a pro-nuclear transfer instead of a spindle transfer. So what he did was, using a donor oocyte and the maternal oocyte, he created two embryos. What he did was he took the pro-nuclear from the biological embryo and transferred it into the embryo with the donor oocyte. So you still have the good quality cytoplasm and mitochondria, but the genetic material of the parents from the nucleus was still passed on to the oocyte. And these are some new things which are coming into the foray, which is going to possibly eliminate the requirement of not being able to pass on the genetic material of the parents to the child. Now this technology which has come in, we all know about spindle check, but now there's this spindle check which has been used as a marker for blastocyst ploidy. As you realize, I mentioned in the study before, where more number of oocytes are required for producing euploid embryos. So what this study did is, when you're getting the oocyte, you classify the spindle based on either whether it's a normal, as you can see in the images, dysmorphic, translucent, telophase, or not visible. What they saw was, they studied 2056 oocyte spindles, and they saw that the oocyte meiotic spindle and blastocyst formation had a very strong correlation. They saw that normal and dysformic had the best results. They did 515 blastocyst biopsies, and they saw that those with the A and B had most likely euploid embryos, while C and D and E had lesser chances of a euploid embryo. Next is something that's embryoscope or basically time lapse. We've had time lapse on our mobile phones in what we're using. And this is something similar which we're using in the lab as well to assess which is the best embryo to be transferred. So the embryos are classified as A, B, C, and D. And you can see that the live birth rate in A is 52.5, 39.2, 31.4, and 13.2, ranking variously. Next is PGT for poor responders. Published in 2017, they studied 1,800 euploid blastocyst transfers. In poor ovarian reserve, they saw that the clinical pregnancy rate was almost 57%, miscarriage rates were still 18%, and they saw that the pregnancy rates in POR patients where PGT was used was high. So they suggested that PGT should be considered for improving pregnancy, and PGT also suggests a decreased effect of advancing age on pregnancy and miscarriage rates for women over 40. NICS basically is the non-invasive chromosomal screening, which is somewhat like our NIPT, which we're doing currently for all our pregnant mothers. Over here, what it says is the blastocyst, which is there, releases genetic material into the culture media that is around the embryo. So what it does is we are testing the culture media. So it's making it non-invasive. It's easier because there's no biopsy. So the skill that's required is slightly less. There's no sample loss because you're not really injuring the embryo. It has a very high sensitivity. It's more flexible because it can be used on the NGS platforms. And now AI is also there to consider the entire thing. We've done about a few patients which ranging from more than 2 failures till 7 failures for NIS. Seen so far 15 pregnancies, and there have been only 2 miscarriages till date. So to conclude my talk, I want to say that adjuvants do play a very important role in improving results in patients above 40, especially with POR. Consider dual trigger in patients prior to oocyte retrieval. IVF or ICSI, go ahead and do what you're already doing. They have the same results. Important to offer everything available to the patient. I know cost does become a factor, but it's the patient's choice to choose. And the future looks very promising, where the need of a oocyte donor could be eliminated completely. Thank you so much. Thank you, sir.
Thank you so much, Rohan. It was a wonderful presentation, and you have gone through the whole journey of fertility after 40. It was an amazing lecture, a lot of insights, embryoscope, and how you go about to treat them. So I think we will take the questions at the end of the session. Now I invite Doctor.
The question answers would be taken in that question answer chat box.
Yes.
Only. They would be answered over there. We are not taking the next question answers.
Yes.
Can we have the next CV of the next speaker?
Start. Dr. Dr. Anshu, don't worry. I'm Dr. Tarakeshwari from Fernandez Hospital. So I would like to start my talk over the next 10 minutes on use of low molecular weight heparin in obstetrics. I respected chairperson and the team members of Energy Society. I thank you very much, and Dr. Sujata in particular, for giving me this opportunity to present my talk over the next 10 minutes. I'll be dealing briefly the common use of the low molecular weight heparins, and their safety, efficacy, and the treatment regimes based on the case scenarios. In obstetrics, till now, we were using unfractionated heparin, but with the advent of low molecular weight heparin and the widespread availability from 1990s, now low molecular weight heparin has become the choice of anticoagulant in our obstetric practice. The 2 most commonly used and also studied were inaxaparin, which is known as a Clexane, and dalteparin, which is known as Fragmin. There are very few case reports on nordaparin and tinazaparin, but mostly we use inaxaparin and dalteparin sodium. To know about the safety and efficacy of low molecular weight heparin in pregnancy, we have this systematic review, and I thank Dr. Catherine for her lucid talk, which she had given to us earlier. And this is the review published in 2005. They studied the data till 2003, from 1990 to 2003, and published by I.A. Greer, who is a renowned obstetrician and gynecologist and a professor interested in her thrombosis in pregnancy, and Catherine Nelson, PSC, is the obstetric physician. Total 81 reports have been studied till 2003, out of which 2,930 patients were given low molecular weight heparin. These last 3 studies, they were excluded, and after excluding them, we have 64 case reports involving 2,777 pregnant mothers, and the indications were mainly acute thrombosis in pregnancy, followed by prevention for thromboprophylaxis, followed by antiphospholipid syndrome in pregnancy. So the commonly studied low molecular weight heparin was inaxaparin in 12,047 mothers and dalteparin in 789 mothers. So let's see what the complications were. If you look at the recurrence of thrombosis, essentially the recurrence is because of underdosing the mother, not using appropriate dose. The recurrent thrombosis is 1.3%, and bleeding tendencies in the antenatal period and postpartum hemorrhage while the woman comes without stopping the drug, and also the wound hematomas altogether is less than 2%. And allergy is the most important thing which these mothers can complain of. Only remedy is you can change over to another brand. So we have 2 mothers who were very allergic to inaxaparin, and they were doing fine with dalteparin. Coming to thrombocytopenia, all of us while using unfractionated heparin, we used to be very scared of heparin-induced thrombocytopenia. But with low molecular weight heparins, there may be a decrease in the platelet count, but 0 incidence of thrombocytopenia. And also the fear of osteoporosis, there were only 3 reported cases, and 1 because of dalteparin and 3 because of tenazaparin. So the incidence of thrombocytopenia and osteoporosis is nil with the use of low molecular weight heparin. Yes, there may be minor bleeds and allergy to the drug. When you compare the low molecular weight heparin usage in 1999 and then 2000 and 2005, the studies 1, 2, and 3, the third is the systematic analysis which shows that the recurrent VTE is 1.3, same, allergic reactions is 1.8, major hemorrhages is 1.9, but the thrombocytopenia, the HIT and osteoporosis are almost negligible. So it is now, the safety is well established, and pregnancy is the only condition in medicine where heparin is used for a longer time. Coming to the indications of use of low molecular weight heparin in obstetrics, yes, we go through these case scenarios. The first will be the acute DVT in pregnancy, the venous thromboembolism in pregnancy. Let's look at this lady, Mrs. L, 31-year-old, married for 6 years. Her weight is 50 kg. I have particularly put a weight because always we calculate heparin dosage as a weight with the weight of the mother. Her BMI comes as 24. She's a known hypothyroid, and this is an IVF conception. She has a viable pregnancy at 8 weeks, and she came to our center with history of left leg pain and swelling of a week duration. Ultrasound of the lower limb confirmed acute deep venous thrombosis involving the superficial femoral vein, popliteal, and proximal posterior tibial vein. 2D echo was normal. Appler workup in this early pregnancy was negative. Her hemoglobin and platelets were fine, and serum homocysteine levels we were doing at the time was lower side. So what do we do? Yes, we start heparin while waiting for confirmation. So we should have a high index of suspicion and start low molecular weight heparin, and the dosage should always be on the high end. The pregnancy dosage, if you take inaxaparin, it will be 1 milligram per kg body weight. This particular lady was started on fragment dalteparin, but even this also the higher dose is 5,000 units 12th hourly, and she has the stockings also, and rest of the pregnancy period was smooth. The only thing she had was low papier, for which we started aspirin. I want to remind everyone that aspirin is not a part of thromboprophylaxis. Only when indicated with antiphospholipid syndrome or when there is a low papier, when we do the 12 weeks first trimester's fetal health check, then we add low dose aspirin. Anyway, now we are giving 150 milligram of aspirin as per the ASPRI trial. She needed the whole of the antenatal period, the prophylactic dalteparin was continued. Only monitoring was by hemogram every trimester to look at just a platelet count. As we all know, there is never a heparin-induced thrombocytopenia. It can be a decreased count, but it always above 1 lakh only. So we have excellent guidelines to guide us with the dose requirement for acute DVT, and this is the RCOG Green Top Guideline 2015, which was reviewed in 2019. Until 2021, this holds good. So one we have to remember is it's always the weight-based dose for low molecular weight heparin. Either you can take a booking weight or you can take a early pregnancy weight. There is no problem. So if this particular lady is on dalteparin, and we have very clearly up to 50 kg, the usage is 5,000 units twice daily is what is recommended and which was started. She was planned for an induction of labor at 38 weeks. All the women on low molecular weight heparin, it is always better to do the planned delivery. So when we start low molecular weight heparin, 3 things we have to remember: doing the basic investigations, apart from CBC, the LFT, the creatinine, blood urea, and educating the mother for self-injection of the heparin. So we have to tell her 2 centimeters away from the umbilicus, just to pinch the skin along with the fat so that it will not touching the muscle, and to inject herself daily, and also keeping an ice or applying ice pack before and after taking reduces the bruise and pain. And third thing is disposal of the injections. So we have to educate the lady why we are giving, how long she should take, how she should self-inject. And the best technique of self-injection is we should demonstrate the day to her so that she and her husband, whoever has to give, sometimes a woman gets scared, the husband can help her. So we demonstrate how to take, and also the safe disposal of the injections. And the last is documentation of the initiation of heparin, the management plan.
Good morning.
Good morning. Good morning.
So we have to document the management plan while on heparin. So remember this mnemonic: bed, basic investigations, education, documentation of the plan. So this lady is planned for induction of labor at 38 weeks. We discontinue the low molecular weight heparin 24 hours prior to induction. And during the monitoring after admission, remember to start the early warning chart. So she had an assisted vaginal birth after 12 hours, and good GAR score, a girl baby of 2.8 kg. And postpartum, drop the dose to 1.5 mg if it is inaxaparin, or it is 5,000 units dalteparin per day. Continue low molecular weight heparin for 6 weeks. Majority of the women, when we say the switch to warfarin after 5 days post-delivery, some would like to breastfeed while on warfarin, some would not like to. But some would like to take for LMWH for 6 weeks. And after stopping LMW for 6 weeks, give a gap of 3 months, but do thrombophilia screening prior to next pregnancy. Remember, this lady, risk factor is IVF only, bed rest, and then immobilization, developing DVT, and we need to screen her for thrombophilia prior to next pregnancy. And if the spontaneous conception DVT, concept 2 issues have to be discussed. So we finished the first case scenario. Now the second indication is prevention of thrombosis, and for arterial as well as venous thrombosis, so thromboprophylaxis. So we need to know who are the mothers who require thromboprophylaxis, and when do we start, and how much we give, and how long we should give. Once again, we have this excellent RCOG guideline to guide us to look at the risk factors. All of us obstetricians have to look at the risk assessment at booking and every trimester, and also every hospitalization. Look at the risk factors, have a risk score, and start low molecular weight heparin, even if it is for a brief period. So we have these guidelines, and it is freely downloadable. I'm not going to talk because limited time. So we have to follow and start the low molecular weight heparin. The commonest indications we have is hyperemesis, mothers getting admitted for a brief time. We should cover with heparin during the hospitalization, and also ovarian hyperstimulation syndrome. These are the 2 most common we come across in our practice. Now, what are the critical time points for risk assessment and prophylaxis? There is an excellent venous thromboembolism task force recommendations. It comes from the California Medical School. It is California Quality of Care and Clinical Maternity Settings. So CMQCC, it is freely available. They give us nice 4 critical points for risk assessment. And they amalgamated, this California task force, amalgamated the American College Guidelines, Royal College Guidelines, and American Chest Physician Guidelines. So these 4 critical points are the first prenatal visit when she comes for the booking in your outpatient clinic, and next time when she gets hospitalized in the for antepartum problems. Third is at the birth hospitalization, including cesarean section or a vaginal birth. And fourth is the post-discharge, extended duration or limited duration of anticoagulation. So remember to do risk assessment and also the points for risk assessment and also the dosage, what we have to give. So we know that this is a prophylaxis what we are giving. It's not therapeutic. So prophylaxis always, we start for the woman less than 50 kg is 20 milligram of enoxaparin. And if it is a dalteparin, 2,500 units, it's a single daily dose. As the weight of the woman increases, the dose requirement increases. So we finished who? We finished when? How long? If it is a vaginal birth, we give thromboprophylaxis as per the risk factors. You have an IVF, you have an induction and assisted vaginal delivery. So they all 3 are risk factors. So you can give for 3 to 5 days post-delivery. If it is a spontaneous, you can give for 3 days. And if it is a cesarean section, we should give for a minimum of 7 days. And 6 weeks post-delivery, if she falls into the high-risk category, or you have somebody with antiphospholipid syndrome, established diagnosis, you have given antenatal low molecular weight heparin and aspirin, she requires a 6 weeks post-delivery low molecular weight heparin. So remember whom to give, when to give, and how long to give, and how much to give. The next third common scenario which we come across is mechanical heart valves. So the chronic rheumatic heart disease lady with a mitral valve replacement done in 2006, she is on acetron 4 milligrams per day and before conception, and she was maintaining her PTINR as well as she's on infective endocarditis prophylaxis once in 3 weeks. She's booked at 5 weeks. So remember, if you don't have a baseline echo 6 months prior to conception, you do the booking echo for the mother and to look at the normal prostatic valve function. That is extremely important. If somebody is non-compliant and if you have a thrombus, then it's a life-threatening situation where we cannot manage in a setting and go to a setting where there is a cardiologist. So this is a one very excellent anticoagulation regimens for the women with mitral valve, mechanical heart valves. It clearly tells us all the regimes, right from warfarin till 35 weeks, and then heparin till delivery, unfractionated heparin till week 13, then warfarin until week 35, and then heparin. This is a third scenario where low molecular weight heparin throughout the pregnancy and unfractionated heparin throughout the pregnancy. This excellent article gives us the maternal complications and the fetal complications. Look at this low molecular weight heparin. The maternal thrombotic event is 10.6%. This is the only condition when we are giving low molecular weight heparin throughout pregnancy and you can't monitor anti-tenia levels. It's better not to use low molecular weight heparin for this mother with a mechanical heart valve. It's always the second regime most of us we use in our scenarios. Unfractionated heparin till week 13 to reduce the warfarin embryopathy, then warfarin until week 35, and then heparin until delivery. So this woman received this regime, but remember, it's always a shared decision after counseling with the patient when we give this regime. So she had a gestational diabetes at 25 weeks. She was on diet, and we repeat echo at 34 weeks. It showed only mild TR and normal functioning mechanical valve. And these mothers also, we bring them for induction, planned induction, because if they get into labor, it's very, very risky. The risk of maternal hemorrhage, as well as if she's on warfarin and fetal hemorrhage, is very high. So we switched off to unfractionated heparin, 7,500 units twice daily to monitor APTT more than 2 times the control. So remember to document when you admit the mother, particularly when you are in a team, for the others to know and follow these So we should remember if she is either unfractionated or low molecular. If low molecular, more than 36 hours should be the last dose. And there are regimes where we can start IV unfractionated heparin 24 hours planned to the planned delivery with a bolus loading dose. Check APTT after 6 hours, and we always aim for 2. And then induction of labor, stop infusion once labor is established. And if it is an elective cesarean section, we have to do stop 4 hours before anesthesia. That means a senior consultant and a senior anesthetist should be reviewing her carefully, monitoring the heparin, when to stop and when to do the delivery. So after vaginal delivery, start IV heparin after 4 to 6 hours, or after cesarean section after 12 hours, we start IV heparin and then switch on to low molecular weight heparin. So this lady, we discontinued heparin 6 hours before delivery. When she was about 3 to 4 centimeters, she delivered after 6 hours. We induced her with prostaglandins, ARM and oxytocin. She had an assisted vaginal birth. So that is about mechanical heart valves. Now the fourth and the foremost thing which we all obstetricians are practicing is for inherited thrombophilias. Antiphospholipid syndrome, all of you are well familiar with, and the only point I want to say is the effect of heparin, the protective role is due to the increased maternal circulatory PLGF levels and the decreased SFT1 PLGF ratio, and this is explaining the protective role in preventing placenta-mediated complications. A lot of research is going on to the histopathological changes of placenta with thrombophilias. Now, there are certain special considerations. Number one, the commonest, whether I should monitor the low molecular weight heparin in pregnancy by doing anti-10A levels. No, because most of our indications are prophylactic and no need to monitor anti-10A levels as advised by the Royal College as well as the International Society of Thrombosis and Hemostasis. It has got a scientific committee where there is still no standardization of anti-10A tests and also no availability at all places. So the prophylactic dose is what we are using, no need to monitor anti-10A levels. Special considerations, we should have this chart in our theaters and the labor ward when we use regional analgesia. Always discuss the implications of the low molecular weight heparin. Treatment with the woman, as I said, delay 12 hours after the previous prophylactic dose for regional analgesia and delay 24 hours after the therapeutic dose. And catheter, low molecular weight heparin, only 4 hours after catheter removal to be given and 12 hours before the removal of the cannula. And if you look at an elective cesarean section, the thromboprophylactic dose of low molecular weight heparin a day prior to. Most of the mothers these days, we have obesity, morbid, 40 BMIs as the problem which we have. We give a dose prior to section. On the day we don't give, on the day of delivery, C-section that morning, all these mothers take heparin early mornings. We tell them take at 8 o'clock. If you take in the evenings and if you have untoward bleeding in the night, you'll get panicky. So one of the things when we initiate treatment is take 8 a.m. low molecular weight heparin or even unfractionated 8 a.m., 8 p.m. So coming to C-section, the thromboprophylactic dose by 3 hours post-op, and that means more than 4 hours after catheter removal, and recommence treatment dose that evening. What about the various indications which are being used all over the country? The literature search very clearly says there is no treatment effective for women with recurrent pregnancy loss and no thrombophilia. When you don't have an established thrombophilia, there is no indication to give low molecular weight heparin. We have enough studies, good randomized controlled trials too. And prevention of preeclampsia, particularly the late onset. Early onset preeclampsia before 34 weeks, and you investigate her in the interval period and establish antiphospholipid syndrome, then give heparin. Otherwise, no. And to prevent SGA births, it should not be used to prevent complications in the women with previous SGA birth. And to prevent placental abruption, enough studies we have, and it's better not to give low molecular weight heparin for the women who had previous pregnancy losses due to abruption. Hence, I would like to conclude saying that low molecular weight heparin is the anticoagulant of choice now in pregnant mothers to prevent thrombosis and also to treat acute thrombosis. Weight-based dose is what is being advised. Either a booking or a recent weight can be used. Anti-tele levels need not be monitored, and platelet count is the one which we need to look at. Thank you for giving me this opportunity, and thank you for patient hearing.
Thank you, ma'am.
Right.
I would like to call Dr. Asha, ma'am, to give the.
Thank you very much, Dr. Takeshwari, for such a good lucid presentation, and especially how obstetricians are getting bold in using LMWH. And you have rightly shown the indications as well as contraindications, the doses. And one very good point that you suggested was start if it is a high risk case, and if you want to really start, then start the LMWH 1 day prior to cesarean. So very good take home messages, and thanks a lot for this celebration.
Thank you. Thank you.
Thank you. Can we have this off, sir, the PPT for a second? And Dr. Jayanta. And I would like to call upon Dr. Niranjan again for the concluding remarks, and he's also standing for the, after winning the election of Foxy, and then he's standing for the IAG. I would like to call Dr. Niranjan.
Thank you, Dr. Rakhi. Thank you, Anshu. Wonderful annual Noida conference is going on, and there are so many delegates. Actually, COVID has changed our life, and we are disseminating knowledge more and reading more, and really what we used to go through our conferences, but it has been changed. So I would like to thank the Noida Society to invite me today here, and I would like to appeal that as a teacher of more than 28 years in Maharashtra MUHS, I have contributed a lot in the field of endoscopy and infertility, trained more than 500 gynecologists for the certificate course and the fellowship course. Even during COVID times, apart from delivering more than 350 plus deliveries, positive cases, which you all have done, I have conducted and been a part of more than 150 webinars where I got the opportunity to go to various places and meet them. For example, I have met Dr. Meera Agnihotri Madam in Kanpur, Usha Sharma Madam in Meerut, and Sunita Tandulwadkar Madam in Pune. And obviously there are many, I can't take names, but it was really heartening. If we cannot meet in presence, at least we can meet virtually. And there we also have Dr. Rishikesh Pai, Archana Verma, and Dr. Jaideep Thang, who have been a part of this wonderful conference. I want to also reiterate that I am the first Indian to be on the editorial board of a European journal in gynae oncology, and that was in 2016. Edited more IAGE newsletters and DVDs. So with this, vision is not enough. We need to also stare and just not stare at the steps, but climb it, and experience counts. Published more than 50 plus scientific papers. As a head of the unit, I have done a lot of contribution, and I'm sure you will always support me the way you have supported me in Foxy for my elections in chairperson and the joint treasurer. And I request you to please do vote, because voting is very important. You have to vote if you are an IAG member. The voting lines will be started on 1st of October till 15. Please exercise your right and do the right choice. Thank you so much for giving me an opportunity to speak and talk to you. Thank you so much.
Thank you, Dr. Niranjan. Moving on ahead, for the next session, I would like to hand over it to Dr. Anshu. Can we have the slides of this chairperson?
Thank you, Dr. Rakhi. And now I would like to start our second session, which is a keynote. And for this, I would like to invite our chairperson. And my first chairperson is Dr. Madhuri Patel, ma'am. Ma'am is a Deputy Secretary General Foxy, is a Joint Secretary Foxy 2009, former committee member Peterborough, Joint Associate Editor Journal of Obstetrics and Gynecology of India, Honorary Clinical Associate at H. Wardia Hospital, Parel, Mumbai, Honorable Consultant Police Hospital, Mumbai, visiting consultant at St. Elizabeth and the Masina Hospital, Mumbai. Ma'am is an ex-professor and head of the Department of ESIC PGI MSR, MGMH, Mumbai, and awarded with the MOGS Mrs. Shalja and Mrs. Narayan Pandit Award for the year 2019-2020, and delivered a guest lecture at national and international levels and the orations. More than 50 publications in the national and the international journal book chapter, and the associate editor of Foxy award-winning book, Gynecological Cancer 2007. Ma'am, please welcome and chair the session. Now, I would like to invite our second chairperson, Dr. Sunita Tendulkarkar, ma'am. Ma'am is organizational post held Indian Association of Gynecological Endoscopy President and Maharashtra State Chapter ISAR, and the Chairperson, Founder, Honorary Secretary. Indian Society of Assisted Reproductive ISAR, Second Vice President, and the Federation of Obstetrics and Gynecology of India Vice President West John between 2015 to 2017. International Society of Gynecological Endoscopy elected board member in 2013-17. Journal of Human Reproductive Sciences reviewer and the advisor, and the notable award of Pride of Foxy 2020, Bharat Gaurav Purushkar in 2019, ISAR Best Personality of the Year 2018-19, and the Best Medical Practice 2016 Europe Medical Association, Best Citizen of India Award in 2016, Glory of Indian Award 2016, Best Gynecologist of Maharashtra 2016, Punya Shloka Abhyabai Holkar Award in 2015, and there is a list of award I can't read even.
Please,
So please, ma'am.
let us not waste our academic time. In India, everyone knows everything. I see here Meera ji.
Congratulations, ma'am. Please.
My sadar pranam to all of you, and I humbly request, don't waste time in introducing chairperson. We should go to the speaker.
Now I would like to request Dr. Rakhi to please introduce our next chairperson.
We've got Dr. Archana Verma, who is the Vice President-elect of Foxy from North Zone. And she was holding a position of Public Awareness Committee, where we've seen her doing lot amount of work in public awareness. And she has been awarded the Best Presidential Committee Award also for that. And she's a recipient of India Book of Records, which she's been doing at loud and at large, for the Women's Health Award for DGF, and Organizing Secretary of North Zone Yuva Foxy 2016. We've got dynamic Dr. Archana Verma, the past president of Ghaziabad Society, also to chair the session of keynote by Dr. Rishikesh Pai. And Rishikesh Pai, sir, we know he knows the best of taking out how he can do it with all the hitches and glitches also of the net, the media, but he has the ways out for each and everything. Presenting to you, Dr. Rishikesh Pai. Ma'am, can you please?
Yeah, thank you, Dr. Rakhi, Dr. Anshu, for your kind introduction. Good morning to all of you, all my seniors and juniors. We all are aware that the endometriosis is a benign disease, gynecological disease, which affects 6 to 10% of all the women in the reproductive age group. Majority of them are asymptomatic, but majority of them may come with pelvic pain, infertility, and adnexal mass. So today we have Dr. Rishikesh Pai to enlighten us about the multidisciplinary approach on endometriosis. I would like to introduce Dr. Rishikesh Pai. It is my honor to introduce him. He is a President-elect Foxy 2020 to 23. He is awarded with Esteemed Fellowship at Endom of the ICOG UK. He is a past Secretary General, Senior Vice President, Deputy Secretary General, Treasurer of the Foxy, past President of the ISAR, IAGA and MOGS. He is awarded with 30 plus awards, including prestigious lifetime awards for the outstanding research in reproduction health by ISSRA, Foxy, and the Indian Medical Association, other reputed organizations. He has delivered many orations and invited faculty across the world. He is the editor of over 16 plus books and written more than 50 chapters. He's the editor of Indian edition of the British Journal of OBGY. He has numerous research publications to his credit. Apart from this, he's a very good orator. I had an opportunity to work with him as a treasurer when he was Secretary General. And you believe me, we had a very good, smooth functioning. I learned many things from him, and he always appreciated in person and in public about my good work. Now I'm going to have another opportunity to work with Dr. Rishikesh Pai when he takes over as a president Foxy, and I'll be Secretary General. And I think Rishikesh, we will do very good work during our tenure. And with this, I would like to also mention, above all, he's a good human being and very kind at heart. With this, I invite Dr. Rishikesh Pai to give his talk on a multidisciplinary approach to endometriosis. Dr. Rishikesh Pai, please.
Thank you very much. I'm really obliged to all of you. And first and foremost, I must pay my respect to two, I would call them the presidents of Foxy only. I always say that there are so many people who are so good but who cannot become president, but they are actually president. One is Dr. Usha Sharma and Dr. Meera Agnihotri. They are like presidents of Foxy, and there's no question about it that they have to be respected whenever they are around. Dr. Rakhi Singh, of course, our dynamic committee chair of the endocrinology, Dr. Sujata Bhatt, our president, Dr. Anshu Raina, our secretary, Dr. Chitra and Dr. Madhu, who have been founder of this society. And there are a lot of my friends, the chairs that are Archana Verma, Sunita Tandulkarkar, and my favorite, Dr. Madhuri Patel, with whom I will hopefully have a nice, happy, inclusive year. All of you have to be there. See, Foxy, it's a thought. It is a movement. It is not an organization. So we are all a part of that thought process, and we should be very inclusive and take it to a next height. Then we have got our Niranjan Chavan. And I would also like to say at this stage that leadership is not ability alone. Like a skilled operator is not a leader. The part of leadership is being able to do skilled surgery. But this leadership has got different aspects. Together you become a leader, and that is very important to understand. And the second point, which as I'm evolving in my life, I've understood this, and that age gives you the maturity and the understanding. And this is the important fact that has to be underlined to our people, because barring India, all over the world, age has been given the topmost priority. Look at America. Most of the presidents they become president at 70. Look at the UK. I have seen everywhere the presidents and all they become, because the most important aspect is experience. Knowledge, so why you need to come here? You go to the internet, you will get more knowledge. So what is it that differentiates speakers? The differentiation is time. And time is a thing that always comes with patience. And this people have to understand. Our juniors there's a blurring in their mind. And this, one of the important things I feel that I should bring back to the society is stability. Stability of thought process. It has to be hierarchical development. Look at all the Western. There's tremendous hierarchy in the Western. Are they backward in their thought process when they think of hierarchy? No, they are not backward. They understand that all are same, but the differentiation is the time that is there. So anyway, I don't want to waste your time. This is my philosophy of life. And Aisha Bakshi is there. I'm very happy she'll be one of the doctor. Many others are there. R.T. Luthra, I can see there also. And Dr. Ashok has now joined. Another thing is the respect to professors like Ashok. Dr. Shanta Kumari has joined. So it's very important to understand that. And the hierarchy has to be brought back to our organization. So I will now share my screen. And it's a small lecture on endometriosis. You all know about it. I don't have to really go, but in a small way, short way, I'll tell you about it. So if you look at the causes of infertility in endometriosis, there are various aspects that contribute to it. Ovulatory dysfunction, immunological alterations, peritoneal factors, poor oocyte and embryo quality, interference with implantation, mechanical factors, interfere with coital function, and sperm inactivation. Basically, the pelvic cavity contains increased hyperactivated macrophages which produce cytokines, And this negative effect on follicles and oocytes creates a hostile environment for fertilization. In addition, endometriotic lesions also produce different cytokines such as interleukin-1 beta, IL-6, IL-8, and tumor necrosis factor alpha. And this can lead to implantation failure and early spontaneous abortion, even in IVF procedures. This is a study in 2018 done by ISIL in fertility sterility, where he showed endometrioma-related reduction in ovarian reserve. It is called ERROR. And he studied 80 patients, 40 with endometrioma, and he matched them with 40 age matched healthy controls. And then he did expectant management. And he studied the AMH and AFC over 6 months. And he found that there was a drop of nearly 26% in the endometrioma group of the AMH level. And he concluded that women with endometriosis experience a progressive decline in AMH levels as compared to healthy women. So this is very important, that it can eat up the ovary and it can decline the ovarian reserve. If you look at endometriosis, it is a common chronic disease. Although women may be asymptomatic, most women typically present with pelvic pain, dysmenorrhea, dyspareunia, infertility, or adnexal masses. Female age, duration of infertility, pelvic pain, and stage of endometriosis should be considered when formulating a management plan. So if you look at it, I have taken, because my job is of infertility, so I'm not interested in. So we have the adolescent endometriosis patients wanting to retain their fertility. So there is a reproductive age group now who is till 30, they don't want to get married. 30, 35 is the minimum time of getting married. So they want fertility, but they don't want a child immediately. So that's also a very important group in practice. Patients who are undergoing infertility treatment, which we can classify into stage 1, 2 and stage 3, 4, and patients who have recurrent disease. So this is how I have classified it. And if you look at the stage 1 and 2 endometriosis, laparoscopy for all policy may be there for many. So many people after 2-3 years, they say, even if there is a asymptomatic, they will put in a laparoscope. So I wanted to find out what is a Western position on laparoscopy. For example, in India, in private practice, we would not go for laparoscopy immediately because patients will say, what is this, doctor is too invasive. On the other hand, if you go to teaching hospitals in 2 years' time, they don't bother, they'll put in a laparoscope. So I wanted to know what would be a happy middle. So the ASRW practice committee guideline has said that it is most clearly indicated for those individuals with symptoms of dysmenorrhea, dyspareunia, or risk factors for peritoneal disease or an abnormal HSG or ultrasonography who do not require ART. Given individual circumstances, there may be a place for scopy for young women with a long duration of infertility, more than 3 years. So even there, they feel that if there's a person who comes with a long duration of infertility, you can put a scope in, because the diagnosis of stage 1 and 2 disease mainly is by laparoscopy. Suppose you diagnose it, what is the treatment? One is, of course, you can do expectant management, but most of the time, because it is a diagnostic on laparoscopy, you would do a surgical management. If you see a small spot of endometriosis, you will burn it. It is important to excise it as well for histopathological diagnosis, if at all you can, because histopathology confirms the diagnosis of endometriosis, and then you can subject them to controlled ovarian stimulation with IUI, and if all that fails in 5-6 months time or a year's time, you can go for IVF. So the treatment of stage 1-2 disease, as you can see, my approach would be young women with endometriosis. If they come to you, do AMH, offer them preservation of fertility if AMH is less than 1.5. If AMH is more than 1.5, you can give conservation. In older women wanting to preserve fertility with endometriosis, do AMH again, and if it is less than 1.5, offer them fertility preservation. If they are asymptomatic, you can treat it as unexplained, do tubal testing followed by controlled ovarian stimulation. But if you have a policy of putting a laparoscope in, even in an asymptomatic, unexplained infertility patient, then if you put in a laparoscope, treat it, do few more cycles of IUI following the treatment, and if that fails, you go for IVF. If there is a symptomatic stage 1-2 disease, then of course, she has got dyspareunia, dysmenorrhea, and she may have a stage 1 disease. You put in a scope and you diagnose it, then you treat it with laparoscopy followed by COS IUI for 6 months, and if fails, do IVF. So this would be the protocol for stage 1 and 2 disease. What about stage 3 and 4 endometriosis? So symptoms, clinical finding, 2D or 3D ultrasound. MRI, somehow I don't like to do in patients unless you have a doubt of a cancer or something, you don't have to do an MRI. 3D ultrasound in good hands gives very good results. And then that many of them, if there's an incidental finding, of course, on a laparoscopy, you would take a biopsy and do histopathology. And there are certain new markers that have come up in the endometrium. One of them is BCL6 marker in the endometrium. It is known as Activa test. What about the treatment? So you have the surgical treatment. You may do a simple laparotomy if you are an average surgeon. If you are in Darbhanga or some deep surgery, you can just open the abdomen and do it. I have come across people who said, "Sir, हम तो hysterectomy 3,500 में करते हैं." So there is a lot of disparity in our country, and in those places where we are thinking about laparoscopy, there is no electricity also. So laparotomy is good enough for those patients. Laparoscopy, of course, is the gold standard. And if you are very fancy, you can even do a robotic surgery. Then, of course, you have the medical treatment, the controlled ovarian stimulation with IUI and IVF. So if you look at the surgery, there are two groups of people who actually did a lot of work on endometriosis in the last decade or so. One was the ASRM committee, and the practice committee guidelines were put out in 2012. The new guidelines as yet have not come in. And the SC committee, where they put out the guidelines in 2014. So all the present dispensation and thought process of treating endometriosis is based on these two guidelines. And in women with stage 3-4 endometriosis associated with infertility, conservative surgical therapy with laparoscopy or possible laparotomy may be beneficial. That was what ASRM said in 2012. You must note that ovarian reserve testing should be done in all patients. In case of poor ovarian reserve, fertility preservation in the form of oocyte freezing or ovarian tissue freezing should be offered. What about medical recommendations? So after cystectomy, suppose you go in with a laparoscope, you do a cystectomy for an ovarian endometrioma, and they don't want to immediately go for conception, then you can prescribe hormonal contraceptive therapy. And for people who want an 18 to 24 month gap, especially with a severe dysmenorrhea, etc., you can give for a liquid LNG IUCD as well. What about the surgical precautions which you will take? So observation of post-operative decrease in AMH, ovarian reserve, may be due to inadvertent removal of ovarian tissue or destruction of follicles. And the amount of tissue removed increases with endometrial dimension. Larger endometrioma, you remove more tissue, and use of pre-operative suppressive therapy and surgical experience. All these three contribute to more tissue removal during surgery. So what are the precautions you should take? Minimal use of elective surgery, precise hemostasis and dissection in a proper plane. Many people are using diluted vasopressin. So as soon as you open the endometrioma, you can actually you can actually get the plane and then you inject vasopressin in the proper dilution. Whenever you inject vasopressin, the anesthetist should keep a tab on it, and then you slowly get the plane. So you dissect the plane slowly. And in our group, what we do is we would go dissect it down to the hilus, and at the hilar level, we will take off the capsule, but we leave the basic capsule behind. And that basic capsule can be cauterized by bipolar cautery, or we can do, if you have the CO2 laser, you can do a CO2 laser surgery. By this method, you will prevent the removal of the normal ovarian tissue. At the same time, you will also reduce recurrence because you are removing majority of the capsule. You just leave the hilar area capsule behind. You can see here that is the two. You can of course do the three-step Donnes procedure. In what the Dr. Donnes does, he puts the scope, he drains the endometrioma, and he comes out. Then he gives GnRH agonist for 12 weeks. Then he goes back again and just cauterizes the wall of the endometrioma. So, but here you need to have a 2-time laparoscopy. But with this, he has shown a lot of conservation of the ovarian tissue, at the same time decrease in the recurrence rate. So the adhesion barriers also like Interseed and Gorotex may be used for preventing of the pelvic adhesions. So what about the ART? So for women with stage 3-4 endometriosis who fail to conceive following conservative surgery, or because of advanced reproductive age, or because of other things, you may have a blocked tube with endometriosis, you may have a 2 million male factor count, IVF-ICSI is an effective alternative. For women who have found to have an asymptomatic endometrioma and who are planning to undergo IVF-ICSI, there is insufficient evidence to suggest that removal of the endometrioma will improve IVF success. And this was the Cochrane review. And based on this review, the H3 guidelines were made. So there is one more thing, that if the endometrioma is larger than 4 centimeters, surgery should be considered to confirm the diagnosis histologically and to improve access to follicles during oocyte retrieval, and possibly to improve ovarian response, because a larger endometrioma can decrease the ovarian response. patients should be made aware that extensive ovarian surgery could compromise ovarian function and diminish the response in ovarian stimulation. And so this was the H3 2014 guideline to the influence of endometriosis on the success rate of IVF is not unequivocal. So always there is a question, before doing IVF, there is an endometrium. Would you remove the endometrium? So there's the unequivocal. A lot of people, and there's a huge study from SART which says no, there is no difference in outcome whether you touch an endometrium and do IVF or you just leave it alone and do IVF. And so the new guideline which has come, which is that the final conclusion is that the only indication for pre-IVF surgery is if there is a severe pelvic pain and or the endometrium is so large that it is going to come in the way of the oocyte retrieval. You know, I was just talking to some people in UK, even 9 centimeters, normally in our group 4-5 centimeters, we like to remove it, but they are even 9 centimeter, 10, they do all sorts of manipulation, and if they have access to the ovarian tissue, they don't touch the endometrium. So this is another study where they studied the live birth rate after surgical and expected management of endometriosis in IVF. So before IVF cycle, in one group they did surgical removal and then did the IVF. Another group they didn't do anything and then they did the IVF. And they found that the clinical pregnancy rate and miscarriage rate were not different between the two groups. And that's why a lot of people are against going in for surgery for endometrium. But there are a lot of new studies that have come up that if the first IVF cycle fails, so you do surgery, you don't do surgery, you do IVF, and it fails, then before the second IVF surgery cycle, there is a study that has shown that if you operate and then do the IVF, you get better outcome. There is a study by Wang in 2019 where he said effect of cystectomy on AMH levels, and there were 171 people on the cyst size was more than 7 centimeters, and the cystectomy was done. And he concluded that women with large bilateral stage 4 endometriosis had a significant decrease in the AMH. And that was this study by Anna Kobo. Anna Kobo and me actually did the egg freezing at the same time in Japan. Me and Dr. Isma had gone at that point in time. Anna Kobo and her group had come from Spain, and we did the same. And she did this 10-year observational study. It's a beautiful paper in fertility sterility where there were 4 arms, and he classified it less than 35, more than 35, and fertility preservation before and after surgery, and concluded that the fertility preservation prior to surgery in women less than 35 years is very important. And this is the paper that has come in 2019, which now gives us the guideline. So if you have a pre-op endometriosis patient desiring fertility, you look at if she has a bilateral endometrioma, unilateral endometrioma with history of surgery for contralateral endometrioma, history of multiple surgeries, or at risk of surgeries, you go for fertility preservation. If this is absent, you look at the ovarian reserve. If the reserve is less or age is more than 37, you go for fertility preservation. Otherwise, you can observe. And the preservation can be either oocyte or embryo cryopreservation or ovarian tissue freezing. So this is just a small clip of the oocyte, and this is the freezing part where we freeze the oocyte. We have been doing it. We have done nearly, me and Dr. Nandita, our group has done nearly 15,000 eggs now, frozen eggs over the years. And this is our vitrification. We were the first in India. 2007, January, I did the first freezing of oocytes in India. I personally used to do oocyte freezing for 3 years. I can do every step of embryology. So for 3 years, I did the freezing myself and thawing myself all the oocyte and embryos in our unit. Then I got tired. I said, how much I can keep? Because I didn't want to give the knowledge. See, I was a bit possessive about the knowledge. After 3 years, any technology you get, you must, now I feel that the window is 6 months. So if you bring a new technology to a country, within 6 months of that, the technology is taken by other people. So that 6 months is very important to build up your group, because you have put in a lot of inputs to get that technology. So this is my philosophy. So now the new technologies that I bring them with the idea that within 6 months to 1 year, this technology will get. So here you can see that small droplet, you put the oocyte, and then you directly dip them in the liquid nitrogen. Directly we dip them. This is a closed system where you cover it with another straw and seal it and then dip it. So there are 2 techniques of closed and open system which you use for during the freezing. And this is the thawing process. I'll show you. I just wanted to show you because these are things that are novel. You don't normally see. You to see hysterectomies, etc., etc. So I thought maybe it will give you some different insight. So you can see this is stored, and then when you want to thaw it, this is the thawing process where you can actually, this is the very important. It's like Abhimanyu's chakra. You can go into the chakra, but when you're coming out, this is the most important step. The removal and the sudden, the gap between the liquid nitrogen and the dish has to be very small and very quick. If you do that way, 100% recovery. See, you can see these oocytes that are recovered here, nicely recovered. And so you can have a very long term. You can freeze the oocyte for 20 years as well. It doesn't really matter. And this was our first Dinah Head and Dr. Nandita's patient and my patient. She froze her eggs she had endometriosis. She froze her eggs when she was unmarried 10 years back and then had 3 children from frozen oocyte. The other technique which is there is the oocyte freezing technique. So you can see here one of the ovaries is taken out and this ovary is taken by laparoscope. We clean it up and then you remove the medulla. Only the cortex is maintained. So you can see here the cortex is kept, the medulla is removed. So because all the ovary is in the cortex. Cortex is only 1 millimeter in 1 to 2 millimeter thick. So you have to remove all the medulla by surgical dissection. We remove it and then we pass it through 3 medias of vitrification DMSO with ethylene glycol, and we make it and we perfuse the whole tissue with the vitrification. And once the perfusion is done, this is a carrier system. We put it on the carrier system. You can see these are nice steel rods, and on that the tissue is spread out and then dip directly in liquid nitrogen, and then you can freeze it for 5-10 years. And then once the chemo radiation therapy is over, patient gets married, you can remove all these tissues and you can put them back into the. So what is my approach? This is the last 2 slides. My approach for stage 3-4 disease, there are 3 options. There is a traditional group will say, no, I want to do laparoscopy. Fair enough. So laparoscopy for all. Do the precaution, see that you don't damage the ovary. After that, you can do controlled ovarian stimulation with IVF for 3 to 6 months. If that fails, you go for IVF. The second approach is, they say, no, I'll do laparoscopy only if there is pain or size is more than 4 centimeter as per H3 and ASRM guideline. Then, okay, fair enough. You do controlled ovarian stimulation with IUI, 3 to 6 months. If that fails, you go for IVF. Third patient group is said, no, if no pain or size less than 3 to 4 centimeters, I will go for controlled ovarian stimulation and IUI and directly go for IVF. So that also. So, and if there is a recurrent, patient has already had a surgery, she comes for a recurrent disease, direct IVF. There are a lot of studies that have shown don't touch the endometrium, go for direct IVF. As far as fertility preservation is concerned, if there is a poor ovarian reserve, AMH less than 1.5, age more than 35, bilateral endometrioma, recurrent endometrioma, oocyte freezing, of course, is better than ovarian tissue freezing. And finally, you do IVF. This is the final slide. So what I do, I do reverse. So now all the patients that we have who have pathology prior to IVF, like hydrosalpingo, fibroid, adenomyosis, endometriosis, I first take the eggs out and make the embryos. First, so we do reverse thing. We remove the eggs, make the embryos, and we see that at least 9-10 embryos we get. Then we go in and do the surgery. So if there's a hydrosalpingo, we'll disconnect the hydrosalpingo. If there's an adenomyosis, we'll give 2 shots or 3 shots of GnRH agonist and suppress the adenomyosis. If the adenomyosis is very large, we'll do an excision of the adenomyosis. If there's a fibroid less more than 5 centimeters, we'll remove it. So whatever we do, because what happens is whenever you do pelvic surgery, there is a possibility of compromise of the vascular supply of the pelvis, which can result in decrease in the ovarian reserve. So first remove, create the embryos, store them, then do the surgery, then, and because what happens after, suppose you do the reverse way, first do the surgery, then you have to wait for 3 to 4 months, then you will do the stimulation. By the time you put the embryos back, the fibroid may regrow again. So this is the reverse way which we do, and we get very good results. So this is the final, I think, slide. Infertile women with suspected endometriosis, you do infertility workup. If other indications are there like low male count, blocked tube, you go straight for IVF. If there is no indication, you look at the ovarian reserve. If there's a poor ovarian reserve or old age, you can go for IVF directly. If there's a suspicion of mild moderate disease, do surgical treatment, do COS IUI followed by 3 cycles, 3 to 6 cycles. If it fails, go for IVF. And if there is suspicion of moderate to severe endometriosis, do surgery if you want, or go directly to IVF. As I told you, different groups live in different things. Thank you for a patient hearing.
Thank you, Rishikesh. Thank you so much. It was really a most comprehensive way you explained the endometriosis. And see, when you are doing so much work, it comes from within. We all know that it's etiopathogenesis, it's so much variability. I just would like to say one thing. There is no fixed protocols in endometriosis, as Rishikesh has widely explained. You have to decide what is the patient's presentation for what she has come. And the new most important thing, which if there are endoscopic surgeons also are attending, start doing oocyte freezing, that is ovarian cortex freezing at the time of endometrioma surgery. So patient may say, I'm not interested in pregnancy right now, just get me rid of pain now. But she's a nulli gravida, you know, she's a stage 3, stage 4. Tomorrow to become a pregnancy, she will need a IVF and probably she may have a premature ovarian failure by the time she planned. So at the time of an endometrioma surgery, taking out some part of a cortex and freezing it. So every endoscopist should have an ART consultant, and every ART consultant should have an endoscopic surgeon in their team to tackle these patients. Rishikesh, thank you so much. It was
yeah, I was thinking I will just say one more point here, Sunita, that basically now there's a new breakthrough technology that has come in just recently. I have to go and so what they have done is that now when you do the ovarian tissue, when you thaw it, you can actually dissect the primordial follicle, mature the follicle in vitro, and treat the embryo and put it back. So that is a new technology. So we were planning to put the ovarian tissue back, but now this technology, once it matures, you can be able to do in vitro maturation and give the baby and put it in.
You know what, even I read that publication, Rishikesh, from the cortical thin millimeter, they take out those primordial follicle, then they do like a IVM, how we do, and they make it mature and then they freeze.
Right.
I believe that technology yet to establish, and we need to give a result so we can do simultaneously. We definitely know that ovarian cortex freezing and then reimplantation has now established over 2 decades. So one can think of simultaneously doing few follicle IVM, develop your technology, develop your lab standard, and once you know that you can do it, maybe 5 to 8 years down the line, you can change your thinking. Up till now, maybe 5 years ago, we were never even thought of. We used to do the surgery and we used to sit and counsel the patient, just plan the pregnancy, plan the pregnancy. Now with the establishment of ovarian tissue cryopreservation and transplantation, with the success, we started thinking it's not only for the cancer, it is not only for the social, but it is all, there are many other benign indications where we can think of doing this. And this is a wonderful eye-opening. I think after 5 years, every endoscopic surgeon will start this cryopreservation with their nearby lab. Sometimes I feel in the city there should be 2 or 3 ART consultants because you will need a lot of space to do this cryopreservation. So there may be 2 ART consultants and everyone sends to them. Their embryologists can master themselves and they can have a space. You know, this all revolution will come slowly and slowly. Thank you. It was wonderful. And the entire Noida society, thank you so much for giving this opportunity to interact with you.
I also want to say, Dr. Rishikesh Pai, it was really a very nice, but we all must know that endometriosis is really a disease where the delay in diagnosis is there and the debilitating disease also. So if we anticipate each and every patient coming to the OPD with the pain, then and telling each and every gynecologist to learn to do and to learn to diagnose with the TVS. So we can do and the line of treatment because if still in the surgery is very, very important. Don't try to hush the surgery because first surgery is the window of opportunity. So there should not be many surgeries. So this awareness has to be there, and so a role of medical management and awareness is to be given to all, and it is very beautifully explained by the sir. He is a master, he is the king
Thank you.
Thank you so much.
Thank you all the persons for this keynote address, lovely keynote address by Dr. Rishikesh Pai. Moving on ahead, can we have the next set of chairpersons, session 3, which is the oration much awaited for all of us by Dr. Shanta Kumari ma'am, who's we are waiting to see her come in action, taking over.
And just a minute, Dr. Raki, I'm helping you for a CV. Maybe he's stuck. So
Okay.
can I read a CV of ma'am, Mandakini
Yes,
ma'am?
yes, please,
From
please
my
take over.
desktop? Yeah.
Yeah.
Welcome, ma'am. Dr. Mandakini ma'am, please share our the most awaited session of session 3, that is oration today. And for this, I would like to call Mandakini ma'am to chair the session. Mandakini ma'am is a chairperson of ICOG FOXI and International Vice President MY Central Asia, Vice President AMWI Central Council, and National Vice President FOXI 2012-13. So ma'am, please chair the session for the oration. Welcome, ma'am. Now our next chairperson.
Can we have the CVs of the next chairperson, please?
So Dr. Alka ma'am have a little problem with a login, so she will join
introduce her
very
also.
soon. So
Please
our
introduce.
next chairperson is Dr. Alka Kriplani ma'am, and ma'am is a Padma Shri for the distinguished service in the medicine by President of India 2015, and ma'am is a BC Roy National Awardee for eminent medical teacher in 2017 and the honorary FRCOG Fellow of Royal College of Obstetrics and Gynecology, London. So ma'am will join very soon, facing some difficulty in the technical part. Now our next chairperson is our own, that Meera Agnihotri ma'am. Ma'am is a professor and the head of the Department of GSVM Medical College, Kanpur, and the presently a chairman ethics and the research state medical council, and the president of WWW Foundation, and the organized international WWF first ever and the conference inaugurated by the President of India and the Union Health Minister. So ma'am, please chair the session for an oration today. So now I would request all my chairperson to please start a third session, that is oration. Please, ma'am.
मीरा जी मैं शुरू करूं मीरा जी should I start
I'm starting. Yes, I'm starting. At the outset, I extend my heartfelt gratitude to Noida Ops and Gandhi Society. The 3 young persons invited me, and Rena and Sujata and Rakhi. They are so important persons, beauty with brains. You cannot refuse their offer at any circumstances. I'm simply honored to be on the dais with my distinguished friends like Mandakini and Alka Kriplani. Being teacher, I can say that Alka Kriplani is one of the very good teachers. She is ex-president of FOXI. Mandakini, she's again a very good teacher. She is heading the highest wing of the FOXI, the academic wing, Indian College of Obstetrics and Gynecology. And she has innovated, all of us know, a number of firsts to this ICOG, and teaching profile has taken a U-turn in her tenure, and we will be seeing them very soon. Our President-elect, Dr. Shanta Kumari, is with us as an orator, and it is really a great opportunity to see her. She is called as, very popularly known and called by us as energy bomb. She really energizes like anything. She doesn't need any introduction to this society, to this audience, but since it is customary, I have to say that she is President-elect FOXI 2021, Chairperson of the FOXI ICOG 2018 as a Secretary ICOG, Member FIGO Working Committee, Violence Against Women 2015 to 21, Vice President FOXI 2013, Secretary 2COGS 2015, IAG Managing Committee Member 2015 to 2019, Chairperson of MNNR COG FOXI Committee 2008 to 2010. She has got number of awards. Most important, we know as FRCOG honor which she got UK 2018, and not only fellow of Royal College of Obstetrician and Gynecology, it is fellow of Royal College of Physicians as well. She got this award. ICOG secretary for 2015 to 17, initiated Dhira project for violence against women, national correspondent and editor for JOGI, vice president Foxy 2013.
Thank you, madam.
It is a long list. I'm with her for such a long time that whenever I meet her, I learned something very important. She's so loving, she's so affectionate. You simply tell her that this has to be done, and I personally feel obliged. She says, yes, madam, it will be done. So that is one quality which as a president, we know that she's having. And now hand over the mic to
So I want to say, I also want to say, Miraji, that Shanta Kumari is a powerhouse of the Foxy.
That is what we are telling you.
Yeah, I'm using different word, different power. So welcome Shanta for this very, very prestigious. Why I'm talking? Because I'm so impressed with your theme, which was principle, protocol and practices.
Right.
And from your theme only, I have taken the clue, and this year equip, empower and educate has come from your theme. I want to give credit to you and acknowledge, and the stage is yours for this wonderful oration. Please enlighten us with this your oratory skills and a subject, please.
Good morning, everyone. Thank you, Noida Society. I would like to thank my dear friend Rakhi, Dr. Sujata Bhatt, Dr. Anshu for inviting me over to Noida to deliver this oration. In fact, Rakhi, when she was a president few years back, she had invited me to deliver the oration. And I remember I had another program simultaneous day, so I couldn't actually make it to Noida. So Rakhi, thank you. And the team again for
Thank you, ma'am.
inviting me back to Noida, Sujata and Anshu. Before I go, I think I have to tell there is some fluctuation problem which is happening at my end, but I have my Geo also on. So if I just go off, I'll be back on. Don't get worried. Dear friends, I would like to actually say hello to my dear Madam Dr. Meera Agnihotri, Dr. Usha Sharma. Both of you are very lovely ladies whom I really admire and adore. And thank you, Dr. Mandakini Meg, for giving those kind words. It's a pleasure to have you as the chairperson of ICOG. In fact, when Sujata called me and Anshu called me and said, you deliver an oration topic. So I actually did not know what was the theme of the conference. And I said, I'm going to talk on principles, protocols, and practices. Because that was the theme of my year when I was the ICOG chairperson in 2011. We obstetrician gynecologists, we are the physicians who actually treat women. And what is the central paradigm in OB-GYN practice? Well, friends, when you actually look at it, what is the core of health? We as the healthcare providers, what is it that we're looking at? First, do no harm. That is the paradigm. Whether you are able to help the patient, whether you are able to do the best possible treatment to the patient, whether you cannot do the best, remember, first do no harm. We've just heard the lovely oration which Dr. Rishikesh Pai has given, and we have heard the chairperson, Dr. Madhuri and Sunita actually talk about endometriosis and the treatment. We just heard the philosophy behind the endometriosis. But remember, you may be the best endoscopic surgeon. You may not be the best endoscopic surgeon. But if you are able to save that ovary so that that woman can go ahead and have a baby, that is the core essence of health in practice. That is what we need to understand, that you have to do your best towards the patient's health. And for achieving the state of complete physical, mental, and social well-being, you need to understand you may not be the best endoscopic surgeon in the world. You may not be the best or the supreme endoscopic surgeon, but if you know the principles behind that endometriosis.
Shanta ma'am, excuse me, I'm not able to see the slides. It is only the blank slides which are there.
Can Can you all not see now?
No.
1 second. I'll just look into it. I'll just stop.
It's
1 second.
only the blank. Stop sharing and reshare it again.
Okay, I'll stop sharing to show 1 second. What is it? Why can't you use this thing? 1 second, just hold on. I'll close that our internet and open our close the internet. Internet.
Initially, I thought it was only me, and I thought my connection is not working. These are all the hitches and glitches. Actually, in the morning, there are so many today. There are so many webinars. In the afternoon, whenever we are logging in, again, at that time also, we are having a lot of problems nowadays with all the speed bandwidth, and then actually all the schools and everybody is using it.
Till now, actually, everything was okay. Then suddenly, now can you see?
No, we can't see.
No,
we can't see.
You can't see now?
No.
But I can see, no?
Slide is not visible.
Ma'am, you have to click with the down arrow. Click with
I
the
know
down
that.
arrow. Yeah.
I know that. I have done that only.
Ma'am, what
Now,
you can... No.
your screen sharing, it's come.
No, you can see the white screen.
1 second. I'll just log out and log in. 1 second. Just give me 1 minute.
Or she could share her PPT with anybody of us.
I think the host can take the slides.
Shanta,
That's
can
all.
you send a PPT
I think
by
I'll
email?
give a
We
call
can
to her.
project it.
Parmit,
Nowadays, I'm sending the, now I think in the future, we should all take our slides and keep.
Ma'am, either you can share your PPT with me, then I can project it also if required.
Can you see now?
No, ma'am.
No, we can't see.
Ma'am, share it with me.
Actually, what you can do is that take the other next talk, and then madam can talk later on, so that by the time she can the PowerPoint presentation.
1 second.
Yes.
It will just take me 2 minutes. I don't know why this happened first time.
actually in last webinar it happened with Alka, then she gave it to the host. Then
It never happened to me actually. First time this is happening.
Alka was also saying the same.
Because we are become.
Shanta, forward your slides to Rakhi.
Yeah,
that is all.
that's what I'm doing now.
Ma'am, either you put it on WhatsApp or you put it on WhatsApp is also good.
I'm going to
Or
the mail.
Yes.
1 second. Attach from computer. It's coming too large.
Ma'am, WhatsApp पे easily आ जाएगा शायद.
WhatsApp it. But
Just
I don't have.
drop it on the, if it is logged in into
Send it in the WhatsApp, but that's there.
If it is logged in, otherwise on the mail.
Mail is coming too big because too many pictures are there.
In the meantime, can we take up Dr. Jaideep Tank's keynote? Otherwise, we can come back.
All right, do that. I'll just send this.
In the meantime, you send me.
Yeah. Of that.
Dr. Jaideep Tank is there, sir?
Yes, he was.
Anshu, will you coordinate with Dr. Tank?
Yeah, Anshu.
He's there.
He is there. Dr. Jayanta, can you please get the screen off for a second? Dr. Tang is there. Can we have the chairpersons of the next session?
Dr. Chitra is a chairperson. She's already there on the screen, I can see.
And Dr. Usha Sharma ma'am is there. Dr. Jayanta, please share the slides. Yes, sir. because of the hitches and glitches, we are moving on to our next session, and we will be back for our much awaited oration. As we have got our first, we've got chairpersons for this address by Dr. Jaideep Tang, sir. And for that we have, can you please share the slides, please? We have got Dr. Usha Sharma, who is the legend in itself, and as has been told, she has always been a evergreen person and ever-loving person. To have a formal introduction, she is the president of Obstetrics Society of Meerut branch from 1978 to 2008 and lifetime chief patron of UP chapter of obstetrician and gynecologist. She's got many awards to her credit, and a lovely lady whom you will always want to listen to her and get her advices, and she always has an advice to us to give for all of us. Every time you talk to her, she will be a pleasant person to hear. She has been awarded with Padam Shri by President of India in 1985 and a list of awards: Indira Gandhi Priyadarshini Award, Mahila Ratna, Meerut Ratna, Hari Om, Alembic Research Awards, VC Roy National Awards, and many more. Moving on to our next chairperson. Next slide, please. Welcome, Dr. Usha Sharma, ma'am.
Thank you.
Can we have the next chairperson, please? Slide of the next chairperson. We have got Dr. Chitra Sethia, who is the founder member. Okay. We've got Dr. Parag, sir. He is senior consultant OB-GYN at Pune. He is the secretary of ICOG right now at present and a president of Menopausal Society of Pune. And National Joint Secretary of IMS 2017 to 18, National Website Editor of Foxy from 2011 to 17, Year Review Journal. And I would like to tell, he's a thorough gentleman who has a lot of knowledge and to her credit, and he's always a welcoming person to answer to any queries, and he's one of the advisors to my committee who has been a promising person to help every time. Next chairperson, we welcome you, Dr. Parag, for the keynote address. Then we have got Dr. Chitra Sethia, ma'am, who is the founder member of our society and the founder president of our society. And she is the director of Apollo Hospital, Noida, practicing since 33 years. An area of interest is high-risk obstetrics and operative endoscopic surgery. She is having many posts in her hands. Founder Secretary of Noida Society, past President, National Local Faculty of various academic sessions and many conferences, and for her credit. Welcome you all for the keynote address, madams. Please. Can we have the CV of Dr. Jaideep Tang, please?
Yes. Please put the CV of Dr. Jaideep.
Good morning all, and at the outset on behalf of chairpersons who are with me, Madam Usha Sharma and Dr. Chitra, thank you the organizers for having us here to chair a very important session by none other than Dr. Jaideep Tang. May I request Madam Usha Sharma to introduce Dr. Jaideep Tang.
Thank you very much. All of us know that he is a very dynamic and dedicated Secretary General, Federation of Obstetrics and Gynecological Society of India, immediate past President, Mumbai Obstetric and Gynec Society, Chair International Federation of Obstetrics and Gynecology Committee for Safe Abortion, Deputy Secretary, Asia Oceania Federation of Obstetrics and Gynecology, ex-chair Publication and Newsletter Committee, Asia Oceania Federation of Obstetrics and Gynecology, Reproductive Endocrinology and Infertility Committee, Asia Oceania Federation of Obstetrics and Gynecology. All of us know that he is a very dedicated person, and we all praise him as Secretary General of our society. Dr. Jaideep Tang, all of us know that he will be telling us about the he will be telling us about the modern obstetrics in present era. And all of us know that modern obstetric care is dedicated to provide personal and compassionate care to every patient, ensuring that most recent and updated care is provided to the patient. Modern obstetricians should be well versed with the preconception counseling and education, evidence-based management of low-risk pregnancy, and early detection and management of gestational diabetes and many other obstetric complications. We all know that labor management and monitoring has now been standardized with e-partogram and continuous electronic fetal monitoring. And labor room should be well equipped with PPH management, and so that we can have knowledge of how to manage the normal labor, and we should have patience, and we should be vigilant enough so that we promote normal vaginal deliveries and reduce the incidence of cesarean section. For this such an important topic, which is modern obstetrics and how we got there, we have got none other than Dr. Jaideep Malhotra. Sorry. May I request my dear Jaideep to please tell his talk on modern obstetrics, how we got there. Dr. Jaideep Tank.
Thank you very much, madam, for that very kind and generous introduction. I will go so far as to say that that introduction was just like your personality, very kind and generous. Thank you very much. Thank you to Parag also for that kind words, and Dr. Chitra Setia, the other chairperson. It's a real honor to be speaking to the Noida OBGYN Society, and I would very much like to thank the program moderators, the President, Dr. Sujata Bhatt, the Secretary, Dr. Anshu Raina, and Dr. Raki Singh, who is a committee chair in FOXI, for their very, very kind invitation. And it's really always a pleasure to work with them. You know that we are going to have a small launch of the USAID project. And I must say that the entire Noida society has been extraordinarily cooperative. And I'm very thankful for them for all their efforts. It is also such a great pleasure to be speaking when I can see such stalwarts like Dr. Meera Agnihotri, listening to this talk. I don't mind admitting that in her presence, I am a little nervous about giving this presentation. And of course, there is Dr. Meg, Dr. Shanta Kumari, Rishikesh, Dr. Madhuri Patel, and so many other stalwarts. Having said that, let me commence with the topic proper. You know, as obstetrics and gynecological healthcare providers for women, and as physicians really who help families complete their family units, I have always believed that it's not only important to look at the science behind our art, obstetrics, but also to understand the narratives which drive our profession. Narratives within the media, in the public at large, amongst activists, policymakers, and us as practicing obstetricians and gynecologists, which make us practice the way we practice modern obstetrics. So this talk is not a simple recitation of the history of obstetrics, for example, the history of vacuum or the history of forceps, but rather it plans to look at the way the narratives which drive our profession in the current day and age have come into being. Let us start with the core of narratives. And I believe the core of any narrative has to be information. If you do a Google search on childbirth, look at the astonishing amount of information that is available. 69,800,000 hits for a simple Google search on childbirth. I mean, how in the world is it possible for women and even doctors sometimes to comprehend, review, sift, analyze, and ultimately make sense of this overwhelming amount of information? Just keep this figure in mind: 69,800,000 hits on Google for a Google search for childbirth. I mean, it's no wonder that women and even obstetricians think that childbirth is complex. Not only complex scientifically, but complex also in terms of the way information is presented and the way this information is available to them on the wide world of internet. This of course raises the question, why is human childbirth so complex and so different from other mammals? Why can't we be like, for example, cows or horses or elephants, where they go into a quiet part of the jungle and then they, in a large number of circumstances, deliver. And once you must have seen the videos of these deliveries, once the foal or the calf is born, the calf just takes a couple of minutes, breaks the sac by its own, and then literally starts walking and attempts to start feeding with the mother. Why is human childbirth, on the other hand, so complex? It's complex because the whole process is a solution to an evolutionary problem. And this evolutionary problem is our ability to walk upright, which requires a small, fixed bony pelvis and also a large brain. And therefore, what has to happen is that a baby whose head is too big has to fit through a small pelvis. And because of this, all human mothers essentially give birth prematurely. And when I say that, I mean that in context to the other mammals who are born mature enough to walk and seek food within hours. Our newborns, on the other hand, are small and helpless for months. Even so, of course, human birth is a feat involving an intricate sequence of events. Despite the fact that women have been giving birth since millennia, our science is actually quite young. In fact, male obstetricians like me are a relatively new addition. Manned midwifery, as it was called in Britain, only started in the 17th century. You can see here that William Smellie, who wrote the definitive, almost the first English textbook of obstetrics, was giving classes, and he said that a 2-year course of lectures cost 20 guineas. That's equal to 2,000 rupees. So at that time, it used to cost 2,000 rupees to attend a course on midwifery and become an obstetrician. It was only in 1928 that one of the first associations, the British College, was established. And since then, our art and our science has taken a turn as a formal subject. Of course, technology then started evolving and we started having safer instrumental vaginal deliveries and safer cesareans. This was all going on very nicely, but then came the APGAR score. It is said that the APGAR score, ironically enough, developed by a pediatrician, was actually responsible for completely changing the way we approached obstetrics and also approached outcomes in obstetrics. So the score was published in 1953, and what it essentially did was turned an intangible and impressionistic clinical concept, which was the condition of a newly born baby. So for example, previously we used to say this baby was born well, was not born too well, or was born sick. It compared this kind of subjective impressions into a number that people could collect and compare. Using it required observation and documentation of the true condition. And essentially what it did was, because doctors are inherently competitive, it started driving them to produce better scores and therefore better outcomes for the newborns that they delivered, which to my mind, raise this massive question. Can childbirth be standardized? And when we say standardized, we have to take into account that if we are going to standardize childbirth, then we have to know, or we have to realize whether obstetrics is a craft or an industry. If obstetrics is a craft, then we have to focus on teaching obstetricians to acquire artisanal skills. For example, the Woods corkscrew maneuver for the baby with a shoulder stud, the Lowset maneuver for the breech baby, the feel of a forceps for a child whose head is too big, and then do research to find new techniques. But most importantly, you have to accept that if it is a craft, that things will not always work out in everyone's hands. And this is something which patients and obstetricians increasingly find very difficult to accept. But if medicine is an industry, and the responsibility of medicine as an industry is the safest possible delivery of millions of babies each year, then you have to shift the focus from artisanal to reliability. And you have to wonder whether all obstetricians can actually master all these techniques. And therefore, when the ABGAR score came and comparison started becoming out of 100 babies, I had 99 babies with an ABGAR of 9, but I had just one baby with an ABGAR of less than 9. And this kind of competition, obstetricians decided that they needed a simpler, more predictable way to intervene when labors ran into trouble. And what did they find? They found this in the cesarean section. One of the problems with obstetrics really is the fact that despite so many publications, our evidence base is quite meager. That, and combined with the fact the responsibility of looking after 2 lives at once, meant that we were always going to have an increase in cesarean rates. To wit, a statement like this started appearing in the media. Now, this is by Barbara Harper, who says, we used to see birth as a miracle and only mess with it if there's a problem. Now, we see birth as a problem, and if we don't mess with it, it's a miracle. I am not very much in favor of such statements. However, the fact remains that if you look at a ranking of medical specialties according to the use of hard evidence from RCTs, obstetrics actually comes in last. It is said that we do few randomized trials, and when we do them, we sometimes ignore the results. To wit, electronic fetal monitoring and instrumental vaginal delivery. To give you a background, how many RCTs did Chamberlain do before he started applying the forceps? How many RCTs have actually told us that there is no difference in outcomes whether we use electronic fetal monitoring and intermittent auscultation, and yet we continue to rely on electronic fetal monitoring and instrumental vaginal delivery? So as Atul Gawande wrote very nicely in the New Yorker, in obstetrics, if a strategy seemed worth trying, doctors did not wait for research trial. They just went ahead and tried it and then saw if the results improved. So in a way, we started improving the same way Toyota and General Electric did, on the fly, but always paying attention to the results and trying to better them. And obviously it has worked. Whether all the innovations and adjustments of the package are necessary and beneficial may remain unclear, but the obstetric package as a whole has made child delivery demonstrably safer, and it has made it safer despite the increasing age, obesity, and consequent health problems of pregnant mothers. I have always felt that perhaps we don't appreciate ourselves enough. But I think it's moment to take a step back and look at what we as obstetricians and healthcare professionals who look after women who deliver have achieved. India currently has the lowest ever maternal mortality in its history. What does that mean in practical terms? That means every day, 30 more pregnant women are now being saved in India as compared to 2013. So what is modern obstetric practice which has led us down this whole tortuous path so far? Modern obstetric practice consists of pre-pregnancy planning, antenatal care, delivery, and post-delivery care very broadly. However, that's not all. As modern obstetricians, we also have to juggle demands of natural birth demands of zero risk from patients. No, I don't want to take any chance. Demands of infrastructure, medical legal parts, and of course TMI, that is too much information, as I already pointed out in the Google search. This has actually led to two major narratives driving our profession in modern obstetrics. One is cesarean rates, and the second, what I like to call the over-preciousness surrounding motherhood. So let's talk a little bit about cesarean rates first. For me, this controversy around cesarean rates has always been something like this, where this gentleman is telling the lady, let me interrupt your expertise with my confidence. I'm completely astonished that people who have not even seen a childbirth and labor sometimes keep on advising us on how to do obstetrics. So the talking points about cesarean rates are, what is the controversy? Is there an ideal cesarean rate? And what is the way forward? It all started with this publication in 1985 from Lancet, which said there is no justification for any region to have CS rates higher than 10 to 15%. Remember this figure and remember this statement, because this has been the bulwark around which a whole huge narrative has been built around doing too many cesareans. If you look at globally, you will see that there are only 4 countries in the world where cesarean rates are between 10 to 15%. Most developed countries and countries which have reasonably tolerable maternal mortality rates actually have cesarean rates far in excess of 30 to 35%. This narrative of 10 to 15% has also given rise to a slew of petitions from the lay public. Anybody who feels that we do too many cesareans starts putting up these petitions. What I'd like you to see here is the number of supporters that these petitions have garnered. If you look at this first petition, they had 20 supporters. The second one had 7 supporters, and they needed to shut down the petition because it did not find any resonance in the lay public. But then this petition came, #SafeBirth, which was very smartly driven with the use of social media and so on and so forth. And it was a very emotively written, in a way, emotionally manipulative way written petition. For example, this person says, I was cut open to deliver my baby, and I was misled, manipulated, confused, and my choice was overridden. Forget the fact that at the end, she and her child were healthy. That is not mentioned anywhere. And even this relies upon that 10 to 15% should be the ideal cesarean rates. Not surprisingly, the media picked it up. Cesarean section surgeries were called a racket. Hospitals were called profiteering, and there were calls for regulating the way we do cesareans. And just like Newton's 4th law, not surprisingly, which says for every action, there is an equal and opposite reaction plus a social media overreaction. In a classic case of social media overreaction, our honorable minister at that time, Shri Menka Gandhi, tweeted that she is worried about the rising rates of cesareans. Doctors who do too many cesareans should be named and shamed. And look what she has based her sort of a conclusions on. Again, 10 to 15% should be the ideal cesarean rate. It caught on with the government also, and then the government of Maharashtra actually invited us for a meeting to discuss how cesarean section rates should be regulated. I attended these meetings once with Dr. Nandita Palshetkar, once with Dr. Meg, and I will tell you what happened after the meeting. So I think the central question that needs to be answered for cesarean rates is that 10 to 15% cesarean rate thing really valid? Is it true? It's not. It's almost always overlooked that the WHO document reflected only on mortality. It never spoke about morbidity. Why did it not speak about morbidity? Simply because there is no data available at the population level correlating cesarean rates with morbidity. Moreover, what is most telling is that none of the countries with a stillbirth rate of 2 to 4 per thousand have a cesarean section rate between the World Health Organization recommended 10 to 15% threshold. It essentially means that that 10 to 15% figure had so many problems. the data was unreliable, the methodology which was used to arrive at these rates was not robust, and most importantly and tellingly, these rates were never meant to assess cesarean rates at the level of an individual facility, individual physician or patient. These were simply rates which were made to look at accessibility and availability of cesareans in the public sector for policy makers. So it all essentially boils down to the problem of selective because morbidity, fetal and maternal, was not taken into account. In fact, now there is excellent data to show that even if you're looking only at mortality, 15% is still too low. This is an article from the JAMA from Ariadne Labs which says that previously recommended national targets for cesarean deliveries may be too low to prevent mortality. Again, maternal and newborn morbidity, for example, obstetric fistula, birth asphyxia, psychological health, ability to initiate breastfeeding, was never ever considered when they were looking at these rates. Why? Simply because there is no data available. Let's now look at Indian data where we have been called profiteering and racketeering and so on and so forth. If you look at the newspapers, you will always see 80% cesarean rates in private sector. Is that true? Let's look at the government data for that. If you look at the population level, you will see that the districts in black, and there are only around 6 of them, are the only districts in our country where cesarean rates are actually higher than 50% at the population level. Most of our country, you can see the orange and red. I'm not being political, but you can see the orange and red, which envelopes most of our country, seems to suggest that what we suffer from, and that because of which our maternal mortality is not going down, is the fact that we have too few cesareans, particularly in the public sector, rather than too many cesareans. Even if you look at the private sector and you look at the states from where most of this data about too many cesarean comes, that's Telangana, Andhra Pradesh and Maharashtra, it should be clear to us that one of the reasons why there is an increased rate of cesarean in private sector is because there are too few cesareans in public sector. So while the incidence, a high incidence of cesareans in private sector has always been commented upon, nobody has ever said that that may be because there are too few cesareans in the public sector. To it, look at this. In Telangana, 42.3%, nowhere near that 80% which people keep talking about, 42.3% cesareans in the private sector, but look at the cesarean rate in the government sector, 10%, only 10%, which obviously means that those number of cesareans have to be compensated somewhere, isn't it? Look at Maharashtra, where the government decided to call the committee. Private health institutions at a population level account only for 11.3% cesarean rates, and public sector accounts for 4.3%. This is not Foxy data or my data. This is government data, which quite clearly shows that there is a paucity of cesareans in the public sector. I would therefore not at all hesitate to quote from this article from BJOG in 2016, which says that the time has come to put the debate about the preferable rate of cesarean on hold. We need to collect more data in the Robson's classification, which will lead us more clearly to actions which will actually improve the quality of care. The WHO probably realized that that 10 to 15% was creating a problem. And this is the new WHO statement which has come out 4 or 5 years back. It's not a new statement. It's come out 4 or 5 years back. And look what they have headlined that statement. Every effort should be made to provide cesarean sections to women in need rather than striving to achieve a specific rate. It's nobody's contention that we should do cesareans willy-nilly, but equally, it should not be anybody's contention that there is a recommended rate for cesareans and that rate is 15%. Is there a recommended rate for cesarean section therefore? The short answer quite clearly is no. Then what do you make of all these activists and all these media reports and the policymakers' tweets saying that because it should be 10 to 15%, we are doing too many cesareans? For me, these are just column inches. ill-informed at best, and malicious at worst. In fact, one advocate filed a case in the Supreme Court to say that doctors do too many cesareans and the Supreme Court has to give guidance to doctors. This case was dismissed with cost. That means the advocate who filed the case was penalized 25,000 rupees for filing the case. And it was Justice Chandrachud who said in the court that who are we as lawyers to decide when obstetricians should decide to do a cesarean. To my mind, there is a little demonization of cesarean going on. And this demonization is going to have unfortunate consequences. For example, this person in Tamil Nadu who decided that it was a normal delivery, thought that, oh, my wife delivered so easily the first time around, I'm going to watch YouTube videos and deliver her. And he attempted to deliver her at home watching YouTube videos. Unfortunately, the woman passed away. Therefore, I think we have to take cognizance of the fact that sometimes there are misleading and even to a certain extent false media reports. As I have tweeted, rhetoric has replaced, sometimes even dangerously, what is best for the woman, her baby. And a rational evidence-based approach to this is required rather than the lazy narrative of the commercialization of medicine in general and birthing in particular. I was therefore delighted to work on this draft on the statement of cesarean rates from FOXY, and I would encourage you to please download it from the FOXY website and read it. We at FOXY recommend that we should start using the Robson's classification now to collect data more uniformly, because there is no doubt that cesareans where medically indicated save lives. There is unfortunately inadequate data to determine the correlation between morbidity and rates, and it is perhaps impossible, and it's going to be impossible going further to determine optimal rates for a cesarean. So the way forward is for all of us to start reporting cesarean rates with the Robson's classification and collect data. So you remember that meeting I told you about that we had with the government of Maharashtra? The outcome finally was that they said, and you can see my name and Dr. Megh's name over here, because we had attended that last meeting, and they essentially said that they would give FOXY the responsibility. So this same presentation was given to the government of Maharashtra, and they finally said that FOXY should encourage its private providers to start collecting data in the Robson's classification. And I think this is something, and this is the second part of the talk. I think I have 3 minutes more, and I will complete in the next 3 minutes. This is the second part of the talk where I talked a little bit about the other narrative of over-preciousness, if you will, of motherhood. And I think, to a certain extent, perhaps, we as obstetricians want to keep on reassuring our patients. Don't worry, I'm there. When you go into labor, I'm there, I'm going to hold your hand, and I'm going to give you a tiny little episiotomy which will heal in no time and you will have a safe birth. But we have to be very realistic in counseling. As Marsden Wagner has written way back in 2000 in the Lancet, nowhere is maternal mortality or perinatal mortality zero. Throughout history, women have accepted this harsh reality until recently when doctors began to promise perfection. मैं हूं ना, चिंता क्यों कर रही हो, मैं संभाल लूंगा. Now, when something goes wrong, women and families feel deceived and seek answers. And this has, kind of resulted in this, what I like to call over-preciousness which surrounds motherhood. Right from morning WhatsApp messages to pregnant women, I'm sure all of us have these pregnant women who come to us highly stressed, highly worried about how the pregnancy will go and, how they are going to. And these birth plans are actually supposed to be something which would facilitate the whole labor process so that there were no. Unfortunately, some women have now become so inflexible about the birth plans. ऐसे ही होना चाहिए, normal ही होना चाहिए. Episiotomy के सिर्फ 4 टाके ही आने चाहिए. And it's becoming quite difficult really to live up to these kind of expectations, because sometimes patients are simply unflexible when it comes to making changes in their birth plans. This is from the blogosphere. It's not from an Indian patient, but I can see this coming here. For example, they have developed with every tiny detail of their pregnancy, so obsessed with every tiny detail of how they will give birth. For example, this patient was asked, did you have a plan for your placenta? So what plan, what possible plan can there be for a placenta? So this person asked, like, do you want to cook it and eat it, or do you want to bury it in the garden so that a tree rises from it and you have a memory of your placenta? And this person says, oh, I just want to push it out of my vagina. Does that count as a plan? And this article, again, I urge anybody who delivers babies to please go to the internet and download this article and read it. This article really, really touched me. It is an article from Time magazine called The Goddess Myth. And what it essentially talks about is the pressure pregnant women have to go through their pregnancy. Starting from good morning WhatsApp messages which say every moment that you're pregnant is a gift, bond with your baby, make sure you eat this to lactate well, make sure you do this to seems to be an expert. I always tell my patients, आप सब्जी जाने को लाते हो तो सब्जी के 2 किलो के साथ 100 सलाह भी लेके आते हो, तो सबकी सुनने की जरूरत नहीं है. You have to ask us and get authentic information from us, because sometimes it had this patient and she used to come with her sister-in-law. They were both pregnant. Vomit 7 times a day. I vomit only twice a day. Does that mean that her pregnancy is better than my pregnancy? I mean, look at the pressures which pregnant women, are facing nowadays. And I think it's very important to counsel them correctly. Make sure that they are not obsessed with getting everything which is correct. And this is what I say about over preciousness of motherhood. Reality has to set in. A reality check really is required for our pregnant women. And it's not only required for our pregnant women, it's also required for all the relatives. I mean, to tell you the truth, that patient whom I said vomiting, that sister-in-law said, well, I never realized that she would take it that way. So I think, this counseling and reality check is very important. We have to also consider about the fact of whether choice is being taken too far when women who are so much menopausal are now getting impregnated. So I'll end with these slides which say that the hallmark of labor management in the 21st century should be individualized care for the laboring woman with the expectation of a successful and safe vaginal delivery, together with the ability to intervene with a cesarean delivery if needed to prevent morbidity and mortality. After all, we need to look forward with hope, not backwards with regret, because at the end of the day, ladies and gentlemen, history is her story too. Thank you very much. I'm very sorry. I think I overshot by around 4 to 5 minutes.
Thank you very much, Jaideep. It was indeed a brilliant presentation, and I think it was also an eye-opener for young obstetricians who are looking at obstetrics differently. And I'm sure Madam Sharma, Usha Sharma also must be very, very pleased, because she comes from an era where the traditional obstetrics was practiced, and you and I belong to an era which is little modified, and the younger generation who are now entering OBGYN are looking at obstetrics very, very differently. Maybe for them, C-section is the norm and vaginal delivery is a rarity. So thank you very much for a brilliant presentation.
I think
Thank you, Dr. Tank. It was a wonderful presentation, but we are also going a stage backwards, considering the younger generation with the high incidence of medical legal issues and the social thing for it. As when we were, we're all 60 plus. At our age, obstetrics was really a part of our gynae practice, and we enjoyed doing our obstetrics. But when you look at the youngsters today, they don't want to practice obstetrics. They are going into fetal medicine, they're going to laparoscopy, they're going into robotic surgery. They do not want to do obstetrics. And I have a feeling that, like in the US, because of medical legal issues, most obstetricians have stopped practicing obstetrics. It's gone back to the A&Ms. Even in Europe, it's gone mainly into the A&Ms. And I think in India, we should not go back to our thais again. We should motivate our youngsters to practice good obstetrics.
and we're going to lose good obstetricians at the way the social media is targeting doctors.
I
Yes,
agree
ma'am.
with you,
That's
Dr.
exactly what I
Chitra,
said
yeah.
about the narratives which are shaping our profession.
Yes.
And because the narratives dwell upon us doing too much or too little in some instances, people are more and more hesitant to take, what were previously regarded as chances. We never take chances. We take calculated risks, looking at the risk versus the benefit. But we have been projected as saying that we take chances. And that's why I think it's very important for us as an association of professionals and as individual professionals to look at the narratives which are shaping the way we do our practice. Thank you very much.
And we do need to do a lot more counseling when we are dealing with our obstetric patients.
Counseling, which he said. But as you very rightly said, in our times it was, the circumstances were very, very different. We always used to feel proud if we get a normal vaginal delivery done. What I feel that afterwards what happened, there was Consumer Protection Act and everything else. And that is why there was a little problem. But even then, what I feel that if an obstetrician is knowledgeable, if an obstetrician is patient, if an obstetrician is vigilant, then they can always plan for normal delivery, but whenever they feel that there is a slightest complication or danger to the mother or the fetus, then they can switch on to the cesarean delivery. There could be clear-cut evidence of doing cesarean section. And as far as possible, we know now there is modern management of and monitoring of labor with e-partogram and electronic continuous fetal monitoring. So we can always wait and watch. So what I feel that Jaideep has really explained each and everything very nicely, though we certainly want to reduce the rate of the cesarean section, but not at the cost of the baby or the baby. So this is, we always should keep in mind. We know that there are complications also with cesarean section. So I will like to congratulate now Dr. Rakhi. She is chairperson of endocrinology committee, and Dr. Sujata Bhatt, president Noida Society, and Anshu Rena, who is secretary, for giving me this opportunity to be a part of such a prestigious program. Thank you very much. And it was so nice that we were having so many stalwarts like Rishikesh Pai, Meera Agnihotri, Shanta ji, and everybody is with us. Mandakini is with us. Ashok Kumar is also with us. It's really a great pleasure to be with you all this morning. Thank you very much.
Thank you, ma'am. Sir, Dr. Shanta ma'am, can we wait for another few minutes and have a USAID project release and then have your oration, ma'am, please? We've got Dr. Alpesh Gandhi also, and right now, and Dr. Jaideep Tang, sir, would you like to do the release now or after the oration?
Whatever Dr. Shanta Kumari wants, I'm fine. If she doesn't mind waiting for 5 minutes, it will take 5 minutes. Whatever you want, Shanta.
You all take the call.
Okay. Right.
As it is, I wanted to finish, and unfortunately, because of the technical glitch.
No problem. I think Dr. Alpesh Gandhi needs to leave, Shanta. So we'll take the opportunity when he is there, and we'll do this. We'll do it very quickly. Alpesh bhai, would you like to start the proceedings, please?
Alpesh is here?
Yes, ma'am.
Yeah, he's
sir, we just saw him.
Yeah.
Welcome, Dr. Alpesh.
Welcome, Dr. Alpesh Gandhi, sir. He is the president, FOXI.
Hello, Alpesh. I never knew that you are with us. Thank you so much to be with us.
Madam, I have just joined, so you are not knowing. It's my side that not your problem, my problem.
Okay. God bless.
Thank you, madam. So, thank you very much for accommodating me, Dr. Sujata, Dr. Rakhi, Dr. Ansu, Noida team. So can we start, Dr. Jaideep, for this?
Yes, please. Alpesh bhai, if you could give a brief introduction, Abhilash will then show a couple of slides, and then we will round it up by asking the president and secretary of the Noida Society for their concluding remarks, and that should be it, really.
A very good afternoon to all of you. I'm thankful to Noida Society for accommodating this project in your annual conference, giving us a few minutes to represent this project in this annual meeting. We all know that India is the youngest country of the world. About 21% Indian population is adolescents. Since adolescence and teenage is the most important age in shaping ideas and attitudes that will form the base of healthy and happy adult girl and women. Recently, Foxy has celebrated August month as the Adolescent Healthcare Month. We had organized a Community Connect program on 10th of the August, which was attended by 1,21,000 girls and boys across India. But the most surprising part was we have received nearly 10,000 questions, queries, and comments. This shows that they have many queries, many problems, but they do not find a proper, a knowledgeable, a faithful platform for interaction from where they can get solutions for their problems. They need confidentiality. Foxy promotes, advocates, and works for preventable adolescents healthcare education, adolescent contraception, dedicated adolescent clinics, and many more issues related to adolescents health, and of course adolescent health helpline services. On 29th February, Foxy has made a historical MOU with USAID at Delhi to work on all such important issues. We all are excited to work with USAID. Under this MOU, we can say at the beginning we have selected 4 societies, Delhi, Noida, Gurgaon, and Raipur Society. We can say this is a pilot project. I will not go in detail of this project. Dr. Jaideep and Abhilash and team USAID will inform you about the project in detail in few minutes. I am thankful to Dr. Santa Kumari, President-elect, for allowing me before her scheduled oration. Once again, I am thankful to Noida Society, USAID, Dr. Jaideep, and all the viewers for accommodating me. With this, I hand over to Dr. Jaideep.
Thank you very much, Alpesh Bhai. Abhilash, could you make your brief presentation, please? Abhilash is part, which is a USAID project to look at healthcare in the private sector. And he will briefly be talking a little bit about the project, which we had rolled out a few days back, but this is specific to the Noida Society. Abhilash, please. Abhilash, you'll have to unmute yourself. We cannot hear you.
Yeah, can you hear me, Dr. Jaideep, now?
Yeah, we can hear you. Thank you.
Sorry for that. Yeah, I was saying thank you, Dr. Alpesh, Dr. Chandakumari, Dr. Jaideep, Dr. Sujata, Dr. Anshurana for this opportunity. It's indeed an honor and very exciting development for all of us to partner with Foxy, and especially with the 4 chapters you have opted for to be part of this pilot initiative. So I represent, I bring with me greetings from United States Agency for International Development. I am part of the SHOPS Plus initiative. So SHOPS is the acronym which stands for Sustaining Health Outcomes Through the Private Sector. This is USAID's flagship program on private sector health, which is implemented across multiple countries around the world. So I think, as Dr. Alpesh said, there are 3 elements essentially. We plan to have this engagement, pilot engagement, between September 20 to June 2020. We hope to increase access to family counseling through 500 private providers in these 4 cities. We hope to, increase provision for adolescent and youth-friendly services, for which, the Foxy guidelines will be revised to accommodate some of the emerging best practices. And this would be a pilot with 30 clinics to test the guidelines. So eventually, the vision is to scale it up. We wish to, transition the helpline as well as embed adolescent and youth-friendly services across the Foxy members across India. So an ambitious vision which starts with a pilot. So what exactly we will do in this initiative is we hope to offer guidelines, job aids, communication materials and tools that can help doctors, individual doctors to counsel better. And we hope to complement your efforts with patients. We have an helpline. The number is mentioned here. There is a chatbot. I was very fascinated to hear Dr. Jaideep talk about, Newton's fourth law, that increasingly there is a reaction in the social media that happens. So we really want to, leverage the power of the social media. We already have a very state-of-the-art chatbot. Like you see the poster here, we had Facebook live sessions conducted with some of the doctors, and we hope to increase it more with some of the participating doctors. A lot of in-clinic communication materials are being developed, QR code based videos and games, especially when patients are increasingly wary of touching anything. We want to, shift some of the patient engagement to the digital arena. And we hope to create personalized videos of the participating doctors. So patients can, just scan it at the patient waiting area, and it will lead to a personalized video of that provider. In addition, a lot of other counseling aids are being developed. These counseling aids are based on adaptation of proven counseling strategies. So just wanted to highlight, like as we come to you, this is an important initiative, the helpline, which is again in a partnership with ISON, which is a leading BPO service. So it's a helpline which is operational between 9 a.m. to 9 p.m., 6 days a week, Monday to Saturday. We have 6 counselors, and the model has been created with a view to scale it up to 100 counselors. So we have that support commitment from the ISON senior leadership. The helpline has both provision for inbound and outbound calls. So if you receive some calls, courtesy your referrals, and they want some method, we will be able to refer them back to you. So we have a protocol in place in which at least 3 or 4 outbound calls do happen for anybody who's interested to adopt a method. The helpline, interestingly, is also integrated with the chatbot, the Kulke, app, which is again an app on containing SRH information. It is further linked to our Facebook initiatives called 50 Shades of Wish, interestingly to attract young people, and Khushiyon Ki Shuruaat is also about, contraception. So if this sounds interesting, our request is that, please, type in your name, phone number and address in the chat box. We'll be happy to meet with you. Our team will meet with you in person to take you through some of these, details. And please do start referring patients to the helpline. My team here who are attending it as part of the attendees, we have Ashok, interestingly, who is based out of Noida. So Ashok is the director of operations and leads a team of around 8 people who will be, fully involved in this initiative. And we have Mr. Kulbhushan Singh, who is the regional manager, who also will be meeting doctors in Noida. So looking forward to your support, and thank you so much for the opportunity today.
Thank you very much, Abhilash. I would like to specifically mention Dr. Shanta Kumari, who gave a very nice presentation the other day during the launch. And I see that Dr. Madhuri Patel is also here. So thank you very much for staying, Dr. Patel. Your support will be very important for this initiative going forward. I will now hand it back to the Noida team, Dr. Sujata Bhatt, Anshu and Rakhi, to conclude the proceedings of this. And I would also like to thank all 3 of them very much for their wonderful and brilliant support and accommodating this part in the presentation. Thank you, Shanta, again for waiting. And as promised, we have wrapped it up in less than 10 minutes.
Jaideep, I just wanted to know, FOXI has come up with the various guidelines for standard practices for the obstetric complications.
Madam.
Will you like to tell about that website, or you can just send us afterwards?
We will send it, madam, surely. Thank you. Thank you.
Thank you. Thank you very much. We are actually very truly privileged to be part of your pilot project, and we definitely would make sure every member in our society is aware about this, and we will make sure they all get the helpline numbers. The helpline number is given to all of them, so that individually each one can do their bit, so that the entire society can progress towards your goal. Thank you.
Thank you so much.
Rakhi, you're on mute.
Noida Society, we are always there for FOXI, and we are going to work in alignment with the FOXI projects, all the projects, one and all, including USA project, which is the pilot project right now. We are always there, and we'll encourage all our members to be in line with it. Moving on ahead, I would like to thank our Alpesh Gandhi for taking out his valuable time for coming down to Noida Society, and Dr. Jaideep Tang and Abhilash for this USAID project, sir. And moving on ahead, much awaited oration which was stopped, and we are back again with Dr. Shanta Kumari for her oration, and I would like to call back my chairpersons for the oration, Dr. Mandakini ma'am and
Meera and Alka.
Dr. Meera, Dr. Meera ma'am and Dr. Alka ma'am. Please, Dr. Shanta ma'am, if you could kindly share the screens.
Thank you. I'll share the screen. If there's a problem, then you have to share.
Yes, ma'am.
Yeah. So welcome Shanta again, and thank you for your patience, and thank you, all the attending the USAID.
Ma'am, it is in blank.
Slides nahi aayi.
No.
Nahi aayi, ma'am. I'll share it.
Wait 1 second. I think I'm able to.
Better.
Wait, I will share. What has happened?
Thank you, Santa Kumari, and thank you all. I will have to leave. Please allow me.
Thank you, sir, for being there for us.
Thank you. Thank you. Thank you.
Yes. Bye,
Dr.
Alpesh.
Gandhi.
Bye.
Thank you.
Thank you, sir.
Can you see the screen now?
Yes, done. Finally done.
Wow.
Good.
Thank you, sir, for joining us today.
So, thank you very much, Noida team, and I have to apologize to my chairpersons and everyone. So, what I have understood today is we need to understand the principles of electricity, the protocols for sharing, and practices of delivering a good oration without any glitches. That is the central paradigm of any webinar. So that is the best way I think we need to look forward. So friends, as obstetrician gynecologists, what is it that we're looking at? Is it only achieving the best of being an obstetrician gynecologist, or like how Rishikesh has told the best endoscopic surgeon, or how Jaideep Tang has told that to be the best, what do I call, obstetrician who does no cesarean section? I think the most important is first do no harm. So you have to be your best towards your patient's health and to achieve a state of complete physical, mental and social well-being. So we need to understand that first we should not do any harm, even if we cannot give the best to her. Friends, all of you know what WHO has been saying. Of course, in the present scenario, we are not very happy with what the WHO is doing, but the statement that being a man or a woman has got a significant impact on health as a result of both the biological and gender-related differences. Who will know it better than obstetrician gynecologists? That being a man has got a significant impact on the as a result of both biological and gender-based differences. Women are always often at a disadvantage. Well, when you look at this, the health of a woman signifies the health of the whole global society. This makes me remember what our late Prime Minister Shri Jawaharlal Nehru had told. If the woman of the family is healthy, the family is healthy. The family is healthy, the village is healthy. And if the village is healthy, the state is going to be healthy and the nation is going to be healthy. And who knows it better than us obstetricians? And we do understand that the woman has got a great role in maintaining the well-being of the communities by giving birth to a healthy child and taking up their upbringing. Because once she brings up a child who is going to be an effective citizen, we know what it means to the country. Now, what is the response of a healthcare policymakers? Well, when you look at it, is it only providing the world-class healthcare to our women? Friends, you remember in January, our Prime Minister, Shri Modi ji, has actually talked about contraception. See, when a healthcare professional, when the policymaker, when a Prime Minister talks about contraception, that shows that it matters to the policymakers to think about women's health. And that will actually make them realize that they have to optimize the resource allocation and usage. And looking at our organization, Foxy, we know we have to define our standards at par with the world, and we need to work towards the well-defined goals. The health systems and policies definitely play critical roles in determining how health services are delivered and used, and obviously that is going to influence the health outcome. We have just seen the simple launch of an USA program, Adolescent Friendly Clinic. Now, we may be wondering why we have to talk about that, why we have to introduce that in Foxy, why do we have this collaboration? This is the way to a better health. When you have a healthy adolescent, obviously you have a healthier woman or man who grows up. So friends, this SDG goal, Sustainable Development Goals, number 1 to no poverty, to zero hunger, to good health, well-being, to quality education, and the most important is the gender equality. Number 5, which is the core of our obstetrics and gynecology. And 17, partnerships for the goal. That is what is essential for us to attain the SDG goals. So right from the agriculture and food security, which are the cornerstone of nutrition, to the goal 5, when the woman will control the family income, she will actually decide that what is that which is very important to the family. As the mother, she knows that she needs to allot enough resources for the nutrition, and that will go a long way for the child's health, nutritional improvement, and then that will lead to a higher GDP and a better society. So this sustainable development, where the environmental aspects, the economic aspects, the social aspects, all 3 of them put together, they are responsible for whatever advances we make. Now we're talking about the evidence-based medicine. We are looking at the patient concerns, we look at the clinical expertise, the best research evidence, so that we can roll out evidence-based medicine. But friends, this EBM also has another meaning, experience-based medicine. Now we would have seen all our seniors have actually rolled out fantastic experience-based medicine over the generations, but they may not have had the best research evidence, but it was the patient concern, the clinical experience did give the experience-based medicine. But we do understand you need the best research evidence to have an evidence-based medicine, but don't deny that experience-based medicine also has some role in your practice. So friends, when you have good principles, you can make protocols, and when you have the protocols, your practices improve for the better. Let's just look at this simple case, GDM, very close to the heart of many Foxians. A simple patient is carried up to living room, an abortion one arrives in the labor room at, she doesn't know whether she's 8 months or 9 months, over distended uterus with the fetal heart difficult to be heard, and then she's in labor. She has not been booked for ANC. Now we are in a dilemma. Is she a term? Is she a preterm? Is she a polyamnios due to GDM, or is there an anomaly? Well, that is the difference between theory and practice. Theoretically, we would have wanted all the women to have had regular ANCs, to fit into a protocol so that by the time she comes to the labor room, everything is in black and white. But that is not the reality. That's the difference between theory and practice. Lack of understanding the value of theory within medical practice. This theory-practice gap. And the gap is a metaphor for the dissonance between the desired learning and the demonstrated learning. This gap is which has to be addressed. Now, is there any guideline to handle that patient? Can I say, no, I'm not going to treat her because there's no guideline. She did not come for ANC. She has never reported for any ultrasound. But then, well, we can't. Can we make guidelines for women who have remained unbooked till labor? That will mean we are endorsing this condition. So this is the dilemma when you want to really have protocols and only evidence-based practices. So we need to see where is it that this theory and practice interact. It is the care, which is a first principle in medicine. And the first protocol in labor is to ensure the maternal and fetal safety. That is the basic core. And practice, you definitely have to use your knowledge in theory, do the best for this pregnant woman, You have to anticipate the problems, the prematurity, the PPH, malpresentation, and do whatever best is possible. When I had the technical glitch, my friend said, you should have sent the presentation before. Then I said, yeah, probably maybe I should have, but then we have not. That doesn't mean that we are going offbeat, but that is what experience is going to tell us how to utilize and technical glitch, even if we are only handling a webinar. So also we need to look at the way we practice. So friends, we know that we have to be very careful, do no harm, beneficence, non-maleficence, justice and autonomy, and well, evidence-based, reasonable practice, feasible and practical. We have just heard a very simple statement in the cesarean section talk. Dr. Tang has told how that there are few states which have got a high cesarean section rate, and there are states where the cesarean section is less than 5% in our own country. So that is making the overall cesarean rate of the country quite okay. But then, is that reasonable? We would have preferred to have a better cesarean rate in those places which did not have, and probably a more reasonable rate in the other places. So, but what is practical? We can't have a less than 10% or 15% because we need to address the maternal morbidity and mortality. So friends, the clinical guidelines, the Institute of Medicine, which says statements that include recommendations which are intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of an alternative care option. This is the consensus report. Then, what about guidelines? Now everybody is actually very drastically and desperately looking, I want this guideline, I want to look at that guideline. Established professional bodies regularly develop guidelines. For example, you take the WHO, the NHS, the RCOG, the ACOG, the SIGN, the Royal Australian New Zealand College, and our own FOXI and ICOG. So the professional bodies regularly develop guidelines for practice based on the review of literature by a panel of experts, but it should be applicable for that population where you're making a guideline. I may like the NHS guideline, we may like the RCOG guideline, but it may not be applicable to our Indian population. So I would prefer a FOXI ICOG guideline because it takes into account what is needed by our patients and by our doctors. So that is the importance of finding a guideline which is an apt. So friends, when I took over as the ICOG chair, I realized that these principles, protocols are very essential for our practices. We decided that as a college, we need to reach out. We need to see what we can contribute to the medical education standards. Of course, to update the materials, the practical applications. Well, if we can attain the global uniformity in standards, that's fantastic. But at least it has to help us to build a stronger healthcare system for our own set of population, our own Foxians. We have 400 plus medical colleges with lot of professors, assistant professors, and registrars. If we can involve them, if we involve the medical colleges where the postgraduates are there, catch them young, instill the ethos for research and practice balance. Well, friends, we just heard how the younger generation are not very keen to take obstetrics forward. Maybe what the country needs, maybe in the future, is not anymore more of IVF specialists or endoscopic surgeons. We are going to have a shortage of obstetrician. Who is going to take care of our mothers? Who is going to deliver the next generation? So we need to have a system which is going to help the community at the grassroots level. That doesn't mean that we shouldn't do IVF or endoscopy, but we should not leave the core of our obstetrics and gynecology. We are looking at the pyramid of evidence. Well, we may have a lot of background information, and yes, what do we have always? Expert opinion. Everyone is an expert. Taking from me to my assistant, to my postgraduate, to anyone in my Hyderabad society or anywhere in the India. Everyone is an expert. When they have a degree, we think that what opinion we have is the best. Then we go a step ahead. We have this case reports and case series, and then the case control studies. Then come the cohort studies, the randomized control trials, clinically, critically appraised topics, systematic reviews, and meta-analysis. So we have got a lot of unfiltered information and filtered information. But 20 years back, I never used to understand what all this meta-analysis, systemic reviews, Cochrane data, and I was doing my post-graduation. I used to wonder why we have to do all this. But friends, we do understand that this is what is going to give us the evidence that what we are practicing is the way forward. Sometimes, unfortunately, we may have too much of evidence. So finding evidence is the first step. Trying to amalgamate the evidence, which may actually confuse you, is the most important thing. Everything seems right, but everything cannot be implemented. For example, we have just talked about the gestation diabetes. Let's look at the American Diabetic Association. They have given a big screening for the gestation diabetics, like all the screening for GDMs, and then the one-step diagnostic tests and everything. Then the IAD, PSD, they have their fasting 1 hour, second hour, they have got their values and cumulative, and the National Institute for Health and Clinical Excellence. Now, then the dilemma is, now which one do we follow for screening gestational diabetes? The universal testing versus the risk assessment, one step versus the 2 steps, cutoff values. We have been having this dilemma right from the time I was a postgraduate, and now also still some people have a dilemma, but we are almost able to actually come to a consensus. Then FIGO decided, the HIP group amalgamated all the evidence. So FIGO adopted and supported this, and they came out with a position that all pregnant women should be tested for hypoglycemia during pregnancy using a one-step procedure. And FIGO encouraged all countries to ensure universal testing of all pregnant women for hypoglycemia. And they recommended universal testing based on the magnitude of the problem and the magnitude of not doing the test. There are a lot of options for diagnosis of GDM. Fully resource settings may have something where they can do everything. They can do a fasting, they can do a random, they can do an HbA1c, they can do a 2-hour 75 grams OGTT. Then there may be a fully resource settings with ethnic population at high risk. Then we have to look what is it that we can do, or a basic setup where there are a low resource setting. So maybe they can't do everything. So we have to give them something simple, but at the same time, which is going to give them the correct data and the correct way of reaching it. So friends, though we may have guidelines, we always have to look at alternatives for the real world. While this is the optimal recommendation, alternatives are given in acknowledgement of the limitation faced in the diverse settings. It may be finances, it may be human resources, it may be infrastructure resources. So any guideline has to be conscientious, explicit, judicious, and reasonable. We cannot be unreasonable. Sitting here, I cannot say, in my corporate hospital, I may be able to do everything. But if I go to a village which is in the interior of Adilabad, where it's very difficult for even an MBBS doctor to reach, I can't have the whole setup of this in that. But that doesn't mean I'm not going to give care to my pregnant woman who is going to deliver there. So if I can take something simple there for that woman, so she may have a reasonable amount of evidence-based management. That is what is needed. So friends, evidence-based medicine, what it is and what it isn't. Definitely a conscious, explicit, judicious, reasonable use of modern best evidence in making decisions. And this was reported way back in the BMJ in 1996, almost more than 20 years back. But still, we need to always remember it, because the evidence-based clinical practice guidelines, look at the current practice, see the guidelines, and then what's the best practice. So that is where you look at adapting the CPGs to local practice. Objectivity and subjectivity, well, we have to look at all the different sources and then be judicious and reasonable. So friends, adapting whatever may be a clinical practice guidelines to your local practice is what is important. You read, you hear. I remember Rishikesh telling me about 4 months back, now what do? I'm getting very bored sitting at home. He said, now is the time for you to read. You try to read and know what is happening. So when you read, you get a lot of information, and then you can try to adopt what is important for you and develop it. so that we can use it for the better practice in our setup. So friends, we have to adopt the new age technology in OB-GYN, technology in gynecology. You take preventive gynecology. Some decades back, we were talking about CS cervix, but now we know that vaccination of the HPV is the most important cornerstone in treatment of this CS cervix. So that preventive gynecology. Take contraception, that is very important. Adolescent gynecology. Take it, you have to accept that you have to evolve to have a better practice. So many, be it maternal health, be it urogynecology, be it fetal medicine. But always the no-do gap, so that your theoretical and practice gap has to be filled. The theoretical practical gap is not only real, but it results in diminished patient care and inefficient clinical practice. We may read a lot of things, we may hear so many things, and we may not be able to actually put all that in a practice in a low resource setup. But if we can try to do what is doable in that setup, we may be able to offer better healthcare. And it also results in failure or excessive lag time in incorporating or deleting the clinical practice based on the current evidence. When I was the ICOG chair, then I decided let us redo one thing, the induction of labor. We have got the NICE guidelines, we have got the ACOG guidelines, we have got so many committee opinions, and then we have the different FIGO guidelines. And when I looked at all of this, then I started wondering, what is it that our Foxians, what is it that our Foxy and ICOG can do to make this one topic, induction of labor, very simple for our practice? We may have so many methods of induction of labor over the generation. Induction of labor is not new. It has been there before I was born, and it will be there after I'm gone. But if we can simplify this and offer a guideline where we have read all the guidelines and we have developed it, adopted it for our setup, and then come with a good clinical practice recommendation. So that is what is needed. So problems are not there which can be just ignored. Problems are solved, but not only by giving new information, but you have to arrange them in a proper way, what we have known since long. See, you don't have to reinvent the wheel. Sometimes you may have a lot of guidelines. When you look into our own government guidelines, they're fantastic guidelines. You can go and read it. You need not reinvent the wheel, but take it and then you come out with what is appropriate for our people. Make it simple and doable. So gain new knowledge by reviewing the old, adopting it and simplifying it. That's what we did with the induction of labor. We recognized the need. We had a core working group. We had a review of literature, review of practices, multiple deliberations, the final draft, which was the methodology. So the general conditions, where the induction of labor to be performed, which method to use, and which patient to be induced, and what are the medico-legal aspects. Now, once we form a guideline, that's not the end of the story. We have to review it every 3 years or every 5 years, because change is happening fast. And only when we actually keep this principle of trying to change and upgrade our protocols, we will not be able to reach the best practice. Now, oxytocin titration for India, this is a very simple thing. See, we know a lot of times that how 1 ml of oxytocin is having. We have seen some mishaps happening when somebody has, okay, put 1 unit, we have seen people have put a 1 whole ampule. So if you have a simple oxytocin titration for India in your labor room, where everyone can see it, your nurses can see, your ANMs can see, your juniors can see, then there's no confusion. You know exactly how much is 1 unit, how much is 2 units. So that will create the unnecessary problems which can happen. So unless we adapt, friends, much of this gap is actually existing by default, related to the lack of awareness by clinicians, the theory that guides their practice. The primary failure within the theory, the practice gap, is not simply recognition. It's the lack of incorporation of research within the current medical practice. So let's take this fetal medicine, which is improving perinatal health and reducing maternal morbidity and mortality. Screening well, ultimate goal is better fetal health, a better tomorrow. We have had the fetal NT scan. We know that is important. And better screening for aneuploidies And we came across then the cell-free DNA, the fetal aneuploidy screening methods. We know we have advanced to a better, this NIPT, the new protocols, which actually put the patients into low and high risk. So we can, by redefining the protocol, by changing the practices, we have better perinatal outcome. We had Doppler, we had ultrasound, and then we moved on to Doppler. How we could actually pick up the impaired placentation, we could predict PIH and reduce the maternal mortality and morbidity. So expanding the protocol for second trimester scans. This change in practices for benefit of better perinatal health is very vital. So we know that if you do a Doppler, is it only for the sake of doing a Doppler? We can time the delivery, we can improve the outcome, we can prevent the stillbirth and intact survival. So what is it we are looking at? More sophisticated, intensive strategies for screening of aneuploidies. And friends, this year we have seen a pandemic actually took us off guard. Unprecedented effect on the global health scenario. As healthcare professionals, we were challenged like never before at using the principles discussed before. We made new protocols and continued with practice in the COVID era. We have to congratulate our Foxy team, our President Alpesh, the whole of the team, Atul, Parikshit, and all of us, and Jaideep Tank and rest of us. We were one of the first organizations which we came up with a Foxy GCPR, which we redefined, and then came this FAQs for pregnant women. So we gave something for our Foxians to read so that they could adapt these protocols into the practices now with the pandemic in place. So unless we adapt, the challenge, the no-do gap, how is it that we're going to overcome this problem? In the month of March, first week, we never knew. We knew that there was some COVID, some coronavirus, but we never thought it will come and strike us so hard. So this bridging the gap between theory, research, and practice is very essential to bringing innovation from medical research into practice application by practicing doctors. So making practical guideline is very important. Information has to reach the target audience. Now see, we have evolved from conferences, CMEs to these webinars. Maybe it's not as good as trying as when you meet people in person, but then when you can see people even virtually. One of my colleagues was commenting, look at Usha Sharma madam. Madam is looking so bright, and when you look at her, we feel when we also get energized. So that has happened even in this pandemic because of this virtual platform. So conferences, CMEs, webinars, well, the drills, the workshop simulators. We've got the advanced life support in obstetrics, which is very dear to our president's heart. The obstetric drills, a simulated obstetric emergency as a facility, which is allowing the midwives, nurses, physicians to maintain knowledge, build skills, and develop teamwork. But that doesn't mean that we advise our patients to use a YouTube to deliver their wives. But this could be used as a medium where we improve or update our skills. We take PPH, so many interventions. 22% is preventable, but how many are well versed in all these drills? So if we keep doing these drills, then we become better. The TOG conclave, the algorithms are very simple. These are doables. You have those algorithms, you have a doubt. You quickly gaze through it and then you know what to do. Standard operating procedures. Writing the SOP is very important. It will actually allow you to standardize your procedure, get started quickly, provide fast, easy answer to a common SOP. And that template will actually communicate to everyone, and then they can use it in their practice. Now, clinical audit. 15 years back, when I used to hear about this audit, somebody used to talk in the conferences, I used to get very irritated. I said, what is all this audit business? The auditor is anyway going to take care of our audit. Why we also have to sit and do our audit? But now we realize clinical audit is a process which is very important for the quality improvement process. Now, the government has told, use the Robson criteria. The Robson criteria, when you open, sometimes, it looks very difficult. You'll wonder, oh God, how can I do the clinical? But the simplified version, once you have, it's very easy when you can put your patient in that criteria. And your audit is there, very simple for you to understand and very easy to tell if somebody questions your cesarean section rates. Well, friends, you need to know what are the clinical questions to ask, how to find the best practice, and how to critically appraise the evidence for validity. Experience definitely complements evidence. Good doctors use both individual clinical expertise and the best available external evidence. Neither alone is enough. So without current best evidence, practice risks becoming rapidly outdated, which can be detrimental to the patient. So the best evidence is the one which must be applied by the clinician with expertise in considering the patient's unique values and needs. So good practice, enhanced patient satisfaction will come when there's a good clinical outcome. So you have to evolve, you have to learn. A satisfied patient is the biggest reward to a clinician, and improving practice at individual level will definitely increase the patient satisfaction. But standardizing such practice will improve the healthcare scenario of the whole country and will contribute to the global health. So friends, when you look at the SDG goals, which sets where you need to have global partnership, once you have the global partnership, that will lead to protocols which can be applicable to the women's health. So you have to review your present scenario, devise effective strategies, build a string of framework for good clinical practice. So principles followed by protocols into your practice. The way to get started is to quit talking and begin doing. So friends, definitely India is moving ahead in women's healthcare. Global partnerships are there, and we have seen even in this webinar, the unique partnership of the US aid with FOXI, which is taking one step forward to our adolescent health. So what we have to always say is we have to welcome the future. Your future hasn't been written yet. No one's has. Your future is whatever you make it. So make it a good one. That should be the idea of what we need to look at the health of a woman. Thank you, friends. And I think now we are going to become experts in the principles and practices of even technical know-how. Thank you, madam.
Thank you, Shanta Kumari, for that wonderful and very exhaustive presentation, taking us through principle, protocols and practices. So beautifully explained. And I think so many delegates are already, attending, and they will definitely like to observe this principle of, especially I like that you have to adopt to the local, local requirements. Because suppose we are having this postpartum hemorrhage, you said, we know that so many people have devised, even in Shivkar's pack, it was devised in Kama hospital that time, and it proved to be such a wonderful, invention. For a very simple condom was used. Similarly, you attached upon the this SDG goals. We are going to have this SDG goal. FOXI is already achieved in way 1 minute. Hello, I'll talk later. So FOXI has already taken that. Jaideep has beautifully said that we have come down to the maternal mortality, and what were the causes everybody knows. Similarly, for this, policymaker has got a very important upon the core of the practice is a finance. Unless you have a finance, budgeting and the supply, everything, we are not going to actually reduce the maternal mortality unless until you have so many things. Second thing which affected me is the adolescent clinic. Today there is an inauguration, Noida societies all implementing it. There is a huge need for the adolescent clinics. And I remember Maharashtra was the first state when I was the deputy director. That time we started the clinics in the all district 33 district hospital. But there is a need, huge need in the private sectors also. So I think with this wonderful presentation, oration, Shanta, and thank you very much. I will hand over mic to my co-chairperson, Dr. Meera Agnihotri, and I take this opportunity to wish Usha Sharma Madam, Meera Agnihotri Madam, Rakhi, thank you very much for inviting me, Anshu, and all the organizing committee for this wonderful opportunity and giving this opportunity to chair the session of a great person like Shanta Kumari. Thank you very much.
Thank you, Dr. Mandakini ma'am.
Meera
ma'am, you are muted. You need to unmute yourself, Dr. Meera.
Is that right?
Yes, ma'am.
Thank you, Shanta, for a wonderful presentation, wonderful oration. I agree with you with each step. Do you remember the conclave at Hyderabad? Do you remember the conclave, Rakhi? You must also be remembering when we were there at Chennai, Mahabaleshwar, and we have sorted out a number of guidelines. And they are, I can tell you that they are just Bible of our younger generation. My residents, my registrars, they are keeping us there. You see, obstetric Bible. Preterm labor पढ़ना है तो जल्दी जल्दी पलट के तीन guidelines. So I congratulate you, and I also once again tell you that World Diabetic Foundation has selected myself as one of the pioneer pilot project holders for this one-step test, which is being guided by the FIGO. So we can have more of them. Regarding our partnership with the government, we understand that each and every patient, whatever guideline we may make, differs. Shanta, it differs. If I'm practicing at one place where there is hardly any place to do episiotomy, my guidelines will certainly change. If I'm working in a center at the medical college where I am practicing, then my guidelines may be slightly different. It all depends upon the supporting system also. So we must train our graduates and undergraduates that these guidelines are made to support you. If they are not just to criticize, I cannot do, so this patient must be referred. I cannot do, so this patient must be referred. And by the time this patient reaches the hospital, where you expect that all the guidelines are there, the patient may die. So you have to just alter, tolerate, and modify your guidelines, which are taught. The basic guidelines must not change, but you must try to tackle each and every patient wherever you are practicing. That is one thing very important. Shanta, my W Foundation will always welcome you like this, because our partnership with the government will work a long way. Mandakini, I'm very happy that you agree with my suggestions and making these teaching modules for our younger generation, and they will go a long way. So at the end, congratulating our President-elect again. Shanta, you are really a wonderful orator, a wonderful person, and an academician. In the end, President Sujata Bhatt, Anshu Raina, and Rakhi Singh, it's very, 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 lovable to be with you, to be with the stalwart sitting over here. I really enjoyed the meeting, and I can tell you the very words spoken by the President and the Secretary in the Rakhi. It was difficult for anybody to tell, no, I am involved in this meeting or that meeting. This is the first meeting for which I can sacrifice any meeting. Thank you, Rakhi. Thank you very much.
Thank you, ma'am. Thank you all the chairpersons for kindly consenting and doing the honors, ma'am. We are very much honored to have all of you over here with us. Moving on ahead, before that, I would like to thank Dr. Shanta ma'am for a wonderful oration also. As it is always, she is at the trying to be, and she is always the best and the powerhouse of energy.
Thank you, Rakhi. And I think there was that small glitch. I should have closed it and opened it. It was just a mismanagement. And Rishikesh was telling, no, next talk, next talk. So I think we should keep our protocols in place in the brain. So we should not get disturbed and actually go ahead. This is what I learned today in my technical glitch. So friends, always remember, so practice and experience will make you an expert in handling glitches.
It was very nice.
Thank you. Thank you, Madam, and thank you, Sujata.
We are more learned with all those advices and the glitches. We would definitely keep that in our mind.
Thank you, Ma'am.
Thank you.
Rakhi, 1 minute.
Yes, ma'am.
Thanks, Sujata. Sujata, I have to thank you personally because I just did not take your name. So thank you very much, and all the Noida society. Thank you very much.
Thank you, ma'am, for being there for us. Thank you,
Sujata,
Moving on.
and Rakhi. Okay, bye.
Bye, ma'am. Thank you. Thank you. Moving on ahead, For the next session, I invite my other co-moderators, Dr. Anshu and Dr. Sujata, to kindly take over.
Thank you, Dr. Raki. Now, without further delay, I would like to start my 5th session, that is a debate. And for this, I would like to invite our moderator, Dr. Ashok Kumar. And sir, please start the session. Sir is a Director, Professor, Department of Obstetrics and Gynecology, Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. Sir is a Secretary-elect of ICOG 2122, Member Governing Council ICOG 218-20, and the Editorial Board Member, Indian Journal of Medical Research, and Archives of Gynecology and Obstetrics. Sir, please start the session with the 2 speakers. Please, sir.
Thank you, Dr. Anshu. Am I audible?
Yes,
Hello.
sir.
Am I?
Yes,
yeah.
sir.
So,
Yes, sir, you are
thank
audible.
Yeah, thank you. And good afternoon. At the outset, I would like to thank the organizers, Dr. Sujata Bhatt, Secretary of Noida Society, Dr. Anshu Rena, President of Society, and Dr. Anshu Rena, Secretary of Noida Society, and Dr. Raki Singh, who is the Chair of the Endocrine Committee, for giving me this opportunity to moderate this debate. And in the presence of my seniors, respected Dr. Usha ji, Dr. Meera ji, Dr. Mandakini Madam, Dr. Shanta Kumari, Dr. Jaideep Tank, Dr. Parag, and Dr. Rishikesh Pai. So I start with this hot topic which is there, and there is a controversy about giving corticosteroid before elective cesarean. What I have come across that people, obstetricians are giving steroid before elective cesarean, but in some of the centers it is not being practiced, and more or less there is no uniformity at the moment. Some people have recommended the guidelines that yes, it should be given. It has many advantages. It has beneficial effect on the newborn, but long-term effects we don't know. So we have this debate, and we have two young ladies, faculty member from the Medical College of Delhi, who will be discussing this controversial topic, and let's see what we come out as a conclusion at the end. And first we start with Dr. Niharika Dhiman. She is Associate Professor in the Maulana Azad Medical College of New Delhi, and she will be talking for the motion. So Dr. Niharika, you can start now.
Thank you, sir. Thank you for the kind words, and congratulations to the Noida Society for organizing such a wonderful program. And I would like to share my screen.
Yeah, it's good to see 2 vibrant young obstetricians going to do the debate. We're just waiting.
Yeah, ma'am, are you able to see my screen?
No, not yet.
Mr. Jain, please share her screen.
Yeah, you'll have to open ma'am first in your in the background, and then share the screen.
Yeah, I've opened in the background. Yeah,
and
just
down
Touch the green button, share screen button, which is in the center down of your screen.
Yeah, I've done that. I've done that already.
And then you share your screen now. If the PPT is open in the background, if you touch it, share screen, which is the green button down.
Ma'am, I've already done that.
Can you share the presentation, ma'am?
Yeah, I'll have to share the presentation.
Yeah.
Basic. I don't know why this is not working.
You can close everything and restart.
Now, it's not visible still, sir?
No, it's not.
No.
You close your presentation and reopen.
Stop sharing. If you've shared it, stop sharing. And then reshare it again. Because we are not seeing any shared presentation over here. come back to this mode where all of us are seen in the screen first.
Yeah, I'm in that column. Yeah.
Then share screen down, green button, enter.
I've already done that twice
Do
or
it
thrice.
again, do it again.
Again, do it again.
I know Dr. Shantakumari said we should be patient, but should we listen to Dr. Chaya Chawla in the meanwhile?
Dr. Jain, can you take her slide and presentation and do it from your end?
Have the slides, ma'am. Sir, ask for it.
Good afternoon, sir. Dr. Devan's presentation.
Yeah, you can.
Yeah, but I'm not able to script. My presentation. Can I have the email address in the chat box?
Yes, I am giving you.
Either we start with Jaya or we do the panel and then go back to the debate. We could do something like that.
Madam, I think in 1 minute she will be sending the presentation to Dr. Jain and then we can start.
Okay. Okay.
Niharika, have you mailed?
So I need the email address because that email comes from the.
No, that has been given on the.
I have given in the chat box.
It's given in the chat box.
Just see the chat box downstairs on the lower.
Yeah. Yeah, I've got it.
Yeah, just mail to Dr. Jain. Dr. Jain?
Yes,
Hello.
sir. Yes, sir.
Meanwhile, you can take the presentation from Dr. Jaya Chawla also. So in case if she is also not working, then you can start directly.
Yeah.
Yeah, that's right.
Dr. Jaya, you can also mail him the presentation. See the email address in the chat box.
Yes, I'll do that. I'll do that, sir.
Niharika, have you mailed?
Yes, I'm just attaching.
Yes, okay.
Dr. Jaya, I have given in the chat box to you.
Mail? Dr. Niharika?
Yes, sir.
It is mailed?
I am checking.
Sujata, tell the panelist moderator also to mail the presentation.
Dr. Aarti is on. She heard you, I think.
Mine is ready. In the meanwhile, I'll test sharing. I think that will be better.
एक बार test share कर लो. Because if it is not, then you also send your presentation, na?
Yes. It's opening. It's opening.
No, this is the panel. This is the panel discussion.
Sharing so
So
that
the panel test drive. Huh?
Now you can
Yeah,
stop it.
I think
yes.
Please stop this. Yes, otherwise we will miss. Yeah. Dr. Niharika, it is mailed.
Yes, sir. I've mailed it.
Dr. Jayant, if you can
No,
do
I
the job.
am updating consistently. I have not yet received.
Yeah.
Gone from my side, sir. I'll just check once again.
Yeah, I got it.
Yes, please do it here.
Yeah, yeah.
I can finish the panel in 10 minutes because we are already delayed pretty much. If he's taking some time.
Yeah, I am on.
okay.
Yes. Dr. Jain, just start with the first slide. Then we continue.
Yeah.
Oh,
Yes, this one. Yes.
for
Put
the
it on
motion,
the-
yes, this is the one. Yeah.
Put it on the.
Yeah, I am doing it. I am doing it. I am having. Yeah.
Yes. Yes. Thank you.
Yeah.
Dr. Niharika, you can start now.
Yeah, yes, sir. So very good afternoon to all of you, and sorry for the technical glitches again. So yeah, so I'll be speaking on a very pertinent topic, which is corticosteroids prior to elective cesarean section, and I'll be talking for the motion. Next slide, please. Next slide, please.
Yeah, it's on.
Yeah. So what is known? As we all know, do I have the remote with me or? Yeah. That's okay. This slide is okay. So what's known? We all know that the Cochrane logo has been, we feel proud to have the Cochrane logo, which was devised after the forest chart from an iconic systematic review, which was done on 7 randomized control trial by Cordley et al., which was based on the use of corticosteroids in preterm labor, preterm patients, preterm neonates. And the simple intervention, as Shanta ma'am said in her previous talk, how these systematic reviews or how RCTs, change the entire practices. Previously, there were many randomized, these 7 randomized trials were put into isolation, but it was not well accepted by the obstetrician. But, a large systematic review changed the practice, and corticosteroids were later, after 1965, they were used quite, are being used successfully, and they have actually prevented several thousands of premature mortalities and morbidities till now. Next, please. So this is what is known. So what is the issue that we are dealing today? The issue that we are dealing today, we know a subset of patients in preterm where this is a valid point that the use of corticosteroids are definitely going to decrease the morbidity and mortality. But what about babies that are born at term by elective cesarean sections before the onset of labor? Are they more likely to develop respiratory complications than babies born vaginally? Are corticosteroids going to help reduce the risk of respiratory morbidities in these patients? So I'm going to basically talk in motion for this. And basically it will be, the evidence behind this would be a latest review given by Cochrane in 2018, which actually the review was done on corticosteroids for preventing neonatal respiratory morbidity after elective cesarean at term. Next slide, please. So before the previous slide, please. Yeah, elective cesarean section. It acts as a trigger factor. So a trigger factor in what? In increasing the respiratory morbidity. Next slide, please. Next slide. It is a well-known fact that as the period of previous one, please. Yeah. So it is a well-known fact that as the period of gestation increases, the morbidity, the respiratory morbidity should decrease. But if you see in this diagram at 39 weeks, where we actually say that at all elective sections should be done after 39 weeks, the rate of morbidity is high. In the blue graph, if you see from 37 weeks to 39 weeks, if you see, the morbidity is high. The respiratory morbidity or the rate of respiratory depression in neonates born at this period is high as compared to neonates born after 39 weeks. So basically, we are concentrating on this subset of patients from 39 to 38 weeks. Will corticosteroids help them? And I definitely believe that the corticosteroids are going to help them. And we also know that neonates born at term by cesarean delivery before the onset of labor are more likely to develop respiratory morbidity, and the cases of transient tachypnea of newborn are more as compared to respiratory distress syndrome than those born vaginally, which potentially severe implications. And if we compare the ratios, if we compare the ratio of the severity of morbidity at 37 to 36 plus 6 weeks to 39 plus 6 weeks, the morbidity increases is almost 1.7 to 2.4 times. Next, please. Next. Yeah. Even this evidence has even backed up this data. They say this has been, there has been a study in neonatal biology. They have studied respiratory distress syndrome in full-term neonates. Actually, why I'm highlighting the slide is because respiratory distress syndrome in full-term neonates is quite different from that in preterm neonates. Basically, if we see here, the highlighted text here shows that there are three major reasons for term neonatal respiratory distress syndrome, and one of them is the idiopathic respiratory distress syndrome caused mainly in a subgroup which have undergone a selective cesarean section. And if we study what criteria are being taken for considering a neonate in respiratory distress syndrome, then one of the criteria is acute explicit perinatal triggering insult, which may be in form of elective cesarean section. So definitely elective cesarean section poses a triggering factor for causing respiratory distress syndrome in full-term neonates. Next, please. Next slide. Next slide. Yeah. So what is the pathophysiology behind this term neonate? As we all know, in premature neonates, the problem is in the alveoli getting expanded at the time of birth. The alveoli do not expand much, but the pathophysiology is different in term patients who have not undergone labor. So there is a lack of physiological catecholamine surge. There is fluid retention in the lungs. There is also a recent molecular mechanism that has been postulated that shows that predominantly lung epithelium sodium channels promote alveolar fluid drainage are underactive in fetus not exposed to the process of labor. As you know, we all know that traditionally we say the labor, while the labor happens, the baby, squeezes through the birth canal and the fluid out of the lungs get squeezed. But this doesn't happen when we do a cesarean of a patient who's not in labor. So how do glucocorticoids help? Basically, glucocorticoids increase the number and function of these sodium channels. So increases responsiveness to catecholamines and thyroid hormones. So basically, this is the rationale for using exogenous administration of corticosteroids in elective cesarean sections, which forms the basis of giving corticosteroids to these patients. Next, please. So how is our Indian scenario different? What challenges do we face? First is the inaccuracy in gestational age estimation. Most of our patients, they might be coming from remote area. They might not be sure of their dates. And then the second one is limited availability and access to resource required to support high quality evidence-based care. Basically, this limited availability happens in both the extremes. A patient might not carry ultrasound where you cannot rely on her date, you don't have an ultrasound. And the other extreme is the facilities, the neonatal care facilities or the NICU facilities might not be available in certain setups in Indian scenario. Then the second important point is there is an increased rate of elective cesarean sections, as it has already been highlighted by Dr. Jaydeep sir, that it has increased over the past years. The rate has increased from, if you see, it has increased from 17.2 in 2016 to 20% is the recent data. So this increase, why I'm highlighting it here is because this increase will increase the number of elective cesarean sections. And moreover, the second point why there is an increase of elective cesarean section is because we are getting more cases of repeat cesarean sections, maybe 2 cesarean sections or maybe 3 cesarean sections have been done and we have to go in for elective cesarean, or the spectrum or the profile of or the incidence of morbidly adherent placenta has also increased over the last decade. So these are those subset of patients in our scenario which are going to require a cesarean section, and maybe they will require not only a early term section but also a late preterm section, because mostly for these patients we might plan a cesarean somewhere between 34 to 36 weeks. Next please. I am not able to see my slides. Yeah, can I have the next slide? I can't see the screen. Nothing is being shared on the screen. I can just see the logo.
Just
Hello?
Just a minute, ma'am.
Yeah. Okay, sure.
Now you can see, ma'am.
Yeah, I can see it. Thank you. So the use of antenatal corticosteroids before elective cesarean section, what is the evidence? The latest evidence basically comes from these two reports. One is a systematic review of systematic Cochrane review, where a total of almost 4,000 women were enrolled and 3,900 infants were enrolled in the study, which included 4 major trials. And one of the trial is the one which formed the backbone of the ASTIC study. ASTIC study was the first study done for knowing the role of corticosteroids in term elective cesarean sections. So these 4 trials were included in this Cochrane systematic review, which was published in 2018. And the most recent one is a narrative review, which has been published this year only in March. And this tells us about the antenatal corticosteroid administration for fetal lung maturity. So various aspects have been covered under this narrative review, which elaborates the use and the various expanded uses of antenatal corticosteroid and also addresses the use of its use in elective cesarean sections. Next, please. So basically, I'll be talking about the first review, the Cochrane systematic review. If we see basically the primary outcome studied in this systematic review of 4 randomized controlled trial was the respiratory distress syndrome incidence, the incidence of transient tachypnea of neonate, admission to neonate special care for respiratory morbidity, and the need for mechanical ventilation. These were the primary outcome. There were many secondary outcomes also which studied the length of stay in NICU, the effect on the development of the neonate, late-term infantile morbidity, cognitive impairment, emotional or behavioral changes. These were the secondary outcomes. Next, please. So based on this Cochrane data review, if we see on the right side of the screen, if we see the analysis, there is a forest plot here, which analyzes what was the incidence reduction in respiratory distress syndrome of the patients who got steroid before an elective cesarean section. So we see that in this forest plot, all the 4 studies and the outcome is on the left side of the line. That means they were favoring the treatment. That signifies or that implies prophylactic administration of antenatal corticosteroids appear to reduce the rate of respiratory distress syndrome by approximately 52% and decrease the risk of respiratory distress syndrome, and the relative ratio was 0.48, which is quite significant. Next, please. Coming on to the secondary primary outcome, which was studied, was the transient tachypnea of newborn. Here also, similarly, we see that in the forest plot, the outcome of all the 4 studies were favoring the treatment. That means prophylactic administration of antenatal corticosteroids appeared to reduce the rate of transient tachypnea of newborn by approximately 57%, and the relative risk was 0.43, which again is a significant number. Next, please. Coming on to the summary of these findings, basically, if we see the comparison, we see that if you can concentrate on the red box, we see that in the placebo group, the incidence is higher as compared to the corticosteroid groups. If we see pertaining to the respiratory distress syndrome, 54 to 26, it was reduced to 26. For transient tachypnea of newborn, from 54 to 23. For admission to NICU, from 51 to 23. And for need for mechanical ventilation, from 15 to 10. So there was a reduction in overall incidence as well as the risk of these respiratory morbidities in patients who had received corticosteroids after a planned cesarean section. Next, please. So apart from the neonatal, immediate neonatal outcome, they also studied the maternal and fetal effect. Are there any maternal and fetal effect of these corticosteroids, single dose corticosteroid that we are giving to the mothers before we take them for a cesarean section? No, there are no adverse or fetal effects. This has been collaborated in the RCOG guideline number 7 also. And basically the data has been collected from the Cochrane library as well as these 2 studies which I have quoted here. So they saw that the risk of choriamnitis, preeclampsia, puerperal sepsis and fetal growth restrictions were not related to the corticosteroids which were given to these mothers. Next, please. So another evidence-based study, we saw that the Cochrane review had 4 randomized studies. In another review, they had, along with those 4 studies, they had included 3 other trials, which included 2,498 women undergoing planned cesarean delivery at more than 37 weeks of gestation, that is at term. So they concluded that antenatal steroids at more than 34 weeks of gestation reduce neonatal respiratory morbidity. A single course of corticosteroid can be considered for women at risk of late premature delivery, that is 34 to 36, completion 36 weeks of gestation, as well as women for undergoing a planned cesarean delivery at or more than 36 weeks of gestation. Next, please. So these were the previous slides basically dealt with the immediate neonatal outcomes and with the maternal and fetal effects. Now coming on to something as much controversies, and so much has been said about what are the long-term effects on the neonate. There have been developmental delays and everything. So there have been numerous studies in this. But to choose for a single study, what we need to follow is that the study should have a long-term follow-up. The sample size should be good enough to have a good significant results, and there should not be any attrition of the data in such studies which have to be chosen to come to a conclusion whether there is a long-term effect. So one of the study which has been actually highlighted in the Cochrane review also is the initial study of Liggins and Hovey, who ran the first randomized control trial, and they had a 30-year follow-up. But they ran a randomized control trial on preterm neonates. But why this study was chosen for a long-term effect of corticosteroid the neonate? Because 30% of their sample delivered at term. So basically, it has demonstrated that there is a slight increase in insulin resistance, though diabetes is not as per se significantly associated with the use of corticosteroids. No difference in cardiovascular outcomes in terms of raised blood pressures, hypertension. No adverse effects on postnatal growth or lung function. There were less developmental delay and less cases of cerebral palsy in this group. Psychological development was also comparable between both the exposed and the unexposed infants. Even a subset of 192 of these offsprings underwent psychological testing, and no difference was found in terms of cognitive functioning, working memory, and attention, psychiatric morbidity, handedness, or quality of life. And this has been published in the recent narrative review on 30th March 2020. Next, please. So we've talked so much about the use of corticosteroids in term cesareans before they go into labor. And as I've already highlighted in my previous slide, that in Indian scenario, or maybe, a worldwide scenario also, the rate of cesarean sections related to previous 2 cesareans, repeat cesareans, or morbidly adherent placenta are increasing. And these are those subset of patients in which we might have to plan a late preterm delivery cesarean sections. So what does the data say about these late term delivery cesarean sections? This data has been published in the New England Journal of Medicine in 2016, and is also one of the data reviewed in the Cochrane systematic reviews. And this says that the use of steroids basically decreased the respiratory morbidity in terms of respiratory distress, transient tachypnea of newborn, surfactant use, and the risk of choriamnitis and proven neonatal sepsis was very less. The only highlighting feature here was that the neonatal hypoglycemia incidence had increased. But it has been also said that the neonatal hypoglycemia had increased, but it had no long-term effects in this study. In this study, and they were supported by previous studies in which neonatal hypoglycemia was present, but no adverse effects was seen in the infancy or in the early childhood. Moreover, this neonatal hypoglycemia in our scenario can be easily picked up by simply doing a heel test and testing the random blood sugar levels of the neonate, and it is treatable cause. So basically, steroids can be given in these subset of patients. Coming to the second concern after the steroids, after the use of
Dr.
steroids.
Niharika, please.
Yes, sir.
Dr. Niharika, your time is finishing.
Okay.
Try to
I'll wind up.
conclude.
Okay. So coming on to the dosage of corticosteroids, are we giving the right dose? We are just giving a single course of steroids, which attains the actual levels in the fetus, which are 1 to 4 nanogram per ml for lung maturation, and these are not harmful to the fetus or to the mother. And the risk, basically it has been seen that the risk of this respiratory morbidity increases when we give 4 or more courses. Next, please. So coming on to the cost effectiveness, WHO.
Please wind up. It is like an talk more than debate.
Okay. List of essential drugs is inexpensive and widely applicable. Next, please. Just 2 more slides, ma'am. So basically, yeah. So basically, this is the randomized controlled trial, and FIGO in 2019 has adopted considering the use of corticosteroid in elective cesarean sections before start of labor. Next, please. Yeah, we can skip this slide. Yeah, so to conclude, elective cesarean section predisposes the fetus to neonatal respiratory morbidities. Antenatal corticosteroid reduces the incidence by 50%. The likely benefits as compared to those of delaying cesarean sections until 39 weeks might overweigh in certain clinical conditions where medical indication of termination of pregnancy is required. And there is an increase in rate of cesarean sections. So late preterm and early preterm period is the one where elective sections are going to fall. So antenatal corticosteroid is recommended prior to elective cesarean section at term and also at late preterm. Last slide, please. Last slide, please. Next. Next, please. Last slide, please.
You
So
say the points.
I would end by saying that preach what you practice and practice what is evidence-based. And evidence-based is the use of steroids in any elective section which is not in labor, and you are doing it at term or in late preterm period. Thank you.
So thank you, Dr. Niharika. Am I audible?
Yes.
Yes.
Yes. So thank you, Dr. Niharika. I think we straight away listen Dr. Jaya Chawla also. She is Associate Professor from Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital. And after that, we will discuss about this and try to see what she has to say. Dr. Jaya.
Yeah, Dr. Jaya, please just try to stick to time because I think we are already running almost 45 minutes late.
Sure, ma'am.
Thank you. Thank you. Thank you.
ever since the times of Graham Liggins, with the sheep story, to the Cochrane review on the topic in 2017, we have known that antenatal steroids improve outcome in prematurity. But we have also known that no obvious benefit was found for chronic lung diseases, mean birth weight, death in childhood, neurodevelopmental delay in childhood, and death in adulthood. The question that arose was, does no obvious benefit equate no obvious harm? Do benefits in prematurity translate into benefits at term? The very reason that the biggest success story in the glorious era of perinatal medicine is being debated today is in itself a reflection that the latest kid on the block, the elective cesarean, is perhaps being viewed with a lot of caution and doubt. And that is why I'm here to speak vehemently against the motion. Esteemed faculty members, Honorable Sir, and dear attendees. First of all, before going into the negatives, let us review the evidence on board for steroids in elective cesareans. The Cochrane database 2018 on the subject in itself confesses that the 4 trials that were included had a moderate risk of bias. The quality of evidence varied from low to very low. And given the low rates of respiratory morbidity in this population, these inferences are not really far from the truth. Let us look at the first and these 4 trials that are actually being considered. The numbers needed to reduce even one of those cases is substantially higher. Need for mechanical ventilation and respiratory distress syndrome actually are not significantly reduced. That's the first trial. Let's keep looking at the numbers on the top there. A little over 1,000 subjects here, and this trial was not even associated with a significant reduction in the incidence of neonatal respiratory morbidity. The third trial, a little less than 1,000 cases, and notice the number of candidates going to the nursery for non-respiratory conditions being roughly double in the betamethasone group vis-a-vis the control group. Also, the methods of randomization were not straightforward. It was not a double-blind study, and the calculated sample size actually could not be achieved. The third study, 76 subjects. It was a single-center trial. Sample size calculation was not discussed. The criteria for admission to NICU were ill-defined, and more than 50% of the subjects were actually in the 39 to 39 plus 6 weeks bracket. So the authors have themselves confessed their lack of long-term follow-up and the small number of women in the 37th week of pregnancy, which is actually the bone of contention. So clearly the data is very less robust to actually cast the net wider from 3% to 30%. Let us look at the ALS trial in a little more detail. Yes, as my learned component has already discussed, the respiratory morbidity, yes, substantially reduced from 14 to 11%. But look at the graph on the other side. The neonatal hypoglycemia actually went up from 14 to 24%. Serious adverse neonatal events, including deaths, took place in the betamethasone group, and the numbers needed to treat were unfairly high. Hypoglycemia, come to think of it, we have already dealt with diabetes in mothers. We know how to deal with it. I know that. Now the point is, when you look at trials and you realize that 40 patients who received dexamethasone, when they were randomized to insulin or no insulin, 85% of women in the no insulin bracket actually exhibited hyperglycemia at levels commensurate with fetal acidosis. Given the fact that recent research has also highlighted the fact that women with lower BMI tend to have higher spikes in hyperglycemia, tend to have more persistent hyperglycemia, and these women can actually be missed because they are not diabetics. Coming to the neonatal risks. Studies have shown that with 72 children with neonatal hypoglycemia in the initial phases of their life, just a few hours after life, were compared with their 32 healthy siblings at 4.5 years, the detriment in fine motor skills was pretty evident. So yes, this hypoglycemia cannot just be ignored. Coming to somatic growth. When the objective of this study was a single course of glucocorticoids given to full-term infants, the outcomes were a significant reduction in length, birth weight, and head circumference. Another study, same outcomes, but here, please mind, the term and the post-term infants are actually having lower Apgar scores after the administration of a single course of steroids at term. We will argue, does this size really matter? But yes, we have implications. When these are followed up from 1 month to say 12 years across the spectrum, neurodevelopmental assessments found a clear detriment on either side of the spectrum, both less as well as more than 35 weeks. When you look at cardiovascular morbidity, look at the numbers. 63,000 women enrolled into postmenopausal postmenopausal brackets actually had low birth weight, less than 6 pounds, independently associated with cardiovascular morbidity. In younger adults, this translates into higher associations with endothelial risk factors, predisposing them to atherosclerosis. This study from Japan tells us that there's a linear inverse association between birth weight and diabetes mellitus, despite adjustments for all the potential confounding factors. The evidence heavily stacked against babies born at less than 2.5 kgs. And yes, this risk is not getting neutralized by normal current BMIs. Brain anatomy. 2013, this study analyzed 18 children born with steroid exposure vis-a-vis double the number without steroid exposure. Remember, these were all singleton term appropriate for gestational age babies evaluated at 6 to 10 years. And the MRIs told us that the red areas were where the cortical thinning was significant, and it was most significant in the area of the cingulate gyrus, 8 to 9%. And this anterior cingulate is where major decrease of depression, bipolar disorders, and mood disorders are concentrated in terms of clinical implications. When you come to physiology, we realize that at birth, when 30 children exposed to steroids vis-a-vis 60 without steroids, term-borns to all of them are pricked with a heel prick at 1 day of birth. Salivary cortisol levels tend to be much higher in the steroid-exposed group, thereby inferencing that the HPA excess is seriously modified in these babies. When we see them grow, we realize that when in response to a psychosocial stressor, 209 term-born babies, 6 to 11 years old at the time of study, after ruling out all potential confounders, continue to have a raised cortisol level. When they are followed up at 16 years of age, the rise in cortisol levels in response to stress increases. Another study which highlights the fact that attention deficit disorders and psychiatric disturbances are more common in this population of steroid-exposed individuals at term at 8 years as well as 16 years. The Aztecs trial themselves, when they followed up their own cohort of babies at 8 and 13 years, they realized that the steroid-exposed cohort had a lower quarter of academic ability. Now, this is a group that has been following steroid-exposed as well as non-exposed babies, and they have the luxury to follow them up for 40 long years. They have followed longitudinally, prospectively from 8 years to 32 years of age, the same cohort. And they have the luxury of a perinatal cohort, which has a perinatal insult, coupled with steroid exposure, a perinatal insult without steroid exposure, and a normal birth weight cohort. When they measured the levels of shyness in this cohort, they realized that those which had perinatal insult along with steroid exposure had consistently high levels of shyness throughout their lives. These were compared to the cohort which was exposed to low birth weight, so the same perinatal insult, but no steroids, and they found that this was moderately high shyness, which was increasing over the course of the postnatal period, thereby implying the normal birth weight babies obviously had a detriment in the shyness over the course of their postnatal phases. This cohort of Saigal et al. Have actually found that developmental programming is to be blamed for the more sensitive issues of distancing from the social threats in babies exposed to steroids. The other side can actually be blamed onto the postnatal conditioning. The same babies, the same cohorts, when they are followed up with EEG-based alpha asymmetry, they've realized that the right side of the brain, which actually is the control center for the negative emotions with the withdrawals, and the left side of the brain, which is actually associated with the more extrovert nature, outgoing nature, and receptive nature of the babies, they realized that the right lobe frontal asymmetry was consistently more pronounced in babies, not only facing perinatal insult, but also steroid exposure. And this has been reflected in psychopathology in all these individuals. Animal studies consistently prove pericardial issues, issues with lipids in the liver, issues with kidney and reduced number of nephrons in the kidneys, hypertensive disorders, and transgenerational endocrine and behavioral disorders and antenatal steroids. Getting inspired with the West is all fine. But when we come at this trial, which was performed as a cluster randomized trial in 6 countries across the globe to determine the feasibility of scaling up of antenatal steroids in low and middle income countries, and look at the numbers. Here we are talking in lakhs, just the way we should do before taking a policy decision for all nooks and corners of the globe. They have realized that yes, the exposure of antenatal steroids indeed increased from 10 to 45%. But did this translate into clinical supremacy? Suspected maternal infections, stillbirth, and neonatal morbidity and mortality all rose significantly high. The grave matter of concern here is that the increase in mortality was predominantly driven by babies born at term. It clearly is a matter of one size does not fit all. Come to think of a woman who is being counseled with benefits for steroids, we say that there will be a reduction in respiratory distress syndrome and transient tachypnea of the newborn. Albeit you might have a small risk of a smaller baby, albeit your baby might just have suboptimal school performance in a few cases. There could be a very tiny possibility of some psychopathic behavior in your baby. And finally, ma'am, can you please just negate the idea of long-term risk of diabetes and cardiovascular disorders? And madam, please turn a blind eye to the possibility of death as well. And please sign on this consent form. Come to think of it, will the answer not be a very obvious one? Thank you. Thank you all for patiently listening.
Super. Very good.
Thank you, Dr. Jaya. I think, Dr. Sujata, can we have some comments from you all, or I conclude then?
Yeah, you conclude first, because let's hear you and then we'll see.
Okay. So, see, Dr. Niharika and Dr. Jaya has given some evidences, not robustly. They have discussed all the, like a debate, that it should be discuss a pros and cons of antenatal corticosteroids for some for elective cesarean sections. I will just make few statements. Number one is that yes, steroids definitely have some benefits, but the benefits are less in term and late preterm situation as compared to when we are essentially give them between 27 to 34 weeks. The maximum benefits in that gestational age. The second is the events which we are talking of, RDS and TTN, they are already very, the incidence or the occurrence in term or late preterm babies, they are very less. So the results which this Cochrane is saying after evaluating 4 studies of around 4,000 women, that there is some benefit, 50% benefit in RDS and TTN. We don't know whether this statistical significance, which is only by calculation and all these, is really important in clinical sense when we are dealing with the patient. Because if we see this TTN, this is a transient tachypnea of newborn, which is already a self-limiting disease. So whether by steroid we are really helping the newborn or not, we don't know, because it itself improves on its own. And the third thing which I want to say is that yes, there are some evidence of neonatal hypoglycemia in these term babies after giving steroid, but the evidences are not much about whether the newborns which have neonatal hypoglycemia, how they behave in the long term. Actually, these subset of newborns have not been studied further. But yes, separately, if you see the baby or the newborn which have neonatal hypoglycemia, their late childhood is affected. It is not psychologically, they are not well behaved. So these are two different relations. They are not in a same subgroup or same type of newborn which are exposed to the steroid. So indirectly or directly, we have some benefits of antenatal steroids, but the evidences are not much. The studies which have been there in the literature advocating the steroid use in elective cesarean, they are not much powered. The number are less
and we don't know about many things in those study. So what in the end, the conclusion, what we could draw from them, that probably we need more powerful or adequately powered studies with larger sample size, or probably some more qualitative and quantitative data is required to further say that whether we should be prescribing steroid or not. However, at the moment, since the evidences are not very statistically powerful because of the lack of power in the studies, we may individualize the situation at the moment. Like individually obstetrician or individually patient can be considered, yes, whether we give in that situation the steroid or not to give the steroid. I think with that I will conclude this. Thank you very much.
Thank you very much. This was actually a very important controversial debate that we had to hear. Although I think personally I will go in favor of Dr. Jaya Chawla, because I follow that. But anyway, it was good to know both the things, because there are still many who give and who wonder why we are not giving. Thank you very much. Thank you. I think without much delay, let's just go on to the panel discussion, because I think all the panelists are getting very restless. I'm very sorry for this delay, but you must have realized it's technical snags. That somehow can't be helped. So let's get on to the panel discussion. Dr. Anshu, will you just introduce the...
Thank you, and Dr. Ashok sir. Sir, for a wonderful debate, and which was really prepared to start our last session, and that
Okay, Anshu, I think, are you having some problem there? Dr. Aarti, she's
discussion. For this, I would like to play the ma'am slide.
Dr. Anshu, is there some problem? We would like to see Dr. Aarti's slide, please.
Yeah, Dr. Sujata, you can informally introduce all my panelists and then we can start. That will be
Yeah,
fun.
I can start off by saying a charming, dynamic Dr. Aarti is going to be our moderator for the next next topic, that is the panel discussion on one-stop clinics. I think this is very important, especially these days. There's lots of endoscopic work going on, and patients will definitely benefit from the see and treat treatment, where it can be just within 24 hours and they go home. So these are case-based, this is a case-based discussion. And let's go on with Dr. Aarti, who's going to moderate, and her panelist, Dr. Subhash Malya. I think all of you all know. Congratulations, Dr. Subhash, for your recent achievement. And the other panelists, Dr. Pranay Shah, are they all there on the, I don't see their names. Dr. Atul, they're all there. Dr. Tenmari, yes, I can see you. Naveen, I can't see his, Nitin, I'm sorry, Dr. Nitin. Anyway, Dr.
Nitin is here. Dr. Nitin is here, yeah.
I don't seem to see them on the...
He is in Dr. Aarti Viltra madam's name.
No wonder.
Yeah, they didn't send him the link, but I'm so thankful. You know, he has to attend a big party. See, he's dressed in beautiful shirts, so I don't...
Oh yeah, okay, now I see. Okay, anyway, Dr. Aarti, come on, let's just get on to the panel discussion.
Good afternoon, dear friends. And first of all, I must congratulate Dr. Sujata, Dr. Anshu and Dr. Rakhi for such a beautiful annual conference for 2 days. Wonderful academic feast for everyone. Congratulations. And I would like to thank on behalf of my panelists too for giving us this opportunity to be with you and to share our views about one-stop clinics on ambulatory hysteroscopy. So I'll be starting with my... Is it fine?
Yes, ma'am.
Yes. Yes.
Yes, we can.
Thank you to all my panelists for holding till post-lunch. Dr. Subhash, Dr. Tinmoy, Dr. Nitin, thank you so much. One-stop clinics, ambulatory hysteroscopy. The topic looks very simple, and you know, when you talk to people, anyone would say, oh yeah, office hysteroscopy. I also do it. But you know, I was going on the net and looking for in-office procedures. So, you know, this fancy editorial which says this can provide a safe alternative to the surgery center or hospital. When we do some office procedure, you know, the main purpose is that we are bypassing the operating room charges, we are bypassing the admission in a proper hospital, and we want to do it in an office setup where we would not be giving IV analgesia or anesthesia to our patient, and the procedure has to be explained very nicely. Similarly, you know, the editorial says in-office surgery can avoid hospital co-pays from your insurance, because most of the cases nowadays are coming through insurance. So that is the second issue, which is, you know, not such a big problem in our country, but in places like US and UK, the doctor would have a backup with a big hospital where they can shift the patient if need arises. Otherwise, they would like to do simple procedures like hysteroscopic tubal occlusion by Assure, testing for the cavity for abnormal bleeding, removing the polyp in the office setting only by giving little bit of oral analgesic and detailed counseling. So may I ask my worthy panelists, what are the diagnostic indications of office hysteroscopy? Dr. Nitin does a lot of hysteroscopic surgeries, I know. So,
Yes, madam. As far as the indication of the office hysteroscopy goes, it is a lot many, like if any patient coming with abnormal uterine bleeding, there is postmenopausal bleeding in a high-risk cases where the anesthesia is contraindicated. One can go with the office hysteroscopy. Any abnormal HSG with showing some as well, like a mass, polyp, or a small fibroid less than 1.5 centimeter, not bigger fibroid, can be removed in the office setting. Also, any cases where you are suspecting abnormal uterine bleeding. So these are the cases of office hysteroscopy. Now, mind you, in India, we are not doing office hysteroscopy per se without anesthesia in all the patients as far as possible. And we always post our patient in the operation theater rather than in the true office or an OPD procedure, because our females are uncomfortable. Also, as a daycare procedure, it is still not covered in the Mediclaim. So people will admit the patient for 24 hours, give them a rest, and then operate in the OR rather than a true office procedure. So even in the operation theater, if we don't give anesthesia and do office hysteroscopy, like especially in case of aged female who is contraindicated for the anesthesia, this office hysteroscopy really works well.
yes, very true. So rather than saying office hysteroscopy, we'll be talking more about ambulatory hysteroscopy. Ambulatory hysteroscopy means we admit the patient on daycare basis. They are with the doctor for about 5-6 hours. They get the procedure done, and then we can do small operative procedures also, and then let them go home on the same day or keep them for 24 hours. Dr. Subhash, what are the therapeutic indications for ambulatory hysteroscopy? Like what all would you like to do on these suspected cases if you admit them for daycare?
Yeah, ma'am, as you have rightly put it across, ma'am, at the outset, ma'am, let me thank the Noida Society for giving us a chance, ma'am. As you rightly put, ma'am, for the uterine septum, ma'am, for the septal resection, we can definitely go, ma'am. We can also go for any polyp or very small polyps. If you're really good at it, if you're having very good experience, like what you have suggested, like Nitin has been doing, ma'am, definitely you can go for a small submucous fibroids. But of course, that comes with a lot of experience and that comes with a lot of cases. Again, as you have said, for the sake of cooperative removal, and even for the diagnostic part of it, the diagnosis of an AUB or probably you won't take a biopsy, yes, definitely you can go for these things, ma'am.
Yeah. So foreign body removal, you know, it's
Definitely,
very
cooperative. Definitely, yes, ma'am.
IUCD or sometimes post-abortal cases, and biopsy is a very simple lesion when the lining is thick. So when we are going for office hysteroscopy, Dr. Tinmay, can you please tell us about the patient selection in these cases?
Yes, madam. At the outset, I would like to thank the Noida Society for giving this opportunity. Quickly going into the topic, it's actually very, very easy to do it if you have experience. And if you don't have experience, it's very difficult. So the gynecological surgery in the office setup, we have to select the patients very carefully. Particularly, we have to talk to the patient, and then I use like vocal, local and focal anesthesia in outpatient setting. So I have a nurse who talks to her constantly, so that we just need to, make sure the patient understands what we are talking and what we are going to do. So we just have to explain and reduce her anxiety, and also avoid other comorbid situations like asthma. But particularly with obese, high BMI patients, I do them in the outpatient setting rather than inpatient setting. And also with patients like comorbidities like heart disease and psychological issues, sometimes in outpatient procedure in the ambulatory setup is much more easier and medically safe rather than doing them in the operation setting.
True. I was going through this study, 13 steps for office hysteroscopy with minimal discomfort. This study by, this study is by Ricardo Lamar, who has done the staging also for hysteroscopic myomectomy. So this was presented very recently, last year only on 27 June. So they have given basic tips, which really help in counseling your patient, in making them relaxed. And you have to tell your patient that we are not taking you to the operating room. We are not going to give you general anesthesia or sedation. And the patient has to be told about the OT room setting also, about the position on the table for examination. And you have to keep the patient engaged by showing them the procedure which is on. That really helps. So it is a very good procedure with less cost, fast diagnosis. The doctor can see and treat at the same time. But the main difficulty is the discomfort which patient may face during the procedure. But as you know, with TVS, you have to explain the patient, and 99% patients are happy. With a smaller case, simpler case, if the patient is counseled well, the procedure can be done comfortably in office settings only. So
I would like to add one point, Aarti madam. I would like to add one point. See, rather than confusing with the routine hysteroscopy and office hysteroscopy, the technique of office hysteroscopy is very helpful when you are doing even in OR under anesthesia. What this ambulatory technique says is no use of valsalum, no use of speculum, and no catch of the cervix, no dilatation. So this technique one has to adopt even while doing under anesthesia, especially in a young girl who is unmarried, where the hymen is intact, where you cannot put a speculum, you cannot catch the cervix with the valsalum. You just directly go with the office hysteroscopic technique. Put the scope directly into the vagina, do vaginoscopy, approach the posterior fornix, come out little bit, locate the external os, and walk into the cervical canal, into the uterine cavity. So this is very important thing to adapt the office technique of using into the routine hysteroscopy. That is very important to learn from the office technique. Whether you do it without anesthesia, with anesthesia, that is secondary. But nowadays we get lots and lots of girls with the Mullerian anomalies and abnormal uterine bleeding, and they are unmarried and hymen is intact. Office technique is very important. That one should learn.
So I'm going to share a video on vaginoscopy and hysteroscopy very soon, but I wanted Dr. Tinmay to comment that what kind of hysteroscope would you prefer to use for a daycare hysteroscopy rather than using the regular 4 mm scope? Like what else do you use? Like I was talking to one of the consultants. He's not been able to join for the panel. He said, I have 6 sets of scope, Dr. Aarti. So I wanted him to answer the question. Let's see what collection Dr. Tinmay is using.
Yes. See, when I was actually a consultant in ambulatory gynecology clinic in UK, we used quite a lot of flexible hysteroscopes. But after coming to India, I feel it's more comfortable to use reusable rigid hysteroscopes. What I use is 2.9 mm scope, including the outer sheath. And that is more easy to maintain, and it's less expensive compared to flexi hysteroscopes. And you can have accessories like scissors and forceps and bipolar electrodes, which are 5 French in size. So it's much more user-friendly and easy to maintain, and nurses can easily learn how to sterilize it. And also, I use 2.9 mm, including sheath, rigid hysteroscope in my routine clinic.
Yeah, thank you. So as we...
Arti, can I just make a point? Yeah.
Sir, welcome. We were looking...
Yeah, hi.
Yeah, hi,
Good evening, sir. Welcome, sir.
Yeah, hello. Yeah. So, you previously mentioned about the indications. I think one of the major reasons why office hysteroscope is not caught on in India is the insurance. Unless we work with our insurance companies and say that we can do it in our office, they want a registered nursing home with minimum 15 beds, and they want many of them want a overnight stay. So I think it is for our society now to take up this collectively that you don't need a big nursing home or an institution to do office hysteroscopy. You can do it in a clinic if it is well equipped, and you don't need overnight stay. I think these are two major hurdles why we can't do it, because even if you've got an excellent office, your insurance will not reimburse it unless it's a 15-bedded hospital. So I think this is something which we need to as a society try and pass it with the insurance companies.
I just hope we can do that, because even I have faced it with my family member. Like on daycare basis, the hysteroscopy was done a big amount, but the hospital would say no, because the patient is not admitted, so we will not get it reimbursed. So this becomes a main issue in picking up the procedure also. So the settings have to be familiar. Like we don't use a speculum, no valsalum is used to be a smooth entry, and we don't want the patient to experience the pain. And as Dr. Nitin has commented, we do vaginoscopy first to minimize the discomfort. We have to keep chatting to the patient. We have to keep showing her on the screen what's going on so that her attention is diverted and she is comfortable. May I ask about the pressures being used when we are doing it in the office setup? What pressures do you use, sir? Dr. Pranay, sir, what pressures would you prefer, sir?
No, so truly office hysteroscopy without anesthesia, the pressures cannot be more than 45 to 50 millimeters of mercury, because anything beyond that will cause pain. And if you're using sedation, probably you could go up to 70 millimeters. As Nitin mentioned, most of the time I do the procedure not in the office but in the regular OT, but with the concepts of office hysteroscopy. So the important thing is the concept, and to pick up the steps of office hysteroscopy, you need not do it in the office. You can do it anywhere, and then depending on the patient choice and the requirement, you could use local anesthesia, or you could use even general anesthesia or a block, depending on that. So I think this is one of the video which I had selected was a patient who is. Are you going to show the video, Aarti, or do it later on?
Do you have your video to share, or I'll share it?
Yeah. So
share the video. Sir is going to show a beautiful video for vaginoscopy and how do you enter inside.
So this was one of the cases which I had selected for this, because she was a postmenopausal patient. Somebody had tried for a hysteroscopy, but they could not visualize the cervix. The cervix was flush. The valsalum could not hold it, and you could not actually see the external os. And these are the cases where an office hysteroscopy technique would be an excellent thing. So as you can see, you're going into the vagina. You can appreciate the. I think we have gone beyond. Can we come back?
Sir, I thought you are going to share video from your computer. Do you have it, sir? Otherwise, I'll load it.
No, I think you'll have to do it from my side, because I haven't picked it out. It's on my PC. But
load it, and in the meanwhile, we can go to the
sure.
Next slide. Sorry, that's why I had texted you. So regarding the distension medium, in the meanwhile, Dr. Subhash, which distension medium would you like to use for daycare hysteroscopy?
No, I've only used normal saline, ma'am. I've only used normal. Though, of course, theoretically, ma'am, I mean, not theoretically, there have been a lot of literature. I think Dr. Tinmori madam will also agree that a lot of CO2 has been spoken in the UK part of it, but I think in our setup, we are all very comfortable using a normal saline, ma'am.
Yes, absolutely, I agree. There is no statistically significant difference in looking at the pictures or looking at the findings between gas and the saline. And saline is much more easier and cheaper to use. So that's what it's preferable.
No, I think if you're going to do any operative procedure, then gas is out. You will have to use saline because you can't really do any operative procedure with carbon dioxide gas, because the moment you try to cut anything, you will have bubbles, and then the whole thing gets disturbed. So just a quick diagnostic look, gas could be an option, but you need an expensive histoflator. But I think most of us would use normal saline.
Sir, I'm transferring the video. In the meanwhile, because I wanted to play the video here. So the video is going to be about how to enter inside. So the message given will be that the stenosis and synechia, they should not be pushed, because when you try to, push them apart, it gets painful to the patient. So we should use a fine hysteroscopic scissors to cut the synechia and get a smooth entry. I'm so sorry. I thought you'll be sharing the video. So this was another tip which was written, because sometimes the moment when you enter inside, although now all of us are using hysteroscopy under sedation only, but if one goes for office hysteroscopy, as Dr. Sujata wanted to discuss, what will we do? Suppose if the patient ends up with a sudden vasovagal reaction due to pain, how do we manage that? Dr. Tinmay?
Yes, it's better to prevent vasovagal thing. There are certain techniques. So in our outpatient setting, for the diagnostic outpatient ambulatory hysteroscopy, it hardly takes 2 minutes to do the procedure. The two painful things that can happen in the outpatient setting, one is the dilatation of the cervix and one is the distension of the uterus. So for the outpatient setting, we don't dilate the cervix at all. If you just do the vaginoscopic technique and if you just distend the vagina with the normal saline, it automatically, you just have to wait. It automatically, like a flower, the external os opens, and then you negotiate through the external os and you reach the internal os and wait there for few seconds, and it will automatically open. And then you just enter the cavity. You don't need to touch the endometrial surface. It just, hardly takes 90 seconds for me to go in and come out. Most of the findings are seen during when I am coming out. So it's just these two things that you have to be very fast and then do it very cautiously. Even if you find a small sign of vasovagal shock, the best thing you should do is just take out the instrument and just observe the vital signs and talk to the patient. It's all in few seconds. You can easily revert the situation. So it's not a good idea to just keep the scope inside the cervical canal, distending the cervical canal. That is the main problem. You get the vasovagal shock. So just go inside very gently and then don't touch the surfaces, and then come out. When you come out, you see for most of the pathology inside the uterus or inside the cervical canal. So that's what we do. It's better to prevent vasovagal shocks. If at all, hardly in my 6 years of practice, we hardly had one episode of vasovagal shock. But we just do always follow these techniques to prevent this.
One more thing, ma'am, which if I add, ma'am, always try to keep your scope in the center of the cervix. You just don't touch any of the musculature anywhere, and that is when you initiate a vasovagal impact, more so the cervical region. It's always better to keep your scope. Try not to go and touch any of the muscle.
Yes, if it is a 0-degree scope, obviously you put the circle in the middle of your screen.
I was about to ask you, since you had from UK, so I was like 0-degree versus 30-degree was something which is about to ask you, ma'am.
Yeah, if it is 12-degree or 30-degree, obviously your circle should be in the different angles of the screen.
No, we are all used to 30-degree, ma'am.
Yes.
And I'm sure most of us. I'm not sure. Pranesha sir also. Sir, you also prefer a 0 or a 30, sir?
No, 30-degree for diagnostic and 12-degree for the operative. So
12-degree for the operative.
I'll play it. Okay.
So Aarti, my video is ready in case you want me to do it. If yours is not loaded.
Video. I was trying to do that. Yes, sir.
Yeah. Can you see my screen now?
Sir, you'll have to, madam will have to stop sharing, and then you will have to start sharing, sir.
Yeah.
Yeah, now you can start sharing, sir.
Are you able to see my screen now?
Not yet,
Not yet.
sir.
1 second.
So suppose Dr. Thinmay, in the meanwhile, when sir is uploading his video, if there is a
No, it's
sudden
already uploaded. It's just my sharing of the screen, so I'm not sure. Are you able to see my screen? I've already said share screens.
No, sir. Have you touched your presentation? Have you opened the presentation and kept, sir?
Yeah, it's already open. Yeah.
Then can you please click on that, sir?
Click on the video. Okay.
Yes, sir.
Are you able to see it now or
Not yet.
No?
No, sir. Share screen. And in that whole thing, you will get your video, whichever is the video you would like to play. Please touch on that, and then we would get it, sir.
Yeah, just so I go back to Zoom and share screen now.
No, so you have still not shared the screen, sir.
No, that's what I'm tapping on the share screen, but nothing seems to be happening.
Sir, I'm sharing. Your video has been downloaded.
Okay.
So now we can share it, sir. Yeah.
Okay.
Now, yeah. Is it visible now?
Yes, ma'am.
Yes.
Yeah. So you want me to describe the steps now, Arti? Yeah, the video is running, so it will come through. So that's the vagina. You can see the atrophic vagina. You can see the the punctate spots, which are very typical of an thin atrophic postmenopausal vagina. And you can appreciate now there's hardly a cervix seen. You can just see a dimple at the top of the vagina, right? You can see this area which is a little lighter. So this probably is the area of the external os. So I'm now going in with a Bitoki 5 French grasper and just trying to nudge into that area which is thin, which I thought was the external os. And you can appreciate that slowly there was a thin membrane which was covering the os, which is now broken up, and we now depend on the hydrostatic pressure for the fluid to gush in and open up the cervical canal. So just like you use your dilators when you're doing dilatation of the cervix, once you open up, you can see the cervical canal opening up now. Do you appreciate that? And now we are in the cervical canal. So again, at the top of the cervical canal, you can see the internal os is tightly closed. And we are again using a 5 French grasper to open up the resistance of the internal os. The advantage of this is that your dilatation is blind and you could create a false passage. But with a 5 French grasper, you can never create a false passage because it is under vision. And if it is very tough, then I would use a 5 French scissors. But most often, the 5 French grasper is good enough to create a passage. And that's a small Nabothian follicle, which is seen in the cervical canal, as if someone has lost a pearl, diamond inside. And now you can appreciate the internal os opening up well. Okay, so and once this is adequately opened, your Bitoki sheath, which was Bitoki 4, can easily walk in. So again, you need to appreciate that in the Bitoki sheath, there are 3 types of sheath: Bitoki 4, 5, and 6, and each will have a matching telescope to go in. So for office cystoscopy, what you want is a Bitoki 4 or a Bitoki 5 sheath. Now you can see the uterine cavity is normal. This patient, although she had postmenopausal bleeding, you can see the endometrium is normal. And this patient actually hysterectomy was safe because she was actually posted for a hysterectomy because the previous gynec could not get an endometrial sample, and she was advised that it is not safe for her to keep the uterus. And when she came to me, I did an office cystoscopy, proved that the endometrium was normal. I did endometrial sampling, which turned out to be atrophic endometrium. And this patient, I've been following up now for the last 3 years, and she's fine. This video is almost, was done in 2017. So I think this is where with your miniature histoscope or with a Bitoki sheath, you could actually save a major surgery for a patient.
Sir, if I can add, ma'am, to what sir has said, ma'am. As sir has rightly said, when he introduced a grasper to just make a dilatation, The advantage is there are no sensitive nerve, no sensitive nerve terminals or blood vessels are there in the fibrous tissue. That's one good part. And secondly, the advantage, in addition to what Sir has actually shown, is suppose if we go into a false passage, there will be a prompt identification for false passage. The patient will tell you that there is a pain.
Yes.
The patient will definitely give you a feedback that there is a pain.
Yeah.
Suppose there is a sudden increase in pain or bleeding or visualization of the red tissue. Now all this will tell you that you're in the wrong plane. So one good thing is, even in a difficult case, the patient will guide you whether you are right or wrong in these cases. Unless the patient is an opioid analgesia, which usually we don't give when we go for any office hysteroscope with some NSAIDs.
Yeah. So my question to Dr. Thinmay is, suppose if you're doing a office hysteroscopy, you have taken a case and this patient lands up with vasovagal, because in UK I'm sure the anesthetic backup is not there. So how would you manage these cases in office setup?
So in the office setup, obviously, we just need to have, casualty setup, all the emergencies it should be kept in a trolley and have to be periodically reviewed. So the nurse, I always have a nurse who is trained in what needs to be done immediately. So, the first thing you have to do is take out the hysteroscope out of the patient's vagina. That is the very important thing. And then check the vitals. And obviously, if she's not in the outpatient setting, we don't put her in IV fluids or anything like that. So you just have to put an IV access, make sure she's stable. And obviously the pain is the commonest reason here for the vasovagal shock. So if she's in pain, we need to give analgesics so that she is getting away with the pain. And I don't do anything more than this because most of the 95% of the time, the patient gets better with this simple taking. But if you are doing a major intervention in the outpatient setting, then the vasovagal shock could be a little bit difficult and serious. So you have to, predict these kind of things and better to avoid in the outpatient setting. So you have to do minimal procedures. What I do here in my setup is mostly diagnostic and small polyps and fibroids less than 2 centimeters, grade 0 fibroids, and very flimsy, thin adhesions, intrauterine adhesions, and removal of foreign bodies. These kind of simple procedures that you can finish off in kind of 5 to 6 minutes. That is the maximum time that you have to look for in the outpatient setting. Anything more than this, if you are anticipating, it's better to do with the anesthetic support, with some kind of sedation. What I normally use is, as I said before, vocal, focal, and local. In my local anesthetic thing, I use lignocaine 2% with dental syringe. I do it intracervical infiltration of anesthesia up to the internal level. 9 o'clock, 6 o'clock, and 3 o'clock position, I infiltrate local anesthesia. The lower part of the cervix and the lower part of the uterus is completely anesthetized with this infiltration. I don't do paracervical blob. I just do direct intracervical infiltration. Most of the time, it relieves the pain when you're dilating the cervix. I don't dilate the cervix more than 6 Heger dilators in the office outpatient settings. So if you don't dilate the cervix too much, and also if you don't distend the uterus too much, the vasovagal shock, there is no point of talking about vasovagal shock in those scenarios.
These tips are very good, but the only thing
I would add, don't hold with a valsalum, because that is again a major cause of pain.
Exactly. Yes, sir. Most of the time we are doing vaginoscopic techniques. So there is no.
So if you can avoid a valsalum, I think that is a major reason of first.
And the dilatation is not needed if we are not applying a valsalum. I don't think, because dilatation itself will be causing pain. So when the fluid makes a passage, and then you can enter your scope along with that, because for dilatation also you need to put a valsalum, otherwise it's not possible.
Another common thing that can happen is, you want to distend the cavity with the fluid, so it has to be slow. See, if you ask your assistant to give the pressure to your saline bottle, then suddenly the intrauterine pressure increases. You should not do that. Gradually it goes, and you don't need a big distension to do minimal procedure at outpatient setting, not like in an intraoperative procedure in the theater. So you just need a minimal distension which is comfortable for the patient.
Ideally,
may I put it across in a different way, Ma'am Thinmay, madam? Like if you're seeing it very well on the screen, that means your pressures are high.
No. We have a hysteromet if we are doing office hysteroscopy, because then we can.
I was just joking, ma'am. If you're really seeing it pretty well, that means the pressures are definitely higher. So, definitely if you're having some sort of, a low vision, that is okay. That is okay in these cases.
That's fine. See, that's what I don't worry about this pressure. You know, as long as you are comfortably seeing the whole cavity and the both carnova, anterior, posterior wall, two lateral walls, don't worry about the pressure. Just see the pathology and come out and deal with it with anesthesia later on. And again, the histomat, I don't use it in the outpatient setting because again, you know, you can't control the pressure. You just do it, you know, natural gravity flow, and it will work out.
Okay, so you just use the saline with gravity. You don't even use a pump or something.
Yes, yeah, I use pump for the operative procedures.
All right, okay. So this was one patient, you know, she was elderly, ultrasound showing a polyp, and we could see some fluid in the cavity around the polyp. So these are the ideal cases which can be easily, you know, tackled in office setting or on daycare setting. And you know, this video shows that we are doing a polypectomy. So do you think any special precaution to be taken for this case? Because normally we are not giving anything for cervical preparation. What is your opinion about preparing the case?
In such cases, if the polyp is really big, one can go and don't cut the release the polyp from the base directly. Just cut the polyp into 2 or 3 small pieces, and then finally you cut it from the base so that you can pick up small pieces without dilating the cervix. And this is how we routinely do in case of menopausal women where the cervix we could not help with the valsalum and you could not dilate the cervix. So you cut the polyp in 3 to 4 pieces initially and then chop it off from the base. And one can use bipolar saline needle, which is available, which is 5 French. You pass it through the operative sheath and cut the polyp into 2 or 3 pieces and then release from the base, and then with the help of the grasper, you remove small pieces.
That's a good tip, yeah. If it is
I had the fortune of seeing this. I mean, this procedure being done by Nitin sir, madam.
Yeah, one small thing. I use you know, bipolar chisel. You know, there's a chisel. It beautifully cuts the base of the polyp, and it's a 5 French size and bipolar energy that you can cut it.
But is it available now, ma'am?
Yes,
it available now?
It's available. It's available.
I think JLK had it.
Bipolar needle available Indian made as well as South made.
Twizzle.
But twizzle is something which. Okay, ma'am. Because bipolar needle is something which I have seen. I've seen and I have it.
Yes. And again, you know, with the polyp, always you have to take out the specimen. If it is a fibroid, if it's less than 2 centimeters, I do it in the outpatient setting. I just keep the fibroid sometimes inside if you can't take it out. See, the taking out is the more painful process rather than doing the procedure sometimes, particularly with the closed cervix. So if it is a fibroid, you can leave it inside and it will actually come out later on, even with misoprostol. But if it is a polyp, it's always better to take out the polyp and send for histopathology. There could be an underlying hyperplasia, malignancy inside the polyp tissue. So always better to take out the polyp completely from the cavity.
Yes, that was the.
May I say this is classical RCOG what madam has said. Polyp you cannot leave behind. Fibroid you can take it. I can assure you this is what RCOG always has been telling.
Yes, yes.
Yeah, Subhash, in India you'll not be paid unless you show the fibroid to the patient and the relatives.
Bilkul sir. Bilkul.
Bilkul you can leave it inside.
Bilkul दिखाऊंगा sir. Bilkul दिखाऊंगा sir.
You can show the video to the patient, sir.
That doesn't work. You show the fibroid, then you get paid.
पैसा पाहिजे सर पैसे पाहिजे.
Yes.
Specimen दाखवा पैसे घ्या.
हो पैसे दाखवायचे पैसे घ्यायचे ना.
No, the patient may even get worried that something is still left behind.
No, of course, ma'am. We have to counsel for that. Definitely, we will have to counsel for
For
that.
all this counseling is very important.
It's not going to be there from inside, Madam Dr. Sujata. It's going to come out. It will come out.
Yeah, we'll have to assure the patient that.
Yes.
True. Very true, ma'am. Very true, ma'am.
Yes.
So now we come to fibroid. Dr. Tinmay was talking about the size of fibroid. This lady, she's 32 years, married for 4 years and trying for conception. And she has this fibroid arising from the posterior wall and pushing the cavity anteriorly. How would you like to manage her? Yeah. Am I audible?
Yes, ma'am.
Yeah. So submucous myoma, more than 50% in the cavity, pushing the endometrium. Rest of the reports are normal and she has been trying for conception. So should we take her in the office setup or should we? her for
Yes.
OT.
Yes, to be honest with you, ma'am, she's a primary infertility patient with a closed cervix and reasonably almost like 1.5 centimeters submucous fibroid. It's not grade 0. It is actually still a little bit in the myometrium. So I would not do it in the outpatient setting, mainly because her anxiety is very high. And also the measurement sometimes may not be very perfect. What we are measuring in the scan may be a little bit bigger there. So, and also cervical dilatation is a big part here. So I wouldn't do it in the outpatient setting, but sometimes I do an outpatient hysteroscopy to assess how I'm going to do it in the theater. For example, I just do an outpatient hysteroscope and see how vascular it is, how is the endometrium otherwise, and whether it is near to the cornua. So those kind of things, I just do it, like 5 minutes outpatient hysteroscopy and just study the fibroid. And then I do it in the inpatient setting.
Yeah, so it's very important to see the type of fibroid which we are going to deal with before we decide whether we are going to take it in the OT or in office setup. And everyone knows about the ESG classification of fibroids, which shows the myometrial extension. Type 0, it will be in the cavity. Type 1 will be less than 50% in the myometrium. Type 2. Type 2 has to be done in the OT more than 2 centimeters. They have to be done in the OT setup only with proper expertise. And rather than ESG classification, Lamar classification of submucous myomas is of great help in deciding the proper plan for myomectomy. And as we all know that ESG classification only tells us the degree of penetration of myoma, whereas step W or Lamar classification tells us about the size, topography, extension of the base of myoma, penetration, and myoma on the lateral wall again gives one more point. So accordingly, we give the score of 0, 1 and 2. Score of 0 to 4 comes to group 1. 5 to 6 comes to group 2, and group 3 has always to be taken in the OT with proper setting, and it has to be done by an experienced surgeon only, because myomectomy seems very simple, but the doctor has to have expertise of dealing with large myomas if they plan to do it hysteroscopically. So as discussed, ambulatory myomectomy may be an option for intracavitary myomas up to 2 centimeters. And if they are pedunculated, they can be grasped with the scissors also. So pre-op evaluation is very, very important. Now I would like to invite Dr. Tinmoy for sharing her case of AUB, which she dealt in the OPD setting only.
Yes. So am I audible now?
Yeah.
Yes, you are.
So I'm just doing the share screen. And just bear with me for 1 minute. I will be there with my screen.
So in the meanwhile, as shown here, we should understand that type 2 hysteroscopic myomectomy has increased risk of excessive fluid absorption because the surgery may take longer time and there may be electrolyte abnormalities. So it's very important to keep a watch on the fluid loss, and we must measure the fluid loss, and we have to look for complete resection of the myoma also, because sometimes large myomas may need 2-stage surgeries. I would like Dr. Pranay sir to give his expert tips regarding myomectomy for larger myomas.
Excuse me, Dr. Atik, can you actually stop the screen? Then only I can put my...
Yeah, sorry.
It's okay.
There I am, yes.
Have you, let us share the video and then I could talk about
okay, sir.
So this is the video about, this is the case. I'm just going to briefly run the story. She's a 40-year-old lady, para 2. She had 2 normal vaginal deliveries and being sterilized. And I got suddenly a call from vascular surgeon in our vascular department and saying that she is bleeding profusely. And she was admitted in vascular department with DVT, deep vein thrombosis, following her air travel. And so she was treated with therapeutic doses of anticoagulation. So she was on the therapeutic anticoagulation for nearly 4-5 days. And she was bleeding vaginally, and her hemoglobin dropped to 4 grams. And even though she was hemodynamically stable, she was continued to bleed continued to bleed, and so the vascular surgeon called me. So when I went and examined her, her cervix was fine and the uterus was normal size, and the ultrasound was normal endometrium and normal size. No, adnexia was normal. She had a normal smear history. Every year she had cervical smear as per her sister's advice, so normal smear history. So when I examined, it was absolutely normal pelvis with normal anatomy of the uterus and the ovaries. So what the options we had at that point is medical management or intrauterine system or surgical. Obviously, I won't put intrauterine system like Marina because she's bleeding profusely. It's not going to stay in there. So on medical, obviously, there are a lot of limitations in starting medical because of she's already known to have this deep vein thrombosis. So I just started her on progesterone just to reduce the flow, and then did a quick hysteroscopy, office hysteroscopy, just to take an endometrial biopsy, because we have a second generation global endometrial ablation technique available in our outpatient setting. We do it in the outpatient setting. It hardly takes 90 seconds to do the procedure. So I was just looking in terms of whether she will be suitable for this NovaSure global endometrial ablation. So when I did the outpatient hysteroscope, the cavity was fine, and there were lots of fluffy materials in the cavity. So I did take it for biopsy, and we did order for a emergency quick biopsy report, and then it came as no hyperplasia or malignant. Planned the next day following her blood transfusion, we planned NovaSure endometrial ablation in the outpatient setting. She just walked into the ambulatory unit and we put her in lithotomy. As I said earlier, I did block the cervix completely at 6 levels, 12 o'clock, 3 o'clock, 6 o'clock and 9 o'clock, and also at 5 and 7 o'clock position with local anesthetic intracervical infiltration up to the isthmus. And then sometimes I anesthetic infiltrated just medial and below to the cornua, both cornua. I use the urologist Cook's needle. I just through the 5 French channel. So with endometrial ablation, that gives more complete anesthesia to that. And it was a size 6 NovaSure ablation procedure. So she was already para 2, so the cervix was easy. It is a bipolar radio frequency controlled impedance control. That means once it touches the myometrium, the machine stops on its own. So the whole endometrium gets completely destroyed by coagulation. And sometimes you may get few packets of endometrial glands, but it doesn't matter, as long as more than 70% of the endometrium up to the basal layer is cauterized or coagulated, it's not going to give troubles. So we did that. It took 90 seconds to do the procedure. So after that, I gradually reduced the dosage of progesterone, and it's been done 1 year back, and she's absolutely amenorrheic since then. So that is the one of the ablative procedure, which is very, very user friendly and very safe technique. It has got a lot of safety techniques. We can introduce CO2 into the cavity, and if the uterine cavity.
Dr. Tinmoy?
Yes, I think the video there is some problem in playing the video. It says unable to share. Have you got my video? Unable to share. Have you got my video? I have already sent it to you. Yeah.
Yeah, but I could not play it either. You had sent it to me twice. I could not play it.
Let me try.
If
we can see your screen sharing, madam. Play the video now. Do the slideshow and play the video.
Okay. So the video is not playing from here.
Perfect.
And do you have the? I think you're not hyperlinked it, or is it in the same folder as the presentation?
Okay.
So there is something wrong because she tried to mail it to me also, and I could not open her attachment. She had sent.
Aarti, basically the whole thing is very instrument driven. So if you do not have the machine, obviously you cannot offer the therapy to this patient. Absolutely. And I feel endometrial resection and ablation would have worked the same way. So today you have the hysteroscope in all the settings, and the same thing if you did not have the the NovaSure machine, which I believe is a very heavy expense because it costs about I think 20 to 30 lakh rupees. So unless you have sufficient volume of cases which you're going to do, individual is not going to be able to afford it. But endometrial ablation would probably work in the same way in good hands if the hysteroscope is available. So obviously it's the same thing.
Yes, I agree, sir. But the cost is not that much. It is actually 7 lakhs, the whole machine, the bipolar machine. And each device is, disposable device. It costs 20,000 rupees.
Okay.
No, it is fine. But I mean, you need to have it. So if you don't have it, then I think a hysteroscope is far more versatile to be able to. And anyway, you need to do a hysteroscopy to check whether the endometrium is normal. So
Exactly.
Like in my thing, if you've already done a hysteroscopy, what stops me from just resecting the endometrium? It's probably 5 more minutes first thing. So but if you have a equipment like that, I think it's superb. I mean, there's absolutely no question about it.
Or else our jugaad only works better. One shot, one shot, finish it off.
Yeah.
So this is our next case. Dr. Sujata, let me know when to stop because I have, lots of cases. Whenever you'll ask.
Looks like Sujata madam is hungry.
I know she's, on it since early morning. So,
but ma'am, on the positive side, ma'am, we still have a lot of participants. I think we have gone beyond about 1.5 hours, but still, hats off to the organizers. We still have a lots, almost 100 people will still logged in. I think it's really speaks volume for the effort which your team Noida has taken.
No, I'm sure they're all very interested in hysteroscopy. That's why, I'm sure they all are hysteroscopists and want to know more because we all have such experienced panelists. So they want to listen to all your experiences. So Dr. Aarti, please, I had allotted 45 minutes for you, but I'm so engrossed in your panel. I don't know how many minutes you took, so I don't know.
Yeah, we'll quickly share because, everyone has lovely tips to share. So I think, so this is our next case. She's para 1 C-section done 18 months ago. She complains of post-menstrual bleeding for 6 to 8 days. We did her ultrasound. So these are the ultrasound findings. Now, and she's interested in having another baby also. So how do we manage this lady? Yes.
This looks like an isthmosyle.
Yeah, it is an isthmosyle.
This is a scar defect.
Yeah.
Okay. It's a triangular, inverted triangular shape.
Correct case for the correct person.
Yes. It's more of an isthmosyle.
Medically, this gap was around 6 millimeter. The myometrial thickness was around 6 millimeter on ultrasound.
Management depend on her future planning, whether she is interested in conceiving further. So if she requires for the baby, we have to treat it laparoscopically by giving a good repair. Excise that scar and repair it nicely. And if she is not willing for further pregnancy, one can go and excise the lower ridge using the resectoscope hysteroscopically so as to facilitate the drainage of the menstrual blood. So this is how one can divide into the management.
Thank you. So this patient, she had a cesarean scar defect, and although she was interested in having another baby, she was managed by hysteroscopic, management of this pouch-like thing, which was the fibrotic tissue was removed and the pouch was removed, and the remainder of the base was cauterized, and then she was kept for follow-up treatment, which she'll be coming after 3 months. So bipolar resectoscopy can resect the scar tissue in the isthmosyle, and I was going through studies, and in JMIG also, there was a review article on treatment of isthmosyle. So the study says that MRI and TVS are the gold standard techniques for diagnosis of isthmosyle. And surgical treatment is still a controversial issue, but should be offered to symptomatic women, and it can be in the form of lap-guided repair, hysteroscopy alone to treat the pouch, or they have mentioned vaginal repair also, about which I could not find much details, but I was wondering that only vaginally, how could one repair it nicely by pushing the bladder up?
Yes, it is done. Many of our colleagues do scar ectopic by vaginal technique. They bring down, they open the A pouch
bring down the uterus and repair and put it back. So it is possible.
Yeah, Aarti, but I would agree with Nitin that whenever there's a fertility issue, because most of the cases which I have done are patients who have failed IVF, and they've had a first baby, they want a second pregnancy, and then multiple failed attempts. And I think in these cases, laparoscopy is much better than hysteroscopy. Hysteroscopy could be an option if the patient. If the problem is an abnormal uterine bleeding, because a lot of these patients might continue to spot for a long time, and with the niche, then hysteroscopy could be a better option. But I think if fertility is the option, rather than cauterizing any part of the niche, excising it and suturing it again to give a good scar would be, I think, a better option.
True.
Because by hysteroscopic resection, we are weakening the scar which is already weak.
Yes, yeah, that's right.
Yes. By resecting the lower edge of the cervix, we are weakening the scar which is already weak, and we are widening the passage.
No,
the
other problem is the other problem is you don't know where the bladder is, because by chance you perforate, you could be actually resecting a part of the bladder muscle there. Because with the previous cesarean section, the bladder could be pulled up, and while you are trying to resect the niche, you could actually be taking biopsies from the bladder rather than do it. So I think laparoscopically.
What Western literature is speaking about hysteroscopic resection and no rupture, because they do pre-op evaluation using MRI and they look for the residual myometrial thickness. I think what we are lacking here, means we won't get exact myometrial thickness, whether it is 6 millimeter or 4 millimeter. What the guideline says is if the myometrial thickness is less than 3 millimeter, will require laparoscopic repair. If the myometrial thickness is more than 6 millimeter, one can do hysteroscopy.
That's why
So one has to really look into the myometrial thickness.
But TVS shows these niche very clearly. A good TVS will show clearly, like you really don't have.
No, not niche, madam, not niche. The residual myometrial thickness above the niche, that is very important in deciding the management factor whether you can do hysteroscopy or laparoscopy. That is very important.
So this is another case. She is 26 years, history of induced abortion, 12 weeks.
I'm sorry to interrupt, Dr. Aarti. I think 45 minutes are over. So, I mean, if you can just wind up with this case, if it's going to take long, then just see what.
Yeah. So she had hyperechoic shadows on ultrasound. Okay. And she was complaining of scanty flow and pain in lower abdomen. So for these hyperechoic shadows, like what all we can suspect? Dr. Tinmoy, you can give your comments.
This hyperechoic shadow, could be just normal. And sometimes, any kind of infections and obviously, previous any surgeries and any foreign bodies, these are all giving this kind of hyperechoic shadows. Sometimes even a long polyp, or sometimes calcified fibroids can give this kind of things. But this doesn't look any of that. And in this kind of scenarios, I would do just an office hysteroscopy to find out what it is. It just takes 2 minutes.
May I intervene? May I intervene?
Yes.
On a very serious note, when Pranesha sir is sitting and when you have such a picture, always remember that there will be a case of, retained products of conception. I think I've had the privilege. I've had the privilege of seeing so many videos from sir.
Yeah. The other thing is bony metaplasia, because that is again very common.
Even Nitin Shah for that matter, osseous metaplasia or retained bones, skeletal parts. I mean, this is one of the newer indications. Of course, we've had a lot of indications.
Absolutely.
But the newer indications, probably in the last 1 or 2 years, this has come out in a very big way. Where
these are retained bony chips, and this video is very old. Maybe it is about 10 years old. Maybe
true, ma'am. But
yeah. So
I've always been watching sir and his videos.
Yeah. So this patient had bony chips in the cavity. That's why she was not able to conceive again, and her cycles were irregular, and that was the reason for those hyperechoic shadows in the cavity. So she is an ideal case for office hysteroscopy, I believe. So
Aarti, again in this case, doing a laparoscopy is equally important. So I think just removing the chips is not going to be the answer for a fertility. because I would like to add a diagnostic laparoscopy at the same time to be able to be sure whether the tubes are good. Even if the HSG is showing patent tubes, there will be some, if she's got bony chips for a long time, there would be some sort of tubal damage. So I think just removing the chips is not going to be the solution. You need to do a histolaparoscopy to give her a complete solution.
Very true. Absolutely.
Looking at this video, it looks like an osseous metaplasia because they are embedding into the basal layer. They are
That's
going
what.
right into the
That's
basal
what. So you need to assess the tubes as well.
Yes. And because we have to remove it right from the basal layer, this osseous metaplasia, and they become pregnant immediately within 3 months by spontaneous conception.
Absolutely. Yes. So an expert comment from sir only, Dr. Pranay sir, because he has given us, precious tips. Sir, sorry for making you wait for so long because the time.
No, that's fine. I mean, nobody can have an excuse that I was busy today because all of us are, at home all the time. So there's absolutely no problem. Yeah. So I think one thing which was missed out in this whole thing was the use of electrosurgery and the use of bipolar technology, which is really come up in a big way. Unfortunately, most of the foreign countries still are very expensive for bipolar, but I think we have a whole gamut of Indian companies which make a very good bipolar generator, and the hysteroscopy, be it office, ambulatory or regular hysteroscopy, with the use of bipolar technology is becoming very safe now. Your fluid overload, your glycine problems are almost getting wiped out because we are using novel saline for everything. So I think that's a big change which we are having the last couple of years.
Yes.
Just one point to add, madam. As a gynecologist, like hysteroscopy is another hand. Like by what we are using transvaginal scan as one of our hands, hysteroscopy should become one of our hands. I think we should make sure that it's actually more evident that all the gynecologists are trying to practice ambulatory gynecology, at least for diagnostic purpose.
I think that change can come in only if medical colleges start doing hysteroscopy. The unfortunate part is hysteroscopy is not done in the medical colleges. And the residents are, your concept of, being another hand, unless it comes from your first year residency, it is never going to change. So
I say my hysteroscope is my stethoscope. I say my hysteroscope is my stethoscope.
No, that was I had given to Dr. first. My hysteroscope.
Sir, there have been a lot of changes, sir. At least in the last 2 to 3 years, sir. I myself have gone to about 7 government medical colleges and taken hysteroscopic clinic on my side. Again, IAG has also been doing, Foxy has also been doing. I'm sure things will change for good, sir. I'm sure things will change for good, sir. As you've rightly said.
I'm sure they will, yes.
Yeah. So ideally, every gynecologist should try to do at least diagnostic hysteroscopy and minor procedures. But for doing any procedure, it has to be the right patient. The procedure has to be selected in a correct manner. The surgeon has to be the right person to do it and at the right place, be it in office or an OR. So we should all follow the guidelines and give good results with ambulatory hysteroscopy. Dr. Sujata, thank you so much. Thank you.
Oh, this was a wonderful panel discussion, an eye-opener to a lot of gynecologists. And I agree, you say your hysteroscope should be your stethoscope, but I had just told you we want to know, I felt it was not conveying see and treat, so that's why I told her change your title.
Thank you, madam, for this opportunity, and I request all of you to vote for me and Subhash in upcoming IIG elections. We are standing for managing committee. Need your blessings.
Thank you very much, sir. Thank you very much, sir. Thank you, everyone, and thank you very much, Aarti, madam, for this wonderful webinar, for the wonderful moderation, ma'am. Thank you very much. It was a pleasure to be. It's my first time with you, and I really look forward to a lot of webinars with you, ma'am. Thank you very much, ma'am.
Thank you. Thank you very much, Aarti madam and Sujata madam. It was fantastic panel discussion.
Thank you.
Thanks a lot for a wonderful
we really enjoyed it.
Ganesha, sir, as usual, you lots and lots to learn from you, sir. Because I've seen a couple of your videos of your retained products, and it's been wonderful. It's been wonderful, sir.
Thank you so much. Thanks.
Thank you, sir. Thank you, Dr. Sujata, Dr. Anshul, Rakhi.
Oh, pleasure to have you all. I think Dr. Anshul, now please go over to the vote of thanks. We've had a wonderful session.
Thank you, ma'am. So thank you, Dr. Aarti, for moderating a wonderful panel with your excellent panelists. with this last session, we came to the end of this 2 days webinar. And on behalf of all Noida Obs and Gynae Society members, I would like to thank each and every one of you who took part in this 2 days annual webinar of Noida Society. I would like to extend my thanks to our all eminent chairpersons, wonderful speakers, moderators, and panelists for their amazing and the valuable inputs. I would like to extend my special thanks to our esteemed seniors, Dr. Dr. Meera Agnihotri ma'am, Dr. Shanta Kumari ma'am, Dr. Pai sir, Dr. Chai Tang sir, and these are the really came and grace, their presence was really gracious. Thank you our all that own Noida Society members for supporting me to organize this webinar, and thank you our dynamic president for their constant guidance and all the effort to be taken till this. So now a very special thank to our Dr. Rakhi for this constant support throughout this journey of webinar over the odd situation of their family friend. Unfortunately, I have to say his father is in ICU on ventilator since last 2 weeks. And even after that, she has constantly supported each and every minute whenever I was required. And that is really grateful. I will never forget this, ma'am. And this is a big thing for you. And everybody can understand how much she is involved for the society and for the Foxy itself. So thank you so much, ma'am. And last but not least, if I will fail in my duty, I will not thank to this organizing pharmaceutical team, that is Pharmed Pharmaceuticals, for their all. Special thanks to Mr. Jayan for their constant support with the hard working, and they tried his best to just come out with all the technical problems and everything. Thank you so much. And I'm really looking forward for similar kind of webinar in future also. Thank you all. Thank you so
Yes,
much.
I think Dr. Jayanta and his team and Noida now have formed a team together. So he knows all our snags and where we don't know anything about technical aspects, and he knows how to tackle it. Thank you, Dr. Jayanta, from me too.
Thank you, ma'am. Thanks a lot. I will look forward to work together again in future. It's also learning experience. Thank you very much. So I close the meeting and I look forward to meet again. Thank you.
Thank you all participants. Thank you everyone.
Thank you very much, Sujata madam. Thank you very much, Rakhi madam. Thank you very much, Anshu madam. Aarti madam, thank you very much. Thanks a lot. Thanks a lot, ma'am. Thanks a lot.
Thank you,
I
ma'am.
would like to thank all my seniors and patrons of Noida Society, with whom we have learned and grown because of their leadership. We have come down till here. Dr. Madhu, Dr. Chitra, who were there right from the day one, starting of the first session till now. Thank you, one and all, everybody. The whole team Noida rocks. The executive team Noida rocks. Thank you, one and all.
And lastly, we should not forget whoever is present at right now should all pray for his speedy recovery.
Thank you.